roundtables. We'll have 2 sessions before we break for our health or tea, and then one more session after tea. Then we go for lunch. Then we come for the last panel discussion. And after that, we have a way forward from the team. We are still waiting for one more guest of honor, but we'll still proceed. On my right, there are very wonderful boards. Can you see them? In between the sessions, please don't write when the panel is going on. There are 7 questions that I'd like us to put our minds together. Your thoughts, they're very easy questions about the topic at hand, which is menopause. And so during health break, please feel free to walk around. We have marker pens. We also have sticky notes that you can just jot your words in. At the end of the day, I'll summarize some of the things that are popping out. And we see where we are at. I'd like to recognize 2 organizations that have put this event together. That's International Center for Research on Women. Let's see, anyone who represents ICRW, just lift your hand up. Thank you so much. Okay, and then we have Reproductive Health Network Kenya, RHNK. Please put your hand up if you're from RHNK. Very good. Asanteni sana. And then we will recognize the other organizations as time goes by. So are we ready? We have a hashtag turning. Are you putting up the hashtag, Sam? Yes. Thank you. But this is our tagline, turning the pause into applause. And we're going to do it in this way. Whenever you hear the word menopause from anyone, I'd like you to applause. But not applause in a conventional way. We'll do it the deaf way. I hope deaf is the correct word. It's hard of hearing. Hearing impaired, yeah? They just, how they share the clap. Is that okay? Whenever you hear the word menopause. Good. Oh, you're getting it, yeah? Sawa. So that's what you're going to do. As Sam is putting up the hashtag, I'll also want us to go to our phones. Just do a quick poll to see who's in the room instead of doing introductions. Go to www.menti.com. The Wi-Fi in the room is open. So www.menti.com. Sam, if you can put it up for me, please. Are we there? Yeah. So the code you're going to put is 2859. Please press on present. 2859 7041. 2859 7041. Are we there? Okay, so let's see. What's your mood today? Today I woke up in a bad mood because Kenya Power did for me that thing. And so, but it's being sorted. But it was not a very pleasant thing when you have a big day and you don't have power in the house. So I am happier now. If you asked me 2 hours ago, I wouldn't be describing myself. So there's someone who says they're curious. Go on, just one word. Hopeful, excited, amazing, nervous. Okay. Audacity, inspired, intrigued, cold. Oh, someone is cold. Let's check the temperature in the room. Or it is perimenopause. Sluggish, fear, eager, inspired. Oh, indifferent. Oh, I hope you're going to change that person's mind by the end of the day. Exhausted. Whoa. Did someone have a night shift? Okay, so we got to the second one. The second slide, Sam. I'd like to know which sector you represent for the purpose of this meeting. I know many of us wear very many hats, so just for the purpose of this meeting, let me know if you're in academia, if you're representing the non-profits, government, media, donors, private sector, other. Okay, so most of us are from the non-profit, and we have other also coming up pretty well. So we have 30 responses out of 44. I think we still have more to go. Okay, so we have a fairly interesting combination there. It's interesting that government is only one. Evelyn? Okay, good. So, and academia are 3, and I think most of them are on this table. Good. Let's go to the next question. How much do you know about this topic? This topic is menopause, just in case. How much do you know? I'm an expert, a lot, a little, I've heard of it, absolutely nothing. That's interesting. I hope this is the time to flip this at the end of the day, that the 9% will be converted to at least the a lot or a little. Okay, next question. In one word, when you hear about the word menopause, what comes to your mind in one word? Scared, sweating, growth. I like that. Old, chaos, end but starting, disruption, no giving birth. I hope that's a positive thing. Or is it a negative? Hot, 45, fat, neglected. Wow. Hot flashes, menstruation stop. Yeah, that's it sounded like it's a very positive thing for that person. Low libido. Prof, you've had that. Look away. And Professor, we have to sort our ladies. Challenges, stress, transition, not ready. Yeah, those buzzwords are very important for my panelists as you're talking. Let's see how to address that. Okay, so I totally forgot that we have an online team. We are streaming this webinar live on YouTube, but also on Zoom webinar. So the AV team, if you're able to check on why they're not able to hear me, kindly before our main speakers get on stage, if you can have it sorted. But we do have, the participants online can also participate in the Mentimeter. So feel free to log into www.menti.com and put in the number that's right there on the screen. Change of season. No kids. Okay? Sam, we are not done yet. The last one. And finally, before we will come to the second last one towards the end of the day, what is one change that you'd personally like to see after today's conversation? Just one thing, just to gauge your expectations. What would you like to see changing once we are done with the day? Policy, stigma and misconception forever deleted, debunking the myths around menopause, research gaps highlighted, men participating in the conversation. Can we applaud the men in the room? Very good. So we have a step forward. There's a lot of stigma breaking, myth breaking that's coming up. More visibility. Sam, you can scroll up on the laptop. Empowerment, awareness, ground policy, elevating andropause. Wow, okay. Prioritizing menopause, more people talking to men, young men and women. Great, so we'll stop there as we collect your information. Again, if you've just come in, I hope you're in the right room. And I don't know why everyone is leaning on this side. So my ashes, the next team of people to come, let them also sit on this side. So my name is Amakove Wala, and I'd like to welcome you formally to this event. Without further ado, Sam, please put up the hashtag. Okay, is our AV okay now? If someone can just confirm with me. Because I'd like to invite Evelyn Opondo, you have to get that title, Doctor. The Executive Director of International Center for Research on Women, who are our hosts, co-hosts today. Karibu sana, Evelyn.
Distinguished guests, esteemed speakers, partners, colleagues, ladies and gentlemen, good morning. I'm happy to report that I have seen another top government official, Dr. Josephine Obonyo, who has just arrived from the Gender Ministry. Welcome, everybody. It's really a pleasure to welcome you to this convening, this very important convening that the ICW, together with Reproductive Health Network and other partners, are convening for this very critical conversation on menopause. I want to start by just saying that some conversations change policy. Other conversations change culture. But the most powerful ones, like the one that we're about to have the power to change lives. Imagine a world where women's health is not tethered to their fertility, but is instead celebrated at every stage of her life. Menopause is not a quiet footnote. It is a defining passage that demands visibility, understanding, and dignity, because we know that the cost of not speaking and the cost of inaction is diminished life quality for women. I know this not as an abstract truth, but because I have had my own experience in doctors' clinics, chasing tests and treatments and trying to name a change in my body that no one taught me the language for. Today, I, together with other women in this room, we stand here to give that silence a voice. Menopause does not follow a tidy checklist. No two women experience the same symptoms in the same exact way. But menopause is not just a women's issue. As we will see today, menopause is a family issue, it's a workplace issue, it's an economy issue, it is a dignity issue, and it's everybody's business. My friends and I joke a lot that, menopause is that time in your life when you lose hair on your head and it suddenly reappears in all the other places that you don't want it, like your chin. It's because we haven't created a culture for women that can describe what is happening to our bodies without shame or without guesswork. You can imagine that even women like myself who work in the reproductive rights space have difficulty describing what menopause is and how it impacts our bodies. Earlier this year, the ICW had a sexual reproductive health and rights dialogue, evidence dialogue. And at that meeting, Dr. Josephine Kibaru, who is seated here with us today, shared a story that felt like a mirror held up to our health systems. She spoke about women in a malaria-prone area who are going into health facilities with heat surges and fevers. And they were told, suspecting that they had malaria. They were tested for malaria. Malaria was negative, but they were told that, you know what, it's just not showing, but it's malaria. And so they were put on malaria treatment. And when the symptoms did not subside, they came back and they changed malaria tablets, and they kept changing that over and over. It's treatment after treatment, but not the right conversation, not the right diagnosis, not the right care. That was not the failure of these women. It was a failure of our systems to recognize menopause because we have not trained for it, we have not measured it, we have not valued it. And when the systems turn away, the stories that we tell fill the gaps. And far too often, they are stories that reduce women to stereotypes. I was just thinking yesterday that perhaps we have been too quick to sketch the difficult mother-in-law in broad and unflattering terms. But what if beneath that outline lies a body that's negotiating silent battles that spills into the way she meets the world? What if? Today, we will hear voices from women in how menopause impacts not just their health, but their relationships, their mental health, their workplace, their sexual health, and many more. This is bigger than biology. It is design. For decades, our research, our policy, our advocacy, our programs have privileged fertility and childbearing. We've celebrated the mother, but somehow we have misplaced the woman that she becomes after she gives birth. That selective focus reinforces a damaging message that a woman's worth is tethered to her reproductive capacity. If our health systems, workplaces, schools, communities are not built to support menopause, we are building on sand. Let me offer 3 commitments that we can make together because clarity compels action. 1, let's listen. Listen by centering the lived experiences of women in their diversity. 2, let's learn. Learn by equipping healthcare providers with the information and the tools that they need to provide comprehensive healthcare at every stage of life. And 3, let's lead by integrating menopause in policies, in programs, and pilot and scale workplace policies that work for women at all stages of their life. In conclusion, ladies and gentlemen, silence is a policy choice. Courage is also a policy choice, Dr. Sede. So I stand here hopeful because rooms like this have changed norms. And it is my hope that this conversation is the beginning of that norm. Thank you very much.
Thank you very much. Another round of applause for Evelyn. Listen, learn, and lead. Thank you for those nuggets of wisdom. Next on the stage is Nelly Munyasia, who is the Executive Director of Reproductive Health Network Kenya. Her bio will also be projected. Many of these people are heavyweights, actually all of them. So we will be just projecting a summary of their bio. But Reproductive Health Network Kenya, karibu sana Nelly.
All protocols observed. Good morning, ladies and gentlemen. Um, Today, when I was thinking about menopause, I was wondering, what am I really coming to say? Is it out of rumor, out of the myths and misconception, or what I learned in nursing school? And then when I was thinking about my nursing school, my training, there was nothing I was told about menopause. And when I think about the work that we do at Reproductive Health Network Kenya, our focus mostly has been on adolescent and youth. And so I've been thinking, so what? After we are done with the youth, so what? No one prepares the youth for the next phase. And so, and thanks, Evelyn, for giving that very clear background on what happens in our community. And I come from a community where I don't think I ever had any conversation going on about menopause. And maybe we had our dad saying, mamako amezeeka. And mamangu amezeeka aje, and she was only 35, 36. And we had, we had the community saying, now that one, amebaki tuku, she's only remained, or, she only has few years, and she has arthritis. And those are old age things, And when I was reflecting about this, and when we were sitting with ICRW thinking about this conference, I was really challenged. And I was challenged because as a woman who probably is headed to premenopause or menopause, I'm thinking, so my hay years are ending clearly, and I'll also start being written off. And the conversation will be, your mom has been running around a lot, doing a lot of work, and now she's tired. And could that be the beginning of a clandestine somewhere, a girlfriend somewhere, because then I have hot flashes? Maybe I'm just not ready to have sex. And who prepares me? Who has even talked to me? And I almost called my guy, and I'll not mention his name, because when I got my last born, he never had a conversation with me on now what do I expect next, because I was very clear that I'm done with having babies. And I also thought about, again, my training school as a nurse. And I work with mid-level providers that are today seated in this room. Most of them are midwives. And I was thinking, what is our role as midwives as we talk about menopause? Where have we failed our women? When they come to us, do we brush them off and just say, umefika menopause, sasa anza kudeal. Like you're at menopause, so start dealing. Start preparing yourself, maybe to go back to the village or just walk around with the fan. And interestingly, today we decided to give us the fan. Evelyn, you'll tell me why you gave me a fan, because I'm not having hot flashes yet. And for me, and that's why I'm just having a conversation around this, even as we talk about this. And we brought in our young people that we work with, our adolescent and youth, because we failed them. Why have we failed them? We have not prepared them for the next phase. Just the same way I've not been prepared. And I'm here to learn. I'm glad that I'm sitting on a table of experts, but also as a midwife who is reminded that, what then is my role? What are our providers supposed to be doing at this point in time? And where we have a lot of issues that come with aging, climate change, but also SRH changing as quite fast with the food that we are eating. No one ever told us that, where I come from, actually, when you give birth, then you grow fat. Professor Tuole, am I lying? Then your man is taking good care of you, right? And you'll go home and they'll say, hey, kijana anafanya kazi mzuri. But no one tells you that when you get to 40, shedding off that weight is going to be problematic. And you'll have backaches that don't end. You'll have migraines. You're forever in the chemist. You almost have 1,000,001 painkillers. And you will be paying for spa, and it's not about that. It's the weight. And then now, those are the things that the experts will tell us today, start checking in. And so, as an institution that is working with providers who are mainly in the communities, and where most of these women will not have the privilege of someone breaking the taboo and telling them that, you know what, this is a normal change. This is the period as a woman you're supposed to enjoy sex. This is a period as a woman you need to be more active, extremely active, and enjoy the years that are waiting for you. And so we are reminded that we need a policy, and that's why I'm seated next to Dr. Serem, so that I'll be hitting him all the time. He's given me enough policies for adolescent and youth, but so what? After they are done with the adolescent and the youth issues. And we know there have been a lot of issues around that. But so what? So we want to make sure by the time we are living here today, we have commitments that we are going to have guidelines to sensitize our healthcare providers so that they know that clearly when a woman comes to you during delivery, when a woman tells you as a healthcare provider that this is my last baby, do we already want to start having those conversations and preparing them for the next phase? When they're having their first baby, depending with the age they come to have the babies, are we ready to have those conversations? How do we integrate menopause with the existing programs? Because again, when we make it an isolation and an issue that we think we need to whisper about, then it becomes problematic. So I'm glad that ICRW and RHNK with other partners, we've taken the bold step to move from the chama meetings where these conversations happen, you know, where women are closed and they're like, hey, you know, I can't rise to the occasion. I'm forever dry. What's happening? Oh, I think go and see Dr. XY to give you some hormones. But what are those hormones for? Why wasn't I prepared early? And where we need to tell women that we also need to exercise. We need to hike. Just because I'm 50, it doesn't mean that my life has stopped. And so I would love to see guidelines for healthcare providers, training them, sensitizing them, especially the midwives who spend a lot of times with women right from when they start to give birth to the second baby, to when they stop, to the contraceptives, and to the changes that come. And especially the midwives that are in the communities where we have a neglected population that is dealing with the challenges that come with menopause. Then how do we continuously just make the menopause conversation normal in the dialogues that we have in the community, in the conferences that we have? How do we normalize these conversations? I want from this meeting to see us getting into radio media, radio stations, writing op-eds around menopause and how women need to navigate that. And also support women so that when we're thinking about their lifestyles, how are we supporting them? How are we working with nutritionists to give them comprehensive, diet so that as they navigate this process, then it becomes a normal process. It's not something that, considered to be a taboo, something that is supposed to be whispered, or something that is normalized that, a woman has come of age and it's her time for her to just sit and rest. So thank you so much for honoring our invite, and we'll be inviting all of you to be part of, the process that will engage policymakers in developing guidelines, but also policies that will ensure that menopause becomes a conversation that is normalized in this country. Thank you so much.
Thank you so much. Another round of applause. Is it all that bad in menopause? How many are going through perimenopause or menopause? Is it all bad? My libido is very high. Okay, it's always been high. I guess it's higher. So Nelly, don't fear. We are going to hear. Sorry? Post. Oh, there are those who are even in post-menopause. So Nelly, don't fear. It's not that bad. And I think that's why we are having the conversation, isn't it? But we've had you loud and clear. We've had your requests for policy and guidelines, and also information being shared, not just at the time of ending the child delivery season, but way before. And I think we'll have that captured very adequately. So we go to our next speaker, whose bio is very, very heavy. But she's the Honorable Lady Justice Njoki Ndungu. You'd want to know why a Lady Justice is doing in this room, isn't it? We're very honored to have you on board. And if you're able to come. So she's going to speak about intersection between justice, rights, and menopause. Did you know menopause is a rights issue? Okay, karibu sana.
Good morning, everyone. It's a real pleasure to be here with you today. And before I talk about the issue of rights, I think it's important that we share experiences. And for me, I am definitely there. And it's interesting because, as we said, every woman has a different experience. Our bodies are different, just the same way when we menstruate, we have different symptoms, we have different challenges. So mine began in a very interesting manner. I had started having challenges both at home and at work, especially with this symptom called brain fog. And it got to the stage where I was feeling utter panic. I was convinced that I either had the onset of Alzheimer's or early dementia. And I went to see a doctor. Actually, I actually went out to actually check what was wrong with me. I had a battery of tests, MRI, CAT scans. I had a physiometric test. I had blood tests. And finally, a team of 3 doctors, a neurologist, and a psychiatrist, and another doctor, all looking at my brain and behavior, said, it is menopause. There is nothing wrong with your brain. You do not have Alzheimer's. You do not have dementia. You are simply going through what many women go through, and it is called menopause. However, as brain doctors, we don't deal with that, so you need to go and see a doctor about your menopause. So I came back to Kenya, relieved that I'm not about to die, and in search of a medical practitioner who specializes in menopause. Now, in Kenya, that is a difficult find. You find most gynecologists are focusing on childbirth, that area of reproductive health, but the reproductive health for more senior citizens like ourselves is far and in between. Also, in Africa, we don't seem to be benefiting from the advances of medical protocols or the medicine that can help us. When we talk about HRT, we are still talking about the old, I don't know how to put it in medical terms, but anyway, I discovered a new form, which is a gel, which you just dab on your hand and you go for the day. There's no swallowing, there's no... So what has happened, there are advances out there which would make life easier for women, but in Africa, one, we do not seem to have access to those developments, advanced developments, and 2, how expensive is it? So, as we engage our policymakers, and I was just telling Dr. Serem that I'm very glad to see him here, we have to be able to engage them on the issue of cost as well. It's in the same vein that we did engage policymakers when we were talking about the cost of sanitary towels, and Kenya was the first country to zero rate sanitary towels so that they could be affordable for women and girls who menstruate. I think that we have gone back, we've rolled back a little bit on that. Now there is a bit of taxation on sanitary towels, but that is the engagement we need to have also around menopause. How do we make sure that the women, both in urban and rural areas, have access to medicines or to treatments that can alleviate their symptoms without it being so costly? So Dr. Serem, we are looking to you and your team, and let us know how we can help you in terms of lobbying on this issue. I also found I had another challenge because I'm an older mom. So I had my children very late in life. And so I am undergoing menopause when I have teenagers. And I am telling you, it creates an environment which is undescribable. So I started doing a lot of reading, and I have 2 books which I bought. I've got several books I have, but there are 2 that have helped me. One is called, where did I put this? It's called Menopause versus Puberty. It's by an author called Tomalisa Lampkin. And it just tells you how you're going to deal as a mother with menopause, with children who are of the age of puberty. And it has really helped because I think my children used to think I was a total terrorist. But now, having recognized that my children are undergoing hormonal changes, I'm undergoing hormonal changes, and this book has helped me with that transition. I think perhaps we are not completely in the completely in the democratic space in my home, but it has helped. So also information for women is something that is there. And I was just listening to the previous speaker talking about how we talk about our mothers-in-laws and even mothers. And I remember distinctly, the first time I used the word terrorist was describing my mother. But now when I think about it, surely she must have been undergoing menopause, and this is. But the society then didn't understand, didn't want to know. And again, as we have this conversation, we have to, and I'm so glad that there are so many men in this room, because we have to bring our male partners on board. When I was in Parliament dealing with sanitary towels, the difficulty was initially how men did not want to be involved in what they call a women's issue. Yet, it was an issue that impacted men differently, but the campaign around the sanitary towels showed us how we need to engage with men. Yesterday, when I was leaving the judges' colloquium, because that's where I came from, in Mombasa, and my colleagues in the Supreme Court were inquiring, why would you leave the judges' colloquium? What meeting is this you're going for? So I said, I'm going to a meeting on menopause. And the 3, my male colleagues looked at me and said, a conference? He says, why do you women have to discuss these things in a conference? And those women's things. And I said, no. Your wives will have menopause. Your daughters will have menopause. Your mothers will have menopause. And therefore, in fact, I'm going to represent you at this conference. But we need to engage them because I normally say, and I've always said this, men and women, we are equal, but we are different. It's very hard for men to understand what is going on in our bodies. And you know the way the symptoms bring themselves. Brain fog, sweating, we are unable to sleep at night, so in the morning when we go to work, we are sleepy. And everyone who doesn't understand thinks we are lazy, we are bad-tempered, we are unreasonable. But I think if this information and education is out there, I think it will be easier to deal with. Anyway, let me now come back. I talked about, I said that there are 2 books I'd like to recommend. For older moms, The Menopause versus Puberty. And then there is another one which I've read which has been helpful called Making Friends with Menopause by Sarah Rayner. Because you have to make a friend with this thing. It invades your body, you have to accept it, and then you have to say, let's live together with it. Obviously, in Africa, it is important that we start looking at the legal and constitutional frameworks to deal with menopause. And we must do so because menopause is a reproductive health issue. And I'm happy to say that in terms of a constitutional framework, Kenya would be one of the countries leading in Africa in terms of the provisions that we find within the Constitution. For example, in Kenya, we have a very clear provision in Article 27 on the right to equality and the rights to equal opportunity, and the rights not to be discriminated against on the basis of sex, on the basis of gender, on the basis of health status. This is something that applies to public institutions and private institutions, so that even under employment, a company ought to have a policy to ensure that those employees that are undergoing menopause are not discriminated against. We also have in our Constitution, under Article 28, the right to human dignity, the right to be treated as a human, for your dignity to be respected. Under Article 41, we have a whole section on labor practices and how we have the right to work and that working conditions should be reasonable. And reasonability ought to be tested against what are the symptoms of menopause and how should you contribute. Should, for example, we be talking about flexi hours, the same that nursing mothers get, should that be applied to also women who have menopause? These are the conversations we need to have. Of course, Article 43 speaks directly to the right to health, including reproductive health. Our Constitution goes further to provide for the protection of persons with disabilities. Sometimes, not all, menopause can result in a debilitating disability. And therefore, those whose symptoms are that bad can claim their rights as persons with disabilities. And finally, not finally, we also have Article 57, which protects older members of society, to assure that older members of society can integrate into society and they can access the same rights as those who are not older. Again, menopause is largely related to women who are older. This is a right that we can claim under the Constitution. Finally, we have under our Constitution, under Article 35, the right to information, and under Article 43, the right to education. Both these rights should be claimed. The stigma that women undergo, that they cannot talk about it. They cannot talk about menopause. You see, the shock when people realize we're having a conference to talk about menopause is all about the stigma around it. Why should we talk about it? Why are we talking about it publicly? And women themselves, therefore, are suffering, but because of the stigma, they are not coming out to seek help, to get medical attention, or even to claim their rights at work. Therefore, the rights as provided under the Kenyan Constitution, but in Africa, those rights are clearly stipulated in international conventions and treaties. Those rights are ours, and those rights can be claimed. However, there is need for the translation of those rights into implementation. And this is where we must engage governments to ensure health policies, educational policies, information policies are engaged so as to include menopause as a subject matter. We need to be able to engage our parliamentarians and to see whether it is possible to engage in legal reform under the employment law regime. But I also think we actually need to move to claim. A lot of people always ask, why don't you judges make pronouncements on the rights? But as judges, we can only make those pronouncements if you come to the courts and move us with a claim, and then we can make the declaration. And I think perhaps it is time for those who are involved in public interest litigation, and there are those I recognize in this room, to work around the issue of menopause and let us have it declared firmly as a right that is owned, firmly so that employers do not discriminate against women who are undergoing menopause. And as Africa is having this conversation, I would be glad, Dr. Serem, I would be glad if Kenya would lead. Thank you very much.
Wow, thank you so much, Honorable Justice. I hope your mom changed from a terrorist to. But thank you. I think you've epitomized quite a number of our different journeys and the challenges that we face. And it's very important to know that this is a rights issue, and you have heard of all the sections that she has mentioned. So Asante Sana. We'll move to our chief guest, Dr. Edward Serem, who is the head of the Division of Reproductive, Maternal, Newborn, Child, Adolescent Health. You have all these women waiting for you. You have children, you have adolescents. But Dr. Edward Serem is a long-standing staff at Ministry of Health, quite conversant with policies, and I think the policy angle has really popped up, and there's a challenge that Honorable Lady Justice threw at you. Karibu sana, Daktari.
Thank you very much, moderator of this hour. Honorable Lady Justice Njogi, Judge of the Supreme Court of Kenya, Opondo from ICRH, African Director, Nelly from RH&K, Executive Director, my colleague, Professor Atwoli, who is a psychiatrist and a lecturer. All protocols observed. Good morning. I'm pleased to join you this morning on this discussion on menopause. When a request was posted by our colleagues who were in this meeting, of course, it actually raised some spanners as to what is it. It is true that menopause had been neglected, and we have never, as a country, had discussions. Menopause is not just a woman's issue. It's a public health imperative. It's an economic issue. It's a human right issue. Globally, the average age for menopause ranges between 45 to 55 years. In Kenya, one in every 4 women will spend more than 40% of their lifespan after menopause, which is almost half of a woman's life. Yet, our health systems treat this phase as it doesn't exist. Unmatched menopausal symptoms may contribute directly to osteoporosis, cardiovascular diseases, diabetes, depression, genitourinary symptoms, and many more. Our researchers and academic institutions need to incorporate menopause into curriculum and conduct studies on menopause that will inform policy. The National Social Health Authority has not addressed or covered menopausal issues. Policy document. We have the reproductive health policy. In reproductive health supports menopause, though the implementation of the policy is a challenge. Community sensitization on women's preparation and awareness of menopause framework structures is supposed to be in place to prepare women transition to menopausal stages. Healthcare professionals in health facilities are not well prepared to handle menopause. I remember when I was, when I used to practice as a gynecologist, having gone through the hands of Dr. Han Kiara, I still had challenges in managing menopause. Because one is that you can accurately diagnose menopause, but the medication was that complex, and more so, not available. So I think this is now, this meeting, in my view, forms like an inaugural discussion for menopausal sensitization and policy guidelines to be in place. On the same note, Judge Njoki has also mentioned the affordability. I think all these things, therefore, will have to be packaged so that we talk about affordability, availability, and management of menopausal symptoms countrywide. So with this, we are therefore, our office, we are going to make sure that we facilitate this discussion moving forward in terms of coming up with the policies and any other issue which needs to be done. Our office is going to be instrumental on this because it's clearly one of the components of our deliverables in reproductive health, not to mention others like reproductive cancers, infertility, and many others. I want to, from here, I'm going to constitute a committee to be in a position to drive this agenda forward so that in the next few months, we are somewhere and we have policy guidelines to guide the country and more so the counties. As we are doing this, of course, we are doing with very many other things. You know very well that right now we have been doing a lot of sensitization on awareness. Every woman, every newborn, everywhere, acceleration plan to make sure that we accelerate reduction of maternal newborn deaths in the country to be in tandem with the world and be in a position to achieve our 2030, Vision 2030 global, Kenyan targets. We have our Kenyan targets, and we are really working on that. You are going to hear more about that. Still part of improving the health of women. At the same time, Kenya is privileged to host the International Maternal Newborn Health Conference here in Kenya. It will happen in March next year. And we would like, therefore, to call for your support to participate, get abstracts ready. It's almost time to call for the abstracts so that you can present presentations which are there. It will be held here in KICC, and yes, I'm part of the committee members, and we are going to constitute national committee members to be in a position to plan for that event. So with those, I don't want to say many more again. We are ready to facilitate all this, and I'm happy whenever you are called upon, you are ready to come in, facilitate, support technically, and in all other resources. Asanteni sana, have a fruitful discussion.
Thank you so much, Daktari, for that commitment. And before we allow you to sit, I'd like to take your commitment very seriously. Dr. Serem, Honorable Lady Justice, Evelyn, and Nelly, please come and put your words into action by signing our commitment form. But we do appreciate Dr. Please come, Dr. Edward Serem. So you all heard him say what? He is committed. Which color do you like? Okay, blue. Yes. Ella? Okay. Try a black. And your signature, Daktari. That could be anyone. Wow. Thank you so much. For the rest of us, feel free to write a note or just sign. That's, no, right. Yeah, continue. Okay. Yes, please. And each of us will have an opportunity. We have more sign-up forms over there. Wonderful. We'll write your names next to your signatures because honestly, the signature bit mean. Good. Great. So as Nelly is winding up, please, the four of you, if you can just come for a group photo, and then we conclude that session. So let's applaud them for giving us that commitment. No, on stage. Yeah, thank you. Thank you so much. And Dr. Serem, I believe we have your blessings to continue with the rest of the program. Asante. Let's give them a round of applause. Nice. Asante sana. And Asante. So he has given us the blessing to proceed, so we'll go straight to the next session. Okay. So we have Professor Osur. How many of you have ever heard of a sexologist? Like every day of his life, he's discussing about sex. Some of you say I talk a lot about sex. Now, Professor Osur is a sexologist, but he's also the Vice Chancellor of Amref International University. Karibu on stage. We have my dear friend. I am summarizing all these bios. Yeah. Angela Nguku is the Executive Director of White Ribbon Alliance Kenya. We have Professor Lukoye Atwoli, the one who fixes our brains, our minds, but is currently the Dean of Aga Khan University Medical College. And last but not least, we have Professor Anne Kihara. For those who don't know, Anne Kihara is the first African female president of all the gynecologists in the world. So we have Figo here. Good. So I'll allow Prof. Osur to start. Just give us a bit of what you want us to hear.
Should I stand or should I sit?
What are you comfortable? Okay. Yeah, please use the mic.
Thank you very much, ladies and gentlemen, and all protocols observed. And thank you, Dr. Wala, for allowing me to speak first, because I have an emergency that I need to sort and then come back after. allow me to read what I want to say, because if I start talking, I might overshoot the time I was given. I was asked a few questions to attend to. One, how can menopause narratives help drive policy and system change regarding menopause? Secondly, what are the most striking or surprising patterns you've observed in these stories? How can we, number three, ensure these narratives are collected ethically and used responsibly? So I decided I'm just going to tell you stories and tell you how we can use these stories to change policy and services and programs on menopause. Those who know me, yes, I'm a vice chancellor, but I spend a lot of my time talking about sex. I have reduced my practice after I got my fellowship in sexual medicine to seeing patients with sexual problems. And I think I'm unfortunately the only doctor focusing on that currently, and I'm hoping my colleagues will join me to talk more about sex. So let me just read my stories and then conclude. And I want to give a disclaimer that these are real life experiences, but I've changed a lot of things in them. So data security, there will be no person you can identify using these stories. And so if you come to me to sort a sex issue, we will sort it. I will not talk about it. Yeah, you can be sure of that. But the stories are real life, but I've changed a lot so that nobody can actually be identified using these. I have two stories. The first one, 2 weeks ago, I was in a housewarming party for a friend who lives in the US. They sent money, had the house built, and traveled as a whole family to come and celebrate their Kenyan new home. The interesting thing, however, is how I got to meet this friend. It was through a phone call from the US pleading with me to save Mr. John's family. John and Jane are parents of this good friend. John, now 72 years old, came to me for treatment because of erectile dysfunction. He has been off sex for 2 years due to this problem. He had read my column in the Daily Nation and decided to reach out. When I saw John is obese, hypertensive, and diabetic, and this is what caused his erection failure. After initial assessment and preliminary treatment, John's erections started coming back, albeit in a weak way. John started making advances to his 60-year-old wife, and that was the beginning of their problems. Jane called their daughter in the US, now my friend who invited me for the house party, and asked her to talk to me to stop treating the erection problem immediately. And her reasons, she gave two reasons. One, she did not want sex anymore. And secondly, her refusal had resulted in a serious conflict, including the man threatening to marry another wife. I asked to see the couple together, that is John and Jane. But when they came to the clinic, Jane requested that John stays out and she talks to me first. She said that when she hit menopause years, the man started having affairs. She tolerated this because she had lost desire for sex, and she felt that she had no moral authority to question the man's actions because she felt she was to blame for not being sexual. She would, however, still occasionally tolerate sex with John for the sake of peace, even though she did not enjoy it. She feared that John would bring disease home. She also feared that the women he was having affairs with would at some point take advantage of him, get children, and claim family property. She therefore felt relief when John's erections failed. She was firm on her request to me. And she told me, if you stand for the welfare of families, you must stop treating John to have erections. So John, on the other hand, had one question for me. What is there to live for after years of hard work if one cannot have sex? How do you enjoy your retirement if you cannot have sex? She accused Jane of being unreasonable and rejecting him, knowing very well that at his age and with erection problems, it was impossible to win and impress a woman in a new relationship. So we had a conflict here. I suggested to Jane that we could get back her sex desire by treating the menopause, resolving the outstanding, social problems, and doing sex coaching to reignite intimacy between them. She simply said no. And I quote her, "There are stages in life. That stage of reigniting intimacy already passed. I do not want to have sex. My age mates do not do such things. Culturally, my husband should be in a different bedroom or his own house at this age." I gave the man homework because I had to find a solution. I told him to go and use his love skills and win back his wife, after which we would re-embark on treating both of them: menopause and erectile dysfunction. Now, remember, so the next time I met them is during the housewarming party for their American, children. And I asked him, "How is it going?" John told me, "I'm slowly wooing her. She's slowly yielding. Progress is slow, but consistent. Very soon, we will be back to you to resume treatment." So I also had a chance to ask Jane, "How is it going?" She said, "He's trying very hard. He's trying to be nice. I am beginning to have mercy on him." And she said, "Let me think of what to do." And then she thanked me for making sure her family did not break by not treating the erectile dysfunction. That is my first case. The second case, which will be faster because of time, Mary, this time, brought her husband to the clinic because she felt there was a big problem in the relationship. She feared that the man had lost interest in her, and as a result, he was avoiding sex. Whenever he attempted to have sex with her, it was unsatisfactory. Sometimes he took long to get an erection, he ejaculated prematurely, and he seemed not to concentrate in the act. He was mean, this is Mary saying, not talking nicely to her anymore, not spending time with her, acting as if he was ashamed of her. The man was 63 years old, Mary was 56. Their children had left home, and they spent a lot of time together fighting. A full medical exam showed a healthy man with no hormone problems. Mary, on the other hand, was in menopause. The man's story was that he was under siege. Mary is no longer the woman he married. And he said this: she lacked sleep at night and felt annoyed that he was sleeping and snoring. She woke him up many times, which was irritating. His suggestion to move to a different bedroom annoyed her, making her say that he no longer loved her. Chronic lack of sleep made Mary tired. She always lacked energy. She had chronic headaches. She blamed the man of doing nothing about it. Her moods changed erratically. She could suddenly get annoyed, shout, and throw things at him. Sometimes in the night, she threw the blanket away claiming it was too hot. She did not want her husband to pull the blanket back. She abandoned the hobbies they used to do together, such as going dancing, because she was always tired and sick. She felt annoyed when her husband watched football instead of paying attention to her. She switched off the TV and ordered him to go to bed. She did not feel like having sex and blamed it on the husband. She said he was not trying hard enough to woo him. He was not romancing her enough to feel sexual. She wondered if he had an affair. This made her monitor his movements, check his phones, and try to be around him all the time. And this is what this gentleman meant by he was under siege. So my diagnosis was that menopause was disrupting the couple's relationship, and they needed information on menopause. They needed to be conscious of the effects of menopause. They needed to undergo relationship counseling to reconstruct, the good relationship they used to have. They needed to manage their lifestyle, diet, and so on to reduce these symptoms of menopause. They needed hobbies that could re-energize them and bring them together. And they needed to consider hormone replacement. The couple accepted everything except Mary refused hormone replacement. So, as I come to the end, we can learn a lot of lessons, and I have many of those stories. Because it appears sex is the easier way to intersect with the health system when menopause starts. My first lesson is that menopause, lived experience stories, describe a desperate and neglected problem which affects many members of our society. And it is important to document these stories ethically, and I will continue doing that. Some of the lessons that we learn from these stories, one is that menopause is not just a woman's problem. In fact, it appears the men might even be in a worse situation in their relationships with a woman who is in menopause or undergoing menopausal problems. I think even the children, from what we've heard, are similarly part of the problem when they think their mothers are terrorists. So menopause compromises the quality of life in all aspects, both physically, psychologically, and even socially. The right to satisfying sexual experience seems to be a big part of this, and not many people attend to it. Culture tells us that maybe at menopause you should stop having sex. Science tells us otherwise. Actually, the oldest woman recorded an orgasm was 114 years. So it is too early to stop having sex at menopause. Care for menopause is unmet in the health system. I don't want to belabor this point. I think Dr. Serem has already talked about it. But we really need the right to information for everyone involved, not just women, even men. They should be able to know why the woman is going through what she's going through, even the children. And training of health workers to be able to provide this service currently is a problem. A funded national program on menopause is important because you can't do anything without money. What I see mostly in the clinic is that whenever people come with these problems, even the insurances don't pay. They say this is not a disease, not covered, we won't pay. And this goes with a lot of other sex-related problems. And we need to provide commodities for this issue, the HRT at the lowest level. You know that 80% of our people go to the primary healthcare level. This is sub-county downwards. Those places, if you say HRT, people will ask you, what is that? Even the health workers don't know what HRT is about. We need these things at the lowest level. And finally, routine data collection to help us make a decision of what, every population is unique. Africans have unique experience with menopause. We need to document that. We need to have it in our national database to help us make decisions. As I've finished, let me make 3 requests as I sit. There is a drug called flibanserin. When men lack erections, now we have multiple drugs to give them, and they are able to have erections and have sex. When women are having pain because they are dry, they are lacking desire for sex, we have nothing to give. Right now, there is one drug which has been developed. It is called flibanserin. It's available in the US. It is not available in Kenya. I want to request that as we work on these policies and the drugs and all that Dr. Serem ensures that flibanserin is in the essentials drugs list. Women, do you want flibanserin? Yes. Thank you very much. Secondly, the hormone replacement therapy myths need to go, and we need to use these ethically to solve a problem that we are seeing. I think it is an injustice when we know the treatment and we allow women to suffer these things, families to suffer these things, men, children to suffer these things. I think that is what we call injustice. So again, I want to request as we work on policies that hormone replacement therapy is included in the essentials drugs list. Yeah? That will ensure that it is available at the lowest level possible. And finally, ladies and gentlemen, as I sit, Dr. Serem, I want to attack you. He was my classmate. We are good friends. But his title is Reproductive, Maternal, Child, Adolescent Health. Where is the sex in that? Can we, in this meeting, declare that we will add S to Dr. Serem's title?
Yes.
Thank you.
Thank you so much, Professor. And feel free to leave and rejoin when you come back. But thank you for sharing those 2 stories. Professor has shared the stories of women who are maybe more privileged. You had their backgrounds. And I think a couple of people here also resonated with it. But I want to call upon Angela Nguku to give the stories of the women whose voices are forgotten. And these are the ones who are in the rural areas, in the underprivileged spaces, using White Ribbon Alliance Kenya. Go ahead.
Thank you, Dr. Wala. First, let me say that I'm very happy to be here. But most importantly, let me say I'm happy to hear everyone talking about their lived experience. Why? Because that is the reason I quit what I used to do to start listening to women first, the real experts, what we call at White Ribbon Alliance Kenya as the real experts. Because they say it's a wearer of the shoe who knows where it pinches most. And for me, I'm a graduate midwife just like Nelly. When I was in the university, no one taught me so many things, including how to take care of women who come to deliver with disability, how to take care of a woman who comes with so many needs after she has finished her delivery, and so many other things. And so as I worked in development for many years, I realized that there was a missing link. And I decided one of the greatest things and the biggest disservice we do is that we start at the top, instead of starting with the real experts. And that's why I founded White Ribbon Alliance Kenya, where we use a very unique approach called the Ask, Listen, Act. We don't go to women with a check. We don't prescribe. We go with an open check and let women decide and tell us what exactly they want. And our surveys are called What Women Want. Ask, Listen, Act is our power approach, because when you ask women what they want and listen to them as they prioritize their needs and act with them, then we get a lasting and sustainable solution. Now, so far we've listened to 9 times, 9 surveys, from what women want for quality care, what respectful care means to women, because women told us their quality means respect to them. It means money and everything else. To the last listen, that was actually triggered by 2 conversations I had. I am a certified coach myself, and one of the things you have to do as a coach is to have a mentor coach by ICF. And I have a mentor coach in South Africa, and as I was talking to her last year, she told me, Angela, I can't do anything today. I have brain fog. Every time I go to see my clients, sometimes I don't know what to say. And I wish somebody started talking about menopause. Then she took me back to when I was growing up, and I saw my mom, just like Honorable Justice Joki, the whole idea about my mother fighting us for no reason, quarreling us, and we were like, what is wrong with this woman? What is going on with her? But then that was not it. It took me back 5 years ago when we started doing the campaigns, the What Women Want campaigns. And every time we went only to women who were in their reproductive years. And we had a lot from women asking us, how comes you're not asking us anything after we have finished delivering? Don't you see us? Why are we invisible to the system? That was also the same thing that we had from young girls who are below 15 years, because they're like, you're talking about adolescent pregnancy, but you're not seeing us. How comes no one tells us about anything? But as we were listening to the other 8 surveys, one of the things that stood out was lack of health information. And that struck us, and last year, in partnership with an organization in Switzerland, they funded a campaign called In Our Lifetime. The report is actually out. We launched it 2 weeks ago. In Our Lifetime is a report that reached 97,000 women and girls across Kenya. And we were asking 3 pertinent questions. What do you want most for your health and well-being across the life course and self-care? And today, I want to tell you what I heard from women who have either perimenopausal or postmenopausal. When I was called to, when I was invited to this, I asked Evelyn, I hope you would want us to talk about what we heard from women. Because a lot of times the discussions we have are only held in such rooms, but not in the mashinani. At White Ribbon Alliance, we go across the 47 counties listening to women in all their diversity. Those in the rural slums, those in the urban, the pastoralists, the engineers, the gigs that you hear about, because they are also women in this country with rights. And let me tell you what we heard. Women are asking for information and awareness. And I will quote what they said. One woman said, we do not want to suffer in silence. We want to understand what is happening to our bodies. Many have said that menopause is not openly discussed, so they want accurate, accessible knowledge in their languages at community level and from trusted providers. I know we pushed and we have asked Dr. Serem for policies, but I can tell you, if those policies continue sitting where the rest of the policies are sitting, then we are doing a disservice. So you and me have a role to play in pushing for rights that reach every woman where they are, not the other way around. So beyond the policy, we need to see action and investments in the same. Last week, my team and I were in Narok and Kajiado for what we call self-care conversations. We use a very different, interesting approach called the talking benches or the Sauti benches, where we listen to women and have intergenerational dialogues, but also sit with women differently as they talk to us about their health and well-being. And I was privileged to sit with women who are postmenopausal, 60 and above. And they told me one thing: we feel invisible. Even in our homesteads, in the society, everywhere, and nobody tells us about anything. We do also screenings for different things, because one of the things that women told us that they want to be screened for different diseases. And let me tell you, as we were doing that, they kept on telling us the many things that they have gone through. Hospital to hospital, nobody's really responding to them. A lot of them are told you are just aging. After you give birth, you just go and rest and wait for your time. And I think for me that is painful. Women told us they want respectful care in healthcare facilities, not being dismissed as what I've just told you, just aging, but taken seriously when they present with symptoms like hot flashes, bone pain, or emotional stress. Let me tell you, listening to those nomadic women was really painful for me, because they're like, you know, they go, they come, and when we try to tell them, to inform them and tell them what we are feeling, they're like, every woman goes through that. You're just being lazy. And by the way, all of us are going there. One time I was listening to a conversation sometime during a Women Deliver conference, and one of the women told us, you know, the only thing we can start talking about is old age, because it's cool. All of us are going there. So whether we are there, it's only a matter of time. The difference is time. Women want mental health and psychosocial support. They describe feelings of shame, isolation, or loss of identity during this stage. They have no safe space to process it. Nobody listens. They are dismissed everywhere. And maybe we are better off because we have people that are going through the same thing with us. Those women have nobody in their homesteads. They are just dying slowly. Their quality of life is poor. They want affordable and available treatment options for symptoms, including hormone therapy, nutritional support, and counseling. Actually, we are the ones who ask them about hormone therapy. To them, they have no idea. So we are like, do you know that there's this thing? Do you know? They have no idea. In fact, even the healthcare workers have nothing. And I think we can attest to that if you have been working with women or you are trained as a health worker. Even if you are taught about it, it's rushed. It's not something that is central. But most importantly, they want menopause to be framed as a life stage, not an illness. Women ask that health systems acknowledge this transition with dignity, just like pregnancy and adolescence. And I think I will tell you, I think I learned this question by one thing that women asked us. They told us, and this is in our report, and if you have, I wish I had come with some copies for you to see. And I think there's a video that will be played at some point of one of the women from Narok who told us something. Women told us that we are tired of being seen as reproductive machines. We want to be seen as a whole, from pre-adolescent all through to post-menopause. And I hope today that we can be able to respond to the 97,000 women and girls across 47 counties in Kenya, in all their diversity, who spoke openly, without fear or shame, on what they want for their health and well-being. Thank you.
Thank you, Angela, as always advocating for every woman's voice through White Ribbon Alliance. Okay, we shift gears a bit. Prof, women have been called terrorists. We've called our mothers terrorists. We've been told we are sluggish. Others have confessed they have foggy brains. I actually have to walk around with a notebook and a pen because, yeah, and when I meet people, I say, please remind me what your name is again. I have stopped feeling shame over that. So we talk about mental health and perimenopause and menopause. And I think at some point, Professor Kihara will also break down to us what's perimenopause, what's menopause, what's postmenopause, because those are three different life stages, yeah? So Prof, over to you.
Thank you. And I know, right? It's a very comfortable space to be in. I want to thank you, Angela, for framing this correctly. And where you finished is where I would begin. That, and you'll forgive me for saying this, all, bar none, all our policy and legislation, and Madam Joki, you will confirm, treat women as reproductive machines in this country. That's where we begin. So we can talk as much as we want here, but the laws of this country that have anything to do with women, the constitutional provisions that mention women explicitly, they deal with them as reproductive machines. And once you stop being reproductive, you are erased from our social setup. So that is something that we might have to think about going forward. And this emanates from our social and cultural environments, which cannot conceive of women as anything other than reproductive machines. And so you have to start confronting those cultural underpinnings of our behavior, the religious background of our thinking, and how we have set up our governance system. Because everything is about the fact that we argue about whether women should have sex, when they should have sex, with whom they should have sex, what happens after sex, what happens to the products of sex. We legislate all that. We've put it in the Constitution, Madam Joki. And that's where the problem starts. And then I will pivot from society to the brain, and I will tell you that the human brain bathes in a soup of chemicals. That is what the human brain bathes in. And this soup of chemicals that our unique brains bathe in is dependent on the function of other body organs. And there are body organs that are far away from the brain, including the reproductive organs, the ovaries, the testicles, which produce chemicals that make their way to the brain, and they become part of what bathes our brain. And our brain is made up of nerves that communicate through electrical signals which are influenced by the soup in which the brain is sitting. And so how we behave is influenced by the composition of that soup in which your brain is bathing. And therefore, when that environment, that chemical environment changes, the things that we call hormones, when the ratios of those hormones changes, their interaction with our brain influences how we think, how we feel, and how we behave. That is a biological foundation of behavior. And menopause is perhaps one of the best examples how our mental health is affected by our physical state. Because a lot of the feelings, thoughts, behaviors that women going through menopause, which is really a product of hormonal change at a certain stage of life, how they feel and behave is influenced by that change in the soup in which the brain is bathing. And therefore, inevitably, there are consequences. Some of these consequences are tolerable, so people can live with them, and some of them are disabling and impairing. When do these changes occur? When I was asked to speak a little bit about what are the common mental health issues or impacts around menopause. And I asked myself, when do those changes in the soup that bathes the woman's brain, when do those changes occur? So again, looking from inside out, they occur at a time of great change in the life of a woman, which induce multiple anxieties, some of which are not necessarily related to the change that is happening in the brain. Menopause occurs at a time when, for many people who have families and children, when the children are becoming or have become adults and are leaving the home and have their own lives to take care of, and they have their own children. And your role as a parent has to change. And how you interact with your offspring and their offspring has to change. But change is difficult because you have been used to doing things a certain way. Menopause also occurs at a time when many people who are fortunate to have older relatives or parents are taking care of parents who are much older and experiencing the vagaries of life. These bodies tend to become frail as we age. They get chronic diseases, they get disabilities. And menopause is happening to you when you're taking care of older relatives who are going through those changes themselves. So that is another reason why it's an interesting part of a person's life. Menopause also occurs at a time when many people are sitting back and taking stock of what they have made of this life and what this life has meant, because you've done so many things, and what impact have you had in this life. And for some people, interrogating what they have done with life can produce certain anxieties, because then you start worrying about the things you haven't been able to do that you thought you ought to be able to have done at that point in your life. As has been mentioned severally, menopause also occurs at a time of social changes, even in relationships. So whatever relationships you're having, whether it's with a spouse or with relatives or with friends or other family members, there are changes that are happening socially around that time anyway, menopause or no menopause. And that is the time that you're also experiencing menopause, and these changes are happening. And so when one is thinking about a person going into menopause, person experiencing menopause and post-menopause, you cannot think about that period in isolation. You cannot think about it only as what is happening inside a person, but you have to think about this person, the environment, holistically, as a part of a greater whole. And therefore, some of the features, some of the symptoms that emerge during menopause not only affect the individual who's experiencing them, but they also affect their social environment. So issues like lethargy, which is common during menopause, because the hormones that are produced before menopause, they help you to harness energy, to focus your energies, to do the things that you think are important to you and so on. When there's fluctuations in those hormones, then there's lethargy and difficulty doing the things that you would normally be able to do. There is cognitive slowing, what we are hearing people call brain fog. A difficulty in following through with plans, memory impairment, and so on and so forth, which also have to do with those changes that have happened in the hormonal environment in which your brain is functioning. There will be sleep changes, because again, those hormones interact with other chemicals that regulate when you sleep, how much you sleep, and how much rested you feel after you sleep. There is the heightened senses. I see the women here smiling. The heightened senses. So, this might be a normal, nice, lovely touch when you're 25, 30. But then it's like a blow when you're at a certain age. So there's that heightened sensation, both of touch, heat, all sorts of sensation, even sound, and so on and so forth. So those are because the brain was bathing in a different environment as you are thriving and growing, and now it is bathing in a totally different environment, and it is having to deal with it. Remember, the brain is blind. The brain lives inside a dark chamber inside your skull, and it only knows what's happening out there through those senses. And so when it is getting hyperstimulated, it goes into spaces where you protect yourself because the environment out there is harsh, and it doesn't know any better. There's emotional lability. I mean, this means your emotions, sometimes you don't feel like you are fully in control of them. All right? So sometimes you want to be happy, but then you're not happy, yeah? My son has graduated from campus, and I'm supposed to be there cheering and so on, but I'm not feeling cheerful. And I don't know why I'm not feeling cheerful, because I should. Everything says I should, but I'm not. And it changes like that, and that's a common feature of menopause. So when you have all these features that I have listed, accompanied by the physical changes of menopause, then those are quote-unquote normal psychological occurrences during menopause. But then we have things that become less adaptive. So sometimes we diagnose depression during menopause. And this is a person who has the features of depression, they meet the full clinical criteria of depression, and the symptoms have emerged during menopause. And the same with anxiety and increased risk of suicide in this population. Okay? So often what the research says is that this, what we might call pathological findings in menopause, when I see them in a woman going through menopause, I take a history, and often you will discover that a person who is being diagnosed for the first time with depression during menopause, a significant proportion of them have had depressive symptoms even before menopause. And therefore, menopause might be exacerbating or triggering episodes of depression. It might not necessarily be the cause of depression. And the same with anxiety, and the same with the risk of suicide. So I think this is framing the common psychological and mental problems that one might expect to experience as they go into menopause. And to say, so for the ones that I mentioned about lethargy and so on and so forth, there is treatment, as my colleagues have talked about, hormone replacement and social and environmental changes and diet and so on and so forth, and exercise and so on and so forth. But then when we diagnose clinical depression, anxiety, suicidality, then there are mental health treatments as well for those that would go in tandem with management of menopause. I do know that I have probably very little time remaining, but I think there's a part of this that has to do with integrating mental health in the care for menopause. And speaking as a mental health advocate, I think I do not narrow it, and I was having a conversation with a colleague, and I said mental health must be integrated in all aspects of health and in all aspects of life, because it begins with promotion, which has to do with eating healthy, physical activity, social connection, mindfulness. This is promoting good mental health, whether you are in menopause or before. We talk about prevention. This is early identification of problems, having access to counseling services, creating a social network, taking care of those, the pombe cutting down on that, substances and so on and so forth. And then talking about issues, having a forum to talk about it like this. It goes into treatment, which is identifying those problems and providing treatments. And treatment is not only medication, but it can be social interventions, changing your environment. It can be psychological treatment, and it can also be medications. And finally, speaking about stigma. I think for stigma, we have to talk about addressing ignorance, and my colleagues here have talked about increasing access to information about mental health and about menopause as well. They've talked about addressing prejudices, that is changing our attitudes towards mental health, both towards mental health itself and to those who are suffering with mental ill health. And we've talked about discrimination, addressing discrimination through social norms, taboos, but also through legislation and through policy. The final thing I would say for menopause care, from my experience in mental health, I would say this is not an individual's problem. So when you're addressing the problems of menopause, please include families in these conversations. Please include the social network of this individual in those conversations so that they become part of the social support network that helps the woman to deal with the challenges that they face during menopause. Thank you very much.
Thank you so much, Prof, for reassuring many of us that indeed some of these things are real and that we're not imagining, we're not just being difficult at work, in the house, that these are chemical imbalances that are triggering, and some really do need attention. Asante sana, Prof. Okay, so we shift gear to Professor Ann Kihara, who will talk to us about how do we address all this. So we've had the woman from Kajiado, we've had the couple who does not want to be touched, and we have people experiencing real mental health issues based on this. Is there a solution, or do we grin and bear it? Go ahead.
Oh, we certainly have solutions, and thank you, Wamakobe. I'm coming with a different context. And I want to start by defining what is menopause, premenopause, postmenopause. Menopause is just a cessation of periods. Your periods stop. 1 year, no intervention in terms of family planning methods or other drugs being used. It is a natural phenomenon. You were young, you had your ovary, at puberty you start your menses, and you begin to acknowledge you can be reproductively active. By menopause, periods stop, your reproductive clock has closed. But it's not always an aging process. I want to put this very clearly. You have those who will go into premature menopause. Why? I'm on cancer therapy. Or I have done surgery on you, especially when you've had conditions like endometriosis, deep-seated endometriosis. You've got scarring on that ovary. And I may be forced to even move it out, or the interventions of surgery just cease it to function. And this can happen very early, ladies and gentlemen. A 34, 40-year-old. Or you had a hysterectomy and we say, your ovaries were not looking too healthy, I had to come out with it. What have you done? You've crushed the estrogen production. And principally, that is the hormone that keeps all these ladies looking very beautiful. Very beautiful. It's your estrogen. then come through the natural process of aging. The ovary is reducing the production of that hormone, but the body clock is beautiful. You start beginning to gain weight between the lower part of your chest and the upper part of the lower part of your pelvis. Why? That fat tissue is actually a compensatory mechanism to produce the estrogen you need. So when you start gymming and you start finding this isn't quite going away, it is because that's a compensation happening. And then you have the lady who, in the premenopausal, which can happen anything between 5 and 10 years before menopause, which you now know, and then the post-menopause is about the 10 years after ceasing the menstrual period. That's the period. We call it climacteric. Please don't confuse it with my sexologist. But that's the period in which really hormonal replacement therapy can make a difference. I hope we're getting it very clear. Now, what happens with the lady who has premature ovarian failure? And especially noting it may be a much younger girl or lady. I have to start complimenting her. Why? Why do we do this? You've talked about the brain fog. And Honorable, I really liked your story because we go through it. I'm still on pen and paper to date, just to make sure I get it right. But you have the brain fog if unaddressed as a result of menopause and your happy hormones. He was talking about happy hormones. We don't want to get too technical. But there's some happy hormones that dance. Your dopamines, your serotonin, they're beautiful hormones. I mean, the milieu, the environment the brain is bathed in, that keeps you a happy soul. Now, when menopause comes and estrogen goes and your happy hormones decline, now you begin to see those mood swings, temperaments, concentration deficits. In its worst, we talk of Alzheimer's or the dementia, which he has to deal with, which families have to grapple with. So that's one big problem you would wish to avert. You have to start upstream. The other is cardiovascular disease, heart problems. The other one is now the bones that creak and you begin to behave like a robot. When you're asked, stand by Nelly, give me time. When it's really on a bad day and cold like it is, you can see some of us are wearing very warm clothes. Not out of choice. You want to keep warm because those bones are not moving as agile. A lot of people will present with fractures. Any small fall or displacement, it just snaps because the bones have weakened and cracked up. So those three things, the bone issue, the brain issue, the heart issue. But let's compound this. This is also the age we're beginning to see diabetes raising its head. We're beginning to see cancers raising their head. So you have other cocktails of things that may surround this particular time phase. And then you have the relational issues. I don't have to belabor to that. But your partners, your children are leaving the nest in a lot of the families, particularly in your post-menopausal year. And for women, there is a give that has to happen. And sometimes it's very painful. So, what is the role of HRT? Simple. I'm replacing particularly estrogen. That's the main hormone. But I also have to know, do you have a uterus or not? Because if I bombard you with just estrogen, I may actually end up giving you a predilection, let me use the word predilection, to getting cancer of the lining of the uterus. So a lot of us will give a combi pack of estrogen and progesterone. So some people will get cyclical withdrawal bleeding. A lot of women don't want that. I'm done. And this is the reason we've progressively reduced the doses of those drugs so you don't end up with a period that you had ceased having. Why am I mentioning this? If after menopause, you're being followed up whether you're on HRT or not, you're getting post-menopausal bleeding, it could be heralding a problem, particularly cancer of the reproductive system. I don't want to say just the uterus. The uterus can have cancer. The ovaries can have cancer. The vaginal lining, even the cervix, they all give us postmenopausal bleeding. So when you have menopause, please, any woman, the first thing you need to know, if my periods return and they had stopped, that's a red flag. I hope we're together. Now, I'll advance it even more. Testosterone. We have an amount of testosterone we release as women, particularly in your mid-cycle during your reproductive years. And we do use testosterone supplements, particularly when you have issues with libido. Low dose. But we know you have to have it monitored by your doctor. Too much of anything is a poison. We're in an era, and I really like the fact, Goko, you went up north. Climate change, environmental toxins, we don't talk as loud, but we know it is beginning to even affect our endocrine, our hormonal environment. So we've got to start paying more attention. So I'm not surprised she gave the story she's given. The sense is there. Do we have HRT in this country? Public system? No. And I hope, Honorable, you're noting. Yes, we have our essential drug list in this country. Estrogen has actually been put in place, and if you look at the latest publication of 2023, it has even been given an indication for hormonal replacement therapy. The progesterone, we have some tablet, but we do not have definite HRT medications are 1, 2, 3, 4, as I've alluded to. Okay? So we're wanting private system, private insurance, and particularly the really beefy ones. You may be able to access the medications, am I right? But these are the girls with premium package. What do I do with Mama Mboga? What do I do with the lady in the rural village? So some of the things people are misusing, and please put it loudly in the airwaves, are family planning tablets. That is wrong. That is wrong. Because family planning tablets have got different preparation, which has got much higher doses, which have a wrong effect to your system. HRT is just that, hormonal replacement therapy. Much lower dosage, and either given consequentially or cyclically. That's one. Do we have testosterone preparations? Nada. So what have women recourse to? And I think all the ladies in this house will be very familiar. We take alternative medicine, cocktail. And I wouldn't mention names, but pyramidal schemes do exist. Yes or no? Do we know them, ladies? And you're told, okay, you can take red clover, you can take evening primrose, you can take, I can go on and on with these alternative herbal and natural things, including soya. Now that one everyone knows. Soya. They do have a role, but to be honest, have we done proper research to look at it in our context? Nada. The other thing I must mention, Honorable, and this concerns me, is all these things that have raised their heads we're not talking about. The Botoxing, the fillers, the facial lifts, the breast augmentation, the liposuction. Now you've understood where I'm coming from? Question is, what is the regulatory framework that we have? And is it right? We have even seen calamities that have happened, haven't we? So we've got to think holistically and not just at HRT, because this is also a time self-image becomes a problem. And women definitely always want to look nice. At 80, I want to still look good, Dr. Monda, don't we? So that's what I would want to say about this question. Conflicting information, misinformation, disinformation, inappropriate sound knowledge. The second one, how can we improve access to safe, affordable HRT in Kenya? We've talked policy, policy, policy. Policy is not operational. We must have guidelines. We must have algorithms. I've talked about the woman with or without the uterus. But we have to add layers. In some women, before you even give hormonal therapy, find out the family history for breast cancers. Find out if she's already having post-sexual contact bleeding, which may actually be heralding that there is a problem at the cervix. So you must look at the patient history. You must know how this patient is through laboratory investigations. Now, the laboratory investigations, I'm coming to insurance because she's seated here. It's a whole bombardment of investigation. I need to know your BMI. I need to know your lipid profile. I need to know your sugar. I need to know how your thyroid is behaving, because they all have a bearing. Now, that cocktail of tests, honestly, honorable, it is impossible for Mama Mboga to afford it. It is impossible. But it must be done, because some of the drugs have got a bearing on the liver. And I need to know how it is. I may be on other treatments because I am a diabetic or I'm a hypertensive. So you have to look at that. Then we have the issue around choosing the route of the medications. Increasingly, we're moving away from you gobbling it up. We want to use transdermal, so patches, gels, creams, because they don't affect you elsewhere. They work where they're supposed to work. So we have to be able to decide with the individual. It is individual. So I come again to Honorable, and I come again to Evelyn and to Nellie and to Angela. Do we have well women clinics? I've always said, where is the Golden Girl Clinic? It doesn't exist. I'm over 50, where's my Golden Girl Clinic? So that I can have this executive screening and checkup. Most of us stop when we stop giving birth. That's it. I never see you again. And when I do see you, I'm dealing with rheumatic problems, brain problems, cardiovascular issues. They've already set in. And even then, they may not ask about your menopausal or your gynecological history. So, well, women clinics. Because really, we've got to start having an entry point at all levels of care for women so that we can begin to have this conversation. Monitoring and follow-up. Please, I don't want you to leave here with a blanket that everybody can go onto HRT. Some of us did not experience hot flashes. I don't know what it is. Some have nightmares. I will not mention who is asking me, what do I do? Yeah? So some have nightmares. But every woman experiences a transitory issue. This is an ideal time to even do screening for particularly reproductive cancers, and please do not forget the breast screening, which we really say start at 40 if you haven't done your basic mammogram. So we have admins that can add value for our women, and therefore it can improve access and safety. We have endocrinologists. Gynecologists ideally should be dealing with this entity because it's a continuum of her care. But endocrine people tend to come in because we tend to see them for diabetes, for my hypertension, for my thyroid problems. So that's a complementary group we should be working together with. Mental health, we should be working with. So when I'm talking about a well woman clinic, it should be multidisciplinary. Must be. Reviews, follow-up, 6 monthly to begin with, and then yearly, if you have no problem with your HRT. HRT does not go on forever, amen. For some women, they'll use it for a year. For some women, 3 to 5 years. For others, they may have to use it a little longer. It's individualized. I don't want you to go there with a blanket. Then, what safeguards should I plan to have to ensure safe prescribing? That's the easiest question to answer. I have a policy framework. I have guidelines. I know how to actually put an algorithm on any woman. Screening, diagnosis, management. And I want to bring in the male because honestly, you are partners and allies in this war. You must walk with us, understand us, have public education forums, have forums where we also undertake localized Kenyan research. So here, I'm even looking at Ministry of Health. Mary is here, Magumbo. I know you'll get the message to my friend. Yeah? We have to start a registry on menopause. We don't have. We just don't have it. And what's not documented is not. Yes. Number 2, we have given too much leeway to the quacks. I'm sorry to say. The quacks. Wherever there's a hiatus, you don't fill it, somebody will come up to fill that space. So those commitments there, honestly, I will be prepared to run. Because menopause has been a neglected area. And it has to change. I'll leave it at that.
Oh. Thank you so much, Prof. Kihara. As you're coming to sit, we just want to take a couple of questions before we break. I know it's loaded. We also have other panels that will cover some of the issues they've raised. We have lived experiences coming up. And in the afternoon, we have research and data and policy conversations coming up. But asante sana for that. So I'll request that we keep it very short. The KISS principle, keep it short and simple. Raise your hand. I'll take one from each column. Okay, one that was first. Anyone here? Okay, so I'll take you. On that side? Okay. Yes, there's a gentleman. If someone can help me pass this around, thank you. Okay, so 4, then we close. Very quickly, your name and your question or comment. You can stand up for the sake of recording. Yes, and being seen. We said we are no longer visible, eh?
Good morning. My name is Wairimo. My question is for Dr. Lukoye. I think I've relayed you a couple of times at conferences about the fact that we don't have any empirical studies or tests for mental health. So when you talk about the brain soup, there's nobody who has ever told me that your serotonin is low because you should be at an 8, but it's at a 4. So how are you being able to now move from that place where we already don't know so much? In fact, my doctor admits that psychiatry has elements of witchcraft. Yeah, Kigamwa. Because you can't really say this is what is wrong with you. So how are you working from that place of not quite knowing what's going on in mental health and now throwing in MHT?
Thank you so much. We'll take all the 4. Okay, thank you.
Mine is for White Ribbon. You notice that...
Introduce yourself, please.
My name is Jockey Domo.
Oh, sorry.
Yeah. It's fine. No, you're right. I should have introduced myself. I want you to share with us perhaps your experiences if you have gone to the coastal area or in the areas in Kisii. You notice that the witches who are killed are elderly women, and whether you have found a connection between the labeling of witches and menopause.
Pertinent. Thank you. There's someone behind. Yeah.
Yeah, thank you. My name is Dr. Wanjiru Munene. My question is to Professor Lukoye and also Professor Kihara. Are we now pushing for these studies to be included in medical school and colleges? Because everyone is talking about they never went through such classes. I think it's a bit too late if it's not there yet. And then maybe a question to Jokin Dungu. What is this cream she's applying so we can buy for our mothers?
Thank you so much. The fourth question.
Thank you. My name is Javan Waita. I work with Jacaranda Health Solutions. My question goes to Angela because she knows what the women want and is related to awareness about menopause among these women. Then the other thing is awareness in relation to seeking behavior during that period. How do they want to be made aware about menopause? I think that is very important.
Thank you. Okay. Let me pick just one out of the three because of time. So she addressed the lady with the black jacket. My panelists are still around even over tea time, so please, let's, yeah, go ahead.
Thank you so much. My name is Bridget. I am excited to be here thanks to my colleague who was not able to come because I am in menopause. So when I ask for my point of information. I'm not sure if I'm asking this to either Professor Ann or Lukoye, but one of you two. I have in the last couple of less than 2 years worked with two colleagues who have been diagnosed with the cancer of the breast. They are both in menopause. Is this a silent war that we should be looking at as women in menopause? And I want to commend also the thought of mental health in menopause. I love what Angela said, and having worked with Angela in a different forum, I'm happy that we're making the steps we're making. But my question is, when will we start speaking? Thank you for this first initiative that we have done. I know we will have a call to action at the end, but what can each of us do to make it happen? Thank you.
Thank you so much. So over to my panelists. As you answer, you also conclude. Thank you.
Okay, I have. Thank you very much for those questions. I'll tackle two. Research as an agenda. If you don't see the patients or the clients in a structured setting, and in this case, you do not have direct access, we'd have to probably be going into the other clinics to look for our menopausal women who are already having other comorbidities that are bringing them in. My suggestion would be this. Put in a clinic. They will come in the droves. Secondly, we're in the age of molecular science. And we do have laboratories that are able to even look now at hormonal profiling. So yes, we have room and must actually begin to look at menopause in this country, seriously. We also have radiological. So there are clinics, orthopedics, where you're having pathological fractures or problems with the wrist or the arthritis. Most probably we are actually missing just giving these girls the HRT. But yes, there are opportunities, but more so, open a well-woman clinic or menopausal. I don't want to use the word menopausal because it really begins to get stigmatized. Out there, most of them call them as well woman clinics or golden girl clinics. Then you know it's after 50. Okay? The second one, curriculum. Yes, we even have it in our medical school curriculum. The question is, how much time is being committed to that element? That's the issue. The other one is the issue of, yes, the breast cancer. We have to go on top of hills. Cancer must be screened for, but I want you to recognize they're equally sensitive. You're talking about the women exposing their bodies. During labor, during pregnancy, it's a different issue. Once they're done with that, what do most women say? I'm done with the doctor. Gynecologist tumewachana na nyinyi. Bye. Nitakuletea mtoto wangu. That's a common statement. But women need to get into that baton wheel of, if you have a car, don't you take it for service? Even a bicycle or a tuk-tuk or whatever it is, don't you? How much more should we be valuing our bodies to give us quality of life? And more importantly, knowing we're actually living longer. That's the reason why we're even seeing more and more women entering into menopause. My parting shot. The investment case in menopause is real. $1, you reap $4. You treat women with menopause right, you will actually gain 7 billion. Jockey, take that to the main house. 7 billion. Why? Not only is she still productive if kept healthy, she also takes care of the generations that follow. Majority of our grandmothers, who do they nurse? Wajuku. Yes or no? They're still in the farms. They're still nursing their husbands and the family members. So she becomes the lady of wisdom in her old age, but still contributes to societal development. We must have an investment case, and we will then reap from the menopausal woman.
Thank you very much, and thank you for the questions. All very interesting, and they show that we have been engaged. So the first question was around how do we diagnose mental illnesses? I think that's how I picked it, and the main thing is that just like any other branch of medicine, a diagnosis is not made based on any one thing. A diagnosis is made based on a collection of information. And it is the information that informs the doctor about what the problem is likely to be. Even whether it's malaria, diabetes, hypertension, depression, schizophrenia, and so on, it is the amount of information you collect, which is why medicine is both an art and a science. So you will go to the clinic and you know about Maswalia Clinic. The doctor will ask you very many questions, and the whole idea is collecting data about you so that they can correlate with how you're feeling and how you're presenting, and then do some tests and combine all that information to arrive at a most probable diagnosis. So, and that witchcraft you saw in the psychiatric clinic is the same witchcraft that's practiced in all of medicine. And medicine is about probabilities. It's highly unlikely for anyone in medicine to be 100% certain that what they're telling you is the truth. Whether it is in the diabetes clinic, whether it is even telling you the sex of the child in the uterus. It's all about probabilities, and there are always surprises. So for instance, to diagnose depression, we will collect information about how you have lived your life and how you're feeling today, and how you have interacted with other people, and how you're working, how you are relating with your family, and so on and so forth. And those will increase the probability that what you're suffering from is depression. So it's a proxy for what is happening inside your brain. And we can tell. Because if I inject you with certain chemicals that make people feel depressed, you will feel depressed. So by observing the behavior, I don't have to extract blood and test for those chemicals. It's a proxy for what's happening in the brain. And this is the case with everything. So that's common in all medicine. It's not just in mental health. There was a question about labeling of witches and so on. A lot of the people in Western Kenya, in Kisii, and at the coast, where people are labeled as witches and killed, there are social issues around that, as well as psychological or brain function issues. So people with dementia, because they often behave differently, and some of their behavior is labeled as witchcraft. They are treated like that. People with certain mental illnesses can be labeled as witches and so on. And people who are just old and live in places where land is scarce, and they're the last remaining owner of this land, and people want that land, they will be labeled as witches. And then they'll be killed, and then other people will take the land. So there are multiple social and psychological factors around the labeling. And if somebody sits down with the people labeling and does an in-depth interview, you will discover that it has nothing to do with witchcraft. It has to do with social and psychological factors around that. Yeah, my colleague has talked about menopause in schools. So today we teach personalized medicine. We teach that you don't make assumptions when somebody walks into the clinic. You don't assume that because they're from place X and they're walking in this way, then they're only having this problem. So we teach about making patient-centered or client-centered, collecting as much information about your client as possible, making sure that you have understood why they have come to see you, and working with them to fix the problem that they have come with. So that is what we are teaching today. And therefore, somebody with menopausal problems ought to be treated as an individual, as a person coming with a problem, which we work together to understand, and then we work together to solve based on the available resources, based on their wishes, not based on what the doctor thinks is the right thing to do. Finally, I think there was this issue around cancer, breast cancer. Again, I will say this for everyone. Screening, as my colleague said, is the key. And do not wait for menopause to start screening. Today in this country, the prevalence of breast cancer in young women is huge. We used to say wait until 40 and start screening. We are seeing women with breast cancer in their 30s. So touch your breasts daily. If you feel a lump, go and see a doctor, get it examined, get it scanned and so on. And early diagnosis saves lives. If you wait until it is painful, until there's a discharge, until it has spread, it's often very late, and then you go through very expensive treatments and so on. And this doesn't apply only to breast cancer, it applies to your entire body. There's screening for breast cancer, cervical cancer, and so on and so forth. My parting shot is this. Everywhere you see me, you will know that I say there is no health without mental health. Whether you're talking about menstrual health, whether you're talking about the health of our older women, whether you're talking about population health, there is no health without mental health. So every time anybody is telling you, I have designed a health service for this segment of the population, ask them what mental health services they have integrated in that segment. Because every stage of our lifespan, we have different unique mental health needs based on where we are in our lifespan. When you're a child, there are different mental health needs. A young adult, different needs. An older person, different health needs. A man, different health needs. A woman, different health needs. So you have to integrate mental health services in all health services, including services for menopause. Thank you very much.
Thank you. And lastly, I'll start by responding to what Honorable Justice Ndungu asked. It's interesting because last week we were near Kilgoris. It's a border of where the Maasai and the Kisii live. And we had a conversation in some of the talking spaces and the Sauti benches I was telling you about. And the older women were talking about the hot flashes and how they suffer in funerals, because if you start experiencing hot flashes in funerals, they say you are the witch. You're the person who has bewitched that person. And so most of them don't attend those funerals. And some of the things, and I think it's a question I was supposed to respond, is around the myths and misconceptions as the biggest barriers to menopause. One of them is the myth of silence, where menopause is not talked about. And I think that is the biggest thing that we need to do to break the silence, for us to be able to allay the disinformation and the misinformation that is really there. The other thing is a misconception that menopause is a weakness, that the symptoms like fatigue, mood swings, or even forgetfulness, that means that a woman is lazy and no longer useful. That is something that we have had a lot and a lot in the spaces that we've talked with women. Stigma now is reinforced around that. So you can't talk about it, and when you talk about it, you're told you're lazy, so you better just be quiet. Then they believe that nothing can be done because nobody talks about it because our mothers did it, our mothers went through it, they're told, why not go through it? You are being a weakling, just the same way rest is being looked at as laziness and the like. And then that idea, the idea that menopause is the end of womanhood, that once you reach menopause, that's the end of you, so why should you be talking about it? You are done, your time is up, so why should you be talking about it? And just to address the same question, I'll address the same other question from the guy from Jacaranda. I think what we've had over and over again is that women want information. They want information where they are, not for you to wait for the woman to go to the facility. You see, we live in a society, especially in our country, where healthcare is supposed, the patient goes to the healthcare, the demand goes to the supply, not the other way around. I think it's the high time that we realize that if we don't pay less now, we'll pay much later. And I think we're already paying that. Where if we have decided that women must go to where the care is, not the other way around. A lot of times I keep asking people, why were we trained that clinics, for example, for immunization should be opened in the morning when we know very well that women are supposed to be fetching water or taking their children and the like? And that's what women told us. Why don't they open the clinic in the afternoon when we have done all these things? It's the same things we are hearing from these older women. We are old, we can't walk, our bones are painful. Why not come to us? So even as we are thinking about interventions, health information, we are all talking about digital technology and the like, it is good. But realize that women are heterogeneous. Let's stop planning for women as homogeneous. We have women who are 80% illiterate in this country. I mean, counties where women are 80% illiterate. How will they be able to access that digital technology? We have women and girls who have never been to school just because of where they find themselves. We have refugees and migrants. We have women with disability. We have different needs for different women. Why do we program for them as if they are just homogeneous? And women are telling us we are different. We are not the same. The last thing that I'll say, and I say this because I can see Dr. Wala looking at me badly. I think we need to stop siloing women. They want to be seen as a whole. We need to be able to let women diagnose the systems. Actually, our casebook and one of our documentaries that we did alongside the In Our Lifetime report is Voices That Diagnose Systems. And I want you to get into our YouTube and really watch it. You will actually hear a lot of the things that women tell us are actually telling us which part of the system is failing. Women who are menopausal said, we are not seen, we are invisible, we are completely out of the system. Health information never reaches us. And I think for me that is already the starting point. And that's why I believe in asking women what they want. Listening to them as they prioritize their needs and acting with them, not for them. Because once you act for them and you go, what happens after that? And I think my clarion call today is that at the end of the day, women want accurate information, respectful care, affordable options, and recognition that this stage of life is not an ending, but a continuation of leadership, contribution, and worth. And they are not yet done. It's us to start thinking differently, to start looking at how we do things differently, and start from where women are, not where we are. Because if we start where we are, we lose more now than later. Thank you.
Wow. Thank you so much. I was very consoled when Professor said someone was having an orgasm at 114 years. So we have not ended with menopause, isn't it? Let's give them another round of applause. So we'll stand up for a group photo, and then I'd request, once you're done, please sign for me my commitment form in legible handwriting, saying that you're doctors. How much as they're going down, you can access them over tea break, but also through the organizational profiles. Please come and sign my commitment form. Thank you. So we are breaking for tea. We are running a bit behind, but we'll catch up. We're right on time.
Yeah, 11:30.
Oh, perfecto. Thank you so much. This is menopausal brain. I saw 11. So, but thank you so much. Our tea will be served right outside for my guest speakers. We have the holding room upstairs, so I'll request that we go upstairs. We should be back in 15 minutes, please. You don't want to miss this next session. The women are fired up to tell you about their life journeys. And right outside there's a booth. So if you felt your voice wasn't heard here, we are doing short clips, recordings, right outside to my left. Please, it's free for anyone. You want to voice what you're doing. This is your time to shine. We're going to collect it with consent, of course, and put it together into a mini documentary series. So right outside to my left, there's a booth that we are doing short clips. Karibuni sana. AV team, please put the documentary for White Ribbon Alliance.
When the symptoms of perimenopause began, she didn't have a name for it. Just symptoms, just confusion about what was happening to her body. There was no nurse or doctor to explain what to expect in a language that she could understand. No one to ask and no answers given. It was just her, alone, with the body changing in ways she didn't understand. The only solution she thought of was taking traditional medicine. Across Kenya, thousands of women are walking through menopause with no guidance, no support, and no recognition. Once they are no longer of reproductive age, the health system stops seeing them. Their needs fade into the background, unseen, unspoken, unsupported.
My name is Nalaketi Leposo. I am 50 years old. I started experiencing changes in my body when I was 40. Headaches, backaches, and then one day, my periods just stopped. I was not using family planning. It just happened. I didn't know what was going on. No one had ever told me about menopause. Not a nurse, not a doctor, not even other women. I didn't ask, and I didn't go to the clinic, partly because I didn't have a husband, and partly because who would I even talk to? Up to today, I have never gone to a health facility because of menopause. I managed the symptoms the best way I knew how. With herbs, I walk into the forest and pick what I need. Other times, I buy from local herbalists. I didn't tell anyone. In our culture, you keep such things to yourself, even when you don't understand them. It's only later, when I talked to other women in the village, women my age, that I realized that they had all gone through the same thing, quietly, alone. We talk now, we share what happened, but still, it's too late because we already navigated the worst. I never had a single checkup. What I would want most is for doctors to give us information, to tell us what age menopause starts, what to expect, and what is normal. At that time, I just want someone to sit me down, explain what was going through my body. I lived through the change in silence. But maybe the next woman won't have to. When a woman has the right information, she is able to navigate through menopause with clarity, not confusion. She becomes her own compass.
Na etu ake toonkuti olong'i kake mikununya enapa agira aisho itu eponari keetu egira adoyio mpaka neeku meeta.
When the symptoms of perimenopause began, she didn't have a name for it, just symptoms, just confusion about what was happening to her body. There was no nurse or doctor to explain what to expect in a language that she could understand. No one to ask and no answers given. It was just her, alone, with the body changing in ways she didn't understand. The only solution she thought of was taking traditional medicine. Across Kenya, thousands of women are walking through menopause with no guidance, no support, and no recognition. Once they are no longer of reproductive age, the health system stops seeing them. Their needs fade into the background, unseen, unspoken, unsupported.
My name is Nalaketi Leposo. I am 50 years old. I started experiencing changes in my body when I was 40. Headaches, backaches, and then one day, my periods just stopped. I was not using family planning. It just happened. I didn't know what was going on. No one had ever told me about menopause. Not a nurse, not a doctor, not even other women. I didn't ask and I didn't go to the clinic, partly because I didn't have a husband and partly because who would I even talk to?
Ore naaji eretoto nayieu nanu tiatua osesen lai naa tenaa kidimayu naing'urakini kuna kera ainei natum biotisho amu maitoki aata enyamali oondamunot.
Up to today, I have never gone to a health facility because of menopause. I managed the symptoms the best way I knew how. With herbs, I walk into the forest and pick what I need. Other times, I buy from local herbalists. I didn't tell anyone. In our culture, you keep such things to yourself, even when you don't understand them. It's only later, when I talked to other women in the village, women my age, that I realized that they had all gone through the same thing, quietly, alone. We talk now, we share what happened, but still, it's too late because we already navigated the worst. I never had a single checkup. What I would want most is for doctors to give us information, to tell us what age menopause starts, what to expect, and what is normal. At that time, I just want someone to sit me down, explain what was going through my body. I lived through the change in silence. But maybe the next woman won't have to. When a woman has the right information, she is able to navigate through menopause with clarity, not confusion. She becomes her own compass.
Ore apa tenanu naa eetuo ake toonkuti olong'i kake meikununy enaa apa agira aisho eitu eponari keetuo egira adoyio mpaka neeku meetai.
quietly, alone. We talk now, we share what happened, but still, it's too late because we already navigated the worst. I never had a single checkup. What I would want most is for doctors to give us information, to tell us what age menopause starts, what to expect, and what is normal. At that time, I just want someone to sit me down, explain what was going through my body. I lived through the change in silence. But maybe the next woman won't have to. When a woman has the right information, she is able to navigate through menopause with clarity, not confusion. She becomes her own compass.
Okay, let's settle down. Thank you so much for honoring our time. We have these flip charts. Please don't let me go home with them empty. Let me read for you the questions. So this number 7 is, if you could tell policymakers one thing about menopause, what would it be? Number 6, before you leave, write the most surprising fact or insight you've gained. Like, I am proud of my midriff right now. Write a catchy slogan or tagline for menopause awareness in Kenya. You don't have to fill all 7. In one word or short phrase, what's one thing that will make menopause easier for Kenyan women? How does menopause affect women in the workplace? One myth or misconception about menopause that you've heard. And if you had to describe menopause in just one word, what would it be? So they're very simple questions. We have felt pens and sticky notes that you can put. Again, we have our booth right outside. Please go and share your story or whatever other information you'd want us to hear. So, great. Now, I'd like to invite one very special lady. She's called Dr. Kafugo Kamau. We know her as Bugo, those of us who know her beyond her health issues. And she's going to moderate the next session so that I can also take a break, and she'll handle this very well because these are her circle of friends, and I think she'll give us more on that. Dr. Kabugo's profile, please let it be up on the screen, Sam. And I forgot, Dr. Kabugo, they are online listeners, so I'll capture questions from there also for you. Okay.
Is it afternoon yet, or it's still morning? 1 minute. Good morning. My name is Kavugo Kamau. I am a clinical pharmacist by training and also a menopause practitioner. I am licensed in Kenya and in Texas, and that is where I basically do what I do. I am also the founder of the Women's Health Cafe, which is how many members are here from our Women's Health Cafe? Wave your hands, and thank you very much. Thank you very much. We are very popular, by the way. The Women's Health Cafe is a women's educational, informational, advocacy space. And the reason why I started that group, and I started with just me on November 29th, 2023, was because of experiences I had with other women. And of course, for me, menopause also became a retroactive kind of story because I was seeing all these things and I was talking to all these women, and I realized many of the women were clueless about a lot of things with their body, even their anatomy. So I started the group, we started it, we grew, we just started growing. But I think a lot of the women started off before that because we started having a monthly menopause support group meeting. Our first meeting, and I think Dr. Monda, were you there? Who was there on the first meeting? It was in September of 2023. And then we have had monthly meetings ever since, and we meet in different places. Now, why was it called the Women's Health Cafe? Is because in my other life, I'm a caterer. And so I thought, how about we just create a very safe space for women to come, probably have a coffee and have a conversation about what's going on with them. So that was just the only information about why the cafe. But I think it worked pretty well because a lot of the meetings we held around a meal, a drink, or something, which kind of made the ladies feel a lot more comfortable, I guess. So it is a WhatsApp group. It started off as a WhatsApp group, and of course it has grown, and now we are at max. We cannot take in any more. I have a waiting list of 302 women, and as of today I only have 3 slots. And usually those slots happen by mistake. If your WhatsApp kicks you out and you have to whatever, you know, you're just thrown out automatically, then your space becomes available. And many women come back and say, oh, but Bugo, my WhatsApp gave up on me. I'm like, it's so hard now to come right around. So it's really not a fair system. So we'll find a way that will make it fair, especially for those who have been there for a long time. But the group on WhatsApp has 2,000 women. Today we are 1997. Like I said, we have 3 open slots. And we just keep growing. So I had to move us to social media. We have a Facebook page, we have a LinkedIn page, we have an Instagram page, we have a lot of other ways that we are attracting. But those other avenues allow men. And the reason why this one was women only is because we needed to create a safe space. And I think many women can relate when we say, sometimes men make us uneasy, right? And we're not able to really say what we want to say. There are a few people who snuck in there. There was actually a clinical officer from somewhere, and he said, please, just let me stay so I'll be able to help my patients. And I said, no, you just have to join the other ones. So it's a women's only space. And then, of course, we broke it down because menopause is just one of those things that we go through. There's a lot of other things that we go through. So within the community, there's subgroups. There's a mental health group. There's a metabolic health group. There's a gynecology group, which captures everybody. That one fills up, and I don't know what to do with that one because every woman falls under that one. What other groups do we have? We have co-parenting because a lot of us mothers are dealing with being single mothers and those kind of things. We just created a divorce one, and incidentally, this month's support group meeting, which is next weekend, is going to be about how perimenopause and menopause may be affecting our marriages and relationships. And I think we already talked about parenting. Parenting is a special one when you're in perimenopause and menopause. So there's about 13 subgroups within that. So somebody asked me, how do you create this safe space? How do you make sure that, and for those who've been there from the beginning, I think we had to set the tone really early, you know, no judgment. Don't come here and say, but you're so this, or but you're so that. We don't need to hear that. I just came, I stated what I'm feeling, and we support you. So it's important that we are here to support you, not to judge you, not to make you feel bad about what it is you said. And then we have a group called Sex and Orgasm, which is actually the most popular of the groups. And that one we had to tone down the porn. There used to be porn in the beginning, and I'm like, this is not what we are about. But we talk about sexuality, we talk about all those things that we need to be talking about. And incidentally, I guess because it's a group curated by me, a lot of the women are that same age group. I'm 50, so the majority, even those who are very active, are between 45 and 55. But we do have, our youngest member in the group is 22. And we do have mother-daughter, you know. But those ones become very complicated because I don't think you want to listen to your mother talking about how she was having wild sex in Mombasa last week, you know. But some of them are comfortable. So we do have mother-daughter groups. And I think what I've learned from that group is women just need sisterhood. You know, if anything, I think sisterhood covers half the job. Then the rest is now share with me what you want. And this group has grown just by word of mouth. It's you go, you tell your sister about it, you go tell your auntie about it, you go tell your mom. There's a lot of people who say, I just want my mom to join it, you know. And so there's been really no advertising, no nothing. It's just sisters bringing sisters, bringing sisters, bringing sisters. And that's been very encouraging. And I want to say, I mean, and the ladies will give their experience from the group, but I want to call up the members who are going to come here today and talk about their lived experiences. You know yourselves. Get up. And I've really tried to make this, I've asked them to keep it very short because we don't have very much time. But when they shared their stories, and some of them I already know their stories, go ahead. Some of them I already know their stories, and I'm like, but your story is so unique, but your story is so unique, and our stories are all unique, right? Our menopause journey is going to be so different from the next and the next and the next. So I couldn't pick which of these to have a conversation with. But now that they're here, we shall rush them through. And funny enough, out of 2,000, group dynamics are very interesting. Eh? Out of 2,000 women, these are the only ones who responded to this call. And I said, I can't choose just some, right? And then I was told, no, cut them to 3. I said, I'm not going to cut them to 3. We're just going to have them write down their responses. But we're going to talk very fast, right? So you can introduce yourself, and where do you want to start? Who wants to start? Okay. And I'm trying to find the questions. Do you want to go with the questions? Do you have your questions? You have what? Okay. Okay, yours was a narrative, wasn't it? Okay, go ahead and tell us your story. Okay, introduce yourself first.
Right, good morning. Is it on? Good morning. You can hear me. Good afternoon, right? My name is Ruth Musembi, and I'm a woman in midlife. Now, that's how I'm introducing myself nowadays. And I'm going through, I think now I might have entered menopause, but I've been on perimenopause for some years. And I have a story, so I wrote it down, and I'll read it. It's very short, but to say that my life has changed since I joined this group. Let me read my story, and then I can add 1 or 2 things. So it is titled, It Takes a Village, My Menopause Transformation. So the way in Africa we say it takes a village to bring up a child, I feel it would need to take a village. For example, today we are in this village, for us to turn around the tides and make sure we are living the life that we deserve. So it truly takes a village to find solutions for menopause challenges. For me, that village has been Women Health Cafe. If it were not for WHC, I would never have discovered Dr. Louise Newson, one of UK's leading menopause doctors. At my very first WC hangout, I sat next to a lady doing a survey on menopause apps. I wasn't using any app, but that's how I found the Balance app. That simple moment opened a whole world of knowledge and hope to me. Still, in that village of WHC, a Kenyan board-certified gynecologist who is right here shared our testimony of how hormone therapy had transformed our life. She said something that struck me deeply. We have a choice. That testimony changed everything for me. I later went to see her. I did my research, and finally I got the right prescription from a doctor at Aga Khan University Hospital. 10 months later, I can stand here as one of the happiest midlife women in this room. My hot flashes are gone. My brain fog has lifted. I sleep 7 hours every night. Yes, and that's a true story. And instead of waking up every hour, when I went to see my doctor at Aga Khan, I had a log. I was logging every time I wake up at night. I log 11:05, 12:06, 1:07, like that. I was waking up every hour, and you can imagine I go to work, I can't work, I'm tired, I'm not productive. And my energy, incredible. My productivity has soared, and I feel alive again. And that's why today, at the very first menopause conference in Kenya, I say this: we cannot be silent. Women in midlife need support. They should not pause their lives. They deserve to live healthy, joyful, and fulfilled lives. As a communicator and an educator, I'm committed to amplifying these conversations until every woman knows she has choices, she has hope, and she has a village. Thank you very much, Ruth Musembi. And as my parting shot, thank you. My parting shot is that I've started a podcast. It has debuted today. It is called Menopause. So I added the word peace because in as much as it may sound like an oxymoron, but that is what we are going for. We are going to be peaceful. We are going to be happy, healthy. We will not just live a long, troublesome life. We are going to live a long, peaceful, happy life. So check me out on LinkedIn, on YouTube. I'm going to be hosting doctors. I'm going to be hosting all of us just to share our stories because I am in the communication space. I'm an educator. And I tell you what, now I'm back to school. I had stopped my PhD in 2022. I couldn't read, I couldn't understand anything anymore. As we speak, I'm defending my dissertation next week. Thank you so much.
Well done, well done. I remember when I first met her, I think it was during the Menopause Day event last year, and you were in the corner there just trying to disappear, but you had so many questions. And I'm so happy to hear that you found help and you are thriving now. That is a true testament. Thank you. Thank you. Yes, Miss Elsie?
Sorry. Hello. You can hear me? So my name is Elsie Wandera, and in addition to being a member of this community, I am the founder of the Endometriosis Foundation of Kenya, and I am also the co-chair of the World Endometriosis Organizations. So that's the hat I will come in wearing, and just talking about that experience from that perspective of entering perimenopause because of the disease progression. So I lost my ovaries at about the age of 40 due to the disease progression. I don't have any children. Did I want children? Absolutely. But do I want them now? Hell no. It's already enough. Like, we're going through enough. I don't think that's something I want to go through. But anyway, I was fortunate enough to work with a doctor, Dr. Charles Muteshi, who one was my gynecologist, but also really just held my hand even as I entered this new stage. And I remember when we had come out of theater, he just, so I was excited because I was like, okay, so how did you fight that endometriosis? What did you find? You know, then he just held my hand nicely and calmly, and he told me, Elsie, I'm so sorry. We could not save your ovaries. And I think at that moment it didn't hit me, but it hit me later. It hit me at baby showers and at all of those spaces. That's not the point of this conversation. The point is to, one, recognize that there's one gentleman who, from a clinical perspective, who helped me get into this space. Although I have beef with him because he didn't talk to me about, you know, the cognitive changes, the sleep disruption, the low libido, the UTIs. Because I would call him, I'd be like, hey, you know, I'm having all of these UTIs. What's going on? I'm not sexually active. And can you see, like, our problem? We've already linked, like, UTIs to sexual activities. Is it necessary? No. So I'm walking around feeling so shameful, but this doctor has the answer for me. So I celebrate that, but I recognize that there is a gap from at that level with our doctors. The second knowledge gap, I think, for me, and as I talked about what I have been going through, which is endometriosis, that was a double gap. So I had to learn and do some investigation for myself about what menopause is, what are the symptoms, and, you know, like, come to learn now that I also have eczema because of this. But, you know, this was, like, when I remember talking to my mother, you know, she said, you know, there was no point of having this conversation. This is private, you know. And there lies also the generational gap. So there are many gaps at every level and at every corner we're turning. There is no care. And I loved what Honorable Njoki Ndungu said about the workplace, and that's another gap because, you know, when we're going through this brain fog and we're going through the hot flashes, there's a room, and we're celebrating, you know, organizations that are providing for women who are in their pregnancy stage and require a room to rest. But what about these rooms for the women who, like us, are going through these challenges in our most productive and reproductive years? So I think that's something else. And I think if those were the two things that we could address, I think at a policy level, But I think I love the space that we're in, WHC. I'm always sharing my story. Like me, I crack these women up. Like I share about like why, like if can we find an answer for, just improve my libido? Like I've suffered. I've already carried the cross. Can't I just enjoy this sunset years, with a man next to me? I don't want to slap him. I don't want to kick him out of my room. Can we just find something for me? So I think there is something that as a country we're doing well. We have got a community health strategy. Why can't we integrate that and look at this condition that we are calling, and I'm glad that there's this conversation at a national level. Why can't we integrate that information and empower the community health workers to actually, as they go from village to village, let them have this conversation? Because they talk about, they're doing stuff on the antenatal care and various other topics. This should be part of that. And I also would love to urge, because the people who are responsible in terms of shaping the policy are in this room, include the reproductive disorders in that in that curriculum or the information pack that you share with them. But I think the Women's Health Cafe is also great. But I think what we need to do is we need to find a place to share the information, the insights that are being shared from at that level, and then turn it into policy or something that can help the generation. Because we need to end, and I'm finishing, we need to end, we need to prevent that transference of silence to the next generation. They cannot suffer in silence. They can't suffer in silence because they're going through the period. They can't suffer in silence because their periods are painful. We're normalizing pain. They can't suffer in silence because menopause is shida ya wamama, and the wamamas are not talking about it. Can we start talking about it, and let's end the silence? I think that's it from me.
Thank you, Elsie. Thank you. And that is a challenge that I've been having. I'm like, we're doing a very good job. When you look and do surveys of the women in the Women's Health Cafe, they're all now very knowledgeable, and they ask questions and they get answers. And it's actually more a peer-led kind of space. But then I'm like, the other day somebody asked me, so can you go to Gikambura and give those women a talk in Kikuyu? And I said, my goodness, that's gonna be hard. But how do we reach those other women? And I like what was spoken to about earlier. There is an option, and we have to just figure out to get to every woman. Yes, Nimo.
Hi everyone, my name is Nimo Gedahu, or Wairimu Gedahu. I think I'm knee deep in menopause. I missed the bit when you're explaining about menopause. I also want to apologize for saying that I know a lot about menopause, because after hearing the women speaking, I don't think I know that much about menopause. I really, with Kifo Mbele, I thought I did. Now, for me, I remember, so I'm a yoga teacher, and I remember having some shoulder pain from nowhere, and I've gone to my doctor and I've said to him, I'm finding it really difficult to teach yoga and to do my daily yoga. And he says to me, here's some dawas, and took the dawas, and the pain went, but came back. And so I started really wondering what's happening for me. Kumba, it's frozen shoulder. I'd never heard of frozen shoulder. I'd heard of hot sweats, cold sweats. Brain fog was a new one, because I didn't know that as well. I think, like Honorable Joki, I thought I was losing my mind at a young 51 years old. So this left me second-guessing myself. It left me second-guessing myself and wondering if I'd somehow caused this injury, when in reality, it was my body telling me there's a bigger hormonal shift that's actually happening. That silence, the lack of information connecting menopause to issues truly left me feeling confused, unsupporting, and carrying unnecessary guilt. Now, I'm doing the questions. I did 1, 2, and 3, so I didn't write the questions, though. I have the answers. So question 2, I wrote, what would have made a biggest difference is clear information and honest conversations from healthcare providers. So if the doctor had explained symptoms like frozen shoulder, brain fog, or night sweats were part of menopause, I wouldn't have wasted so much energy blaming myself or worrying or hunting for answers. Now I work from home, so I'm my own boss, so HR policies or office adjustments don't affect me in any which way. But what I do need is access to knowledgeable medical support, affordable treatments options, and spaces where women can connect and share. That would have made the transition feel less like wandering in the dark. And thank beep for WHC. I've been told by my 14-year-old I've got a potty mouth, hence the beep. Number 3, if I could send one message to policymakers, it would be this. Take menopause out of the private nuisance box and treat it as public health. Fund training for the frontline clinicians, subsidize effective treatments, require menopause-friendly workplace policies, and run education so women aren't gaslit by the system. I would go so far as saying make it a part of the curriculum in reproductive health in schools, which I hear has been removed, I think, which is a huge disappointment, and not just for girls, but for boys as well. Because like we've seen, we need the men in this journey that we're walking. It's not just the women who need to walk it alone. And while medication has its place, and I hope this is not what Anne meant by the, what's the word? My brain fog is showing. The quacks. And while medication has its place, please don't overlook body-based therapies like somatic therapy and trauma-informed practices. These aren't luxuries, they're essential tools that help regulate nervous system, ease pain, and rebuild women's sense of connection with themselves during one of the most destabilizing transitions in their life. Asanteni sana, and tuendelee with this journey of ours of menopause.
Thank you very much, Nimo. And I have to mention, Nimo is also a psychotherapist. She doesn't like us to know that because she wants to be more of a somatic yoga trainer. But I must say that she's one of the few women, or one of the women who has managed her symptoms quite well without any hormone treatment. And it actually goes to what Dr. Atwoli was saying earlier, that there's other things you can do. There's lifestyle modifications you can do that will help improve your symptoms. But as practitioners, we meet you where you are and then try and get you to the next, right? Wairimo?
Good afternoon, everybody. My name is Wairimo Karori, and for the purposes of this conversation, I am a user and survivor of psychiatry in this country. I've had psychiatric symptoms since I was about 17. I'm now 49. And the diagnosis was finally done 15 years ago. In the 15 years, I have been on medication for about maybe 10 of those years, 10, maybe 9, 10 years, because I've taken 2 drug holidays. And the reason why I take the drug holidays, one was 1.5 years, the other one was 4 years, is because nothing has ever worked for me in terms of psychiatry, like psychiatric medication. We've tried everything. In fact, during the worst season of my mental health in 2021, I was admitted 4 times, all voluntary admissions for severe suicidal ideation. And we ended up doing ECT, electroconvulsive therapy, which did nothing for me. In that season, I went without showering for 63 days. And so for me, mental health is not a stylish diagnosis, it is a debilitating condition. I've never been able to build a career. I've run businesses that have all risen to the level of my non-functionality because we can't rise above that. I have basically winged it as a mother. I think that's the one thing that I've been able to do. I have a 26-year-old daughter. But overall, there are many things that I've not been able to do because of my mental health. And basically, after ECT in 2021, we spent a year, 12 months, with my doctor trying to trigger hypomania because the biggest presenting diagnosis is bipolar 2, and the depression is what is really, really bad. And so we spent a year with him trying to, like, I was on the strongest antidepressants possible, And by the time we gave up after a year, it was because I had been on the strongest 3 at the highest dosages without a mood stabilizer, and I was still in bed. And so I told him, this is just expensive P. I am not working. My medical bills were, my medicine bill alone, and I have a daughter who also has mental health diagnosis, was 32,000 a month. And that was wholesale, which is about 30 to 50% less than retail. So at that point I said, okay, since this is not working, let me go off the meds again. And so I've been off meds since November 2022. There are many things I've tried, because the one thing I decided when I first got my diagnosis in 2010 is I'm going to take every single shot in the dark for my health. And so I've tried everything. I've tried diet modification. The 4 years I went without medication, the first drug holiday. I had a lot of lifestyle changes. When I went into that particular depression that led me back to medication, I had been exercising for 9 solid months. I'd work at Jaffrey every day for 9 months. Like if I miss a day, it's a day or 2. So a lot of the conventional wisdom and interventions don't work for me. And so the vicious cycle has basically been depression, which leads to non-functionality, which leads to lack of productivity, which leads to financial instability, which leads to depression, because financial instability is my biggest trigger. And so there are two things. There are many things that made me take the MHT shot in the dark. First, Bugo knows that she's the only person who could have gotten me to look at menopause. I said, we shall do this, we shall ignore it, we shall close our eyes, it shall pass, and then we shall go back to normal. But when I joined WHC, I started interacting with the content, but I never really followed up. Now, one of the biggest impairments is actually cognitive. My executive function and my cognitive faculties were at almost 0. And what I mean by that is, in one of the times that I went back to school to try and finish my degree, I was on a university quiz show, and we were first runners up in Africa. But a couple of months later, and for the past about 13 years until very recently, I'd walk into quiz shows and my brain is completely blank. And I realized that is actually one of the reasons why it took me so long to try and finish my degree, because I'd walk into an exam room and I know this stuff and I cannot remember anything. So the cognitive decline for me has not just been in the past, like say 5 or 6 years. It's been for a long time. So the reason why I decided to try MHT is because, one, my daughter, who has mental health diagnosis, has PMDD, which is basically a mental health diagnosis caused by reproductive hormones. And so I thought to myself, if we share a lot of genetic material, and this, she has mental health issues that are based on her reproductive health, which is terrible, maybe this would work for me. The second one was a conversation I had with somebody who is in the queer space. They're a trans person, assigned female at birth, and they were transitioning from assigned female at birth into male. And so they were on hormone therapy which was testosterone. And they have about maybe 10 mental health diagnoses. And so they were actually doing very well on testosterone. And then they stopped the testosterone because they were getting secondary characteristics like a deeper voice and a beard, which they didn't want, and also because of the cost of the testosterone. And within less than 2 weeks, they had crashed, they had even lost their job. Like they were completely non-functional. So I said, okay, if that person's mental health is being affected by hormones, maybe this is also something for me. And so now I'll share my experience on MHT. It's been 3 months. We hit 3 months on Monday. Because of all the things that go with debilitating mental illness, I had to start on the cheapest, lowest band, which is what we call sequential, which means that you take 14 days straight of estrogen, and then you do 14 days straight of progesterone. Now, Kabugo and my family pharmacist and my best friend, my daughter, are watching in fascination because the estrogen pushes me into a depression and non-functionality. And the progesterone throws me into hypomania, including hypersexuality. In fact, I hadn't figured out what was going on with my body. The hypersexuality is the one that gave me an inkling, because that comes with hypomania. And so I was like, okay, this is actually something that is affecting across that way instead of this way. Like the MHT is actually affecting whatever Professor Liko was calling my brain soup. Yeah? And so the other person who really inspired me when we had a conversation was actually you, Ruth. Because when you told me that you had actually had to defy your PhD and then you had gone back after being on MHT, I think the time we were talking about that, you'd been on it for 6 months. I said, okay, maybe even all the stuff that I've been unable to do with my brain, maybe this is part of the solution. Because if I wasn't holding this paper, my brain would be glitching. There are actually times when my brain glitches to the point where I'm giving a presentation, like in some of the work I'm able to do, and I cannot remember what I was meant to say next. And it's not a memory issue, it's that my brain has completely blanked out. So what I'll say is we need more accessible information and MHT. Because you see, you can imagine if I didn't have the knowledge I have, because I say I'm my own best doctor, I'm the one who knows what goes on in my body. If I didn't have the knowledge that I have, I can't imagine if someone is put on MHT, maybe has a latent mental health conversation going on there, and it completely ruins their life because nobody's looking at the mental health. So there needs to be a lot of integration of the disciplines. The second thing, and this I think is for a lot of us who are, I guess most of us who are perimenopausal or menopausal are older, but I also know that there are people who go into perimenopause even at 30. The one thing I'd really encourage you to do is please ditch sugar. Like, I can't say it any other way. Because one of the things that happens for me is ever since I got rid of, actually, now for you guys I'm saying ditch sugar. For me, I'm saying I ditched carbohydrates. Yeah, like I don't take any carbs at all. And what that has done is, I think it was you, I can't remember your name, who was saying how the visceral fat, that's the one thing I've not had to deal with. I actually have no lifestyle illnesses. I don't have diabetes, I'm not pre-diabetic, I am not hypertensive, my heart is perfectly fine. And for a woman who's 49, that's a bit unlikely. So ultimately, I'll say that the disciplines, especially now in my corner, mental health and probably gynecology and endocrinology, need to sit and have a conversation, because when you look at these things in isolation, they don't make sense. Yes. But if you try and say, okay, because menopause has a laundry list of like 70 symptoms and they keep growing, yeah? So if we can look at those symptoms and maybe try and figure out which ones could be affected in which direction, we'd maybe do more. The other thing that I'll say is we need more menopause advocates within the mental health space, because I'm in a lot of mental health groups by virtue of the fact that I've been in that world forever. And I feel like there are so many women who've been left behind. Some of them, the diagnosis comes back as fibromyalgia. There are all sorts of things going on there. And yet, if this is the solution, like if I do another 3 months and another 3 months and we get to a year, and I find that, let's say, 70% of my symptoms have resolved, I think we need to take a look in that direction. Yeah.
Thank you, Irimo. I forgot to mention that the Women's Health Cafe is a gender-safe space. I think she mentioned something about that. Yes, we are a gender-safe space. And thank you for that. Wairimo, I wish you all the best. We are walking this together. Thank you. Yes, Mokami.
Hi, everyone. Good afternoon. My name is Mokami, and I want to talk about, I know over here it says menopause, turning the pause into applause. I want to talk about menopause's younger millennial sister, perimenopause, because I see a lot of younger women in this room who probably think, I have time. People are talking about their 50s, people are talking about their 60s. We will deal with this, or science will have caught up by the time I get there. And so I want to share my experience regarding that. See, the thing about perimenopause is that it sneaks up on you. There is no test. You go to the doctor, there's nothing, there's no one day you're like, this feels weird. It's just a slow, gradual accumulation of symptoms. So in your mid-30s, maybe your early 30s, maybe your late 30s, all of a sudden, you're waking up at 3 o'clock in the morning. That's weird, but maybe you're stressed, work, whatever, right? All of a sudden, your periods are a bit heavier. That's not a problem. That's another problem. All of a sudden, you're gaining a little bit of weight that you weren't planning on, right? It's a slow accumulation of symptoms, and it's very hard to accept what's happening. And this is what's happened to me and all my friends. I still have friends to this day who can't remember my name, and are saying, I'm not in that thing. It's something else. I'm tired from work. I don't remember your name because I'm tired, not because I'm in perimenopause. And the other thing about this, the stage at which it happens is when you're at the prime of your life, right, as a woman. So you've probably gotten the job you want, you're financially where you want to be, you're at the top of everything, right? So all of a sudden, you are not able to concentrate in the office, and you're now a director, you're now CEO, you're now manager. You're wondering what is happening. This is when I should be showing them what I can do. And then all of a sudden you're like, I can't sleep, I can't focus, I'm tired. All of these things are just a slow, gradual accumulation. And it sucks. That's really, that's really it. So what happens? What did I do? A lot of my friends, what did we all do? We just go into denial, because this is something that happens for your mother's generation. We're just in denial. This is not happening. For one of the reasons we go into denial is because there's a lot of age stigma, right? The other thing that's really hard to accept is that you are aging. You know, some of us just thought that we would reach 38 and just pause. We would just, and then one day we'd be 60, but we'd be exactly the same from 38 till 60. Something would happen at 60, I don't know, a switch would be turned. That's not what happens. There's also another group of us that are still child-free or want children in our late 30s and our 40s. So how can you tell me that my fertility is declining, my estrogen is disappearing, when my mother does not have enough grandchildren yet? And she reminds me all the time, right? How can you tell me that these things are happening? The other challenge is that, I don't know if it's the same for some of you, but for my mother's generation, this is something they never talked about. So my mother doesn't want to talk to me about menopause because she can't accept that I am now an old woman, right? And I'm not an old woman, I'm a baby girl. We're not having this, you know? Exactly, I told you, we're baby girls, but it happens to baby girls as well. So one of the things that is sadly, as you start learning about this, you're now facing the denial, you're saying, hey, something is happening. There isn't a lot of information out there. One, because the information is targeted to women in their 60s. Two, because science just hasn't caught up. For some of us that are younger, I want to go to a doctor and I want to take a test for my hormones. And I want that test to say, at this stage you're perimenopause, at this stage you're menopausal. That doesn't exist, people. If there are women in STEM here, please help us develop these tests so that by the time some of you in your 20s are there, this test will exist, but right now they don't exist, right? So because there's a lack of information about all the symptoms, there's a lack of information even at the hospital level, at the doctor level. You come in, you complain of sleep, they say, maybe you're just tired, maybe it's work. They're not connecting the dots, yeah. That is perimenopause. So what do you do? I'm here to tell you, especially the younger women in this room, there's a lot of hope. You can fight back. Do not take this, do not hear this word aging and start freaking out and start buying, you know, creams and lotions and trying to get liposuction. You can fight back in many ways. Personally, I started researching a lot of natural therapies just because I don't think I can afford HRT for the next 15 years if it's not covered, you know, under a government health plan. I just don't think that's manageable. But you can do things like really focus on your sleep. You can do things like focus on your diet, unfortunately. Things like alcohol, you'll have to cut. Your body will let you know, by the way. Anyone here who knows, your body one day will just say, we're done with alcohol, and then you just have to accept. I can see someone's head going down, yes. But you can fight back. Community is really, really important, and this is what's so great about Women's Health Cafe. Have this conversation with your friends, have this conversation with your aunts, have this conversation with your moms, and get ahead of this. I think the disservice that our parents' generation did is that this was something that they hid. This was something that we hush-hush, we didn't want people to know about because there's still stigma about aging. But we can still keep glowing up even with this. This is just part of the journey. It doesn't mean that all of a sudden we've turned, you know, gray hairs are popping out on our head. So that's my story.
Thank you. Thank you, Mokambi. So those are the representatives of the Women's Health Cafe. We have very many stories in that space. I want to tell you how I became a menopause practitioner. It is an opportunity that we got from the Menopause Society, which is formerly North American Menopause Society. Like I said, I'm licensed in the US. They gave us opportunities as healthcare providers to get educated and be members of the Menopause Society. So the opportunity is available to physician's assistants and up. So we have neurologists, we have urologists, we have anybody who wants to take an interest and wants to specialize in the menopause space. So that's how that came about. But I think that is something we need here as well. We have a group, I don't know if people know, Dr. Monda has a menopause clinic, right? Nairobi Hospital in Gigiri, right? And Dr. Monda is one of those doctors who has given herself to not gaslight women anymore. I tell doctors, when women tell you they are feeling, believe them the first time. So Dr. Monda runs a clinic. There's also a clinic at Kenyatta Hospital. Do you guys know that? There's a clinic at Kenyatta National Hospital. I think it's on Tuesdays. But those doctors and the pharmacists and at Kenyatta Hospital and we got together and we are trying to register a menopause society. We've been trying for 4 years. We can't. What kind of question is that? This is Kenya, right? We are stuck. We are stuck. So I'm saying this out loud so that people can know. Because once we can form a society, we can get organized, we can get to training women, and talking to women, training healthcare providers. I find myself teaching a lot of doctors lately because there are those who come to me and they say, oh, don't you think 36 is too young to be... I'm like, what do you mean? I give them my story. My story was at 37, I used to work in distribution and I used to go and train nurses and teachers and doctors in around the country. I was coming from Meru. I was wearing scrubs. It was a very hot day. And I had this issue with dehydration and I thought, oh my gosh, I think I'm sweating too much, right? It was very hot. And as I got somewhere near Sagana, my heart started beating like it was coming out of my chest. I seriously thought I was dying. And so I pulled over, I said, if nothing else, I'll take a cold bottle of water and an aspirin and see if I can get home. I'm in Sagana. So I took that and immediately I felt better. The cold water, I don't even think the aspirin had time to do anything, but the cold water itself just stopped it. And then I came to town and I got home, and the next morning I went to see our dear friend Jackie Kitulu. And I told her, Jackie, I was dying. Yesterday I was on my death. I was driving and she was like, okay. So she plugged me in. She told me, well, there's nothing wrong with your heart. I said, you're kidding me. Yesterday I was dying. And then she said, well, if you feel better, go see a cardiologist. So I went to a cardiologist and he plugged me in and he said, there's nothing wrong with you. And I said, this is serious. So I left there feeling like I was the crazy one, okay? I was 37. And then, fast forward, 38, it happened again. This time I was home, I was alone, but there's no pain. It just starts beating funny, you get faint-headed, and And I said, I just need to sit long enough. Fortunately, I lived a walking distance from Nairobi Women, so I went in there and I was like, somebody needs to check my heart. And the cardiologist came and plugged me in and said, there's nothing wrong with your heart. And I said, this is the second time it has happened. I thought I was dying, but how do you tell me there's nothing wrong with my heart? It didn't happen again. I think it happened again when I was about 42. And then I was like, I'm sure somewhere down the line, someone's going to tell me something's wrong with my heart. So last year, for those who know, I had to take my friend Ivarita to India to get her heart fixed also. And while we were there, I said, let me do another, those executive checkups. And they go and they plug me in and they say, your heart is perfect. And I said, now, for me to have connected those dots, and then someone who's 37 comes and tells me, I'm still too young, you have no idea. So that is my perimenopause story. And we shall invite Dr. Korir here to help us with stuff today.
Good afternoon. Good afternoon, everyone. I want to see if there are any questions to these good ladies here before they can. So one here, I'll take two before we go to the interesting part of what media can do. Any other person? Okay, we'll take this question here. To any one of them, and then, yeah.
Can you hear me now?
Yes.
Okay. So my question, one of the questions I have is, what do you think is holding back the integration of menopause into everyday's primary health services? And the other one is for the stories you've shared, and I've loved the stories you've shared. I'm gonna be telling them when I get out of here. So the question I have for you is, what was the most challenging part of your menopause journey? And did you feel like the health system was equipped well enough to be able to support you? Yes, thank you.
You wanna take that?
My name is Nderitu Lona, youth advocate at RHNK.
Should answer and then, yeah. So the hardest part for me was I have a 14-year-old daughter, so menopause, puberty, I'm going to get the book Honorable Njoki was talking about because, yeah. Bugo will tell you, these people who wake up bouncing from bed and just consistently smiling or happy. But a few years ago, I'll say about maybe 7, 8 years ago, I was so angry consistently, and I didn't know what it was I was angry about. And it went on for a while. The yoga helped, but it didn't help as much as I wanted it to help. And then, Gafla bin Vu? My daughter hits puberty. And so there are these two females in the house who are like two lions fighting over a male lion or something. We were really just not getting along well. And I had not understood that it had to do with menopause. In fact, like I was telling Buga earlier, I was blaming my child. I was like, she's a problem with her puberty. So, you know, and I think for me that has been the biggest problem, because I became someone who I did not recognize, which was really, really scary for me. And this is why I was talking about, we need to bring these conversations into schools for both boys and girls, so that they're also understanding what's happening. But also, so as we grow up, I'm grown, but as we grow up, we understand what it is that's happening to ourselves. And so we're not gaslighting our children, but actually understanding and being able to walk this journey, and for them to also understand what's happening to mom, so we're not being called terrorists. But yeah, so that's what, for me, that was one of the harder parts of menopause.
Can I speak from an advocacy perspective? And I think there is very little information documented about the number of women who are suffering with menopause, amongst many other conditions. Endometriosis, we know that these are issues that are very underfunded, under-researched, and therefore we are underrepresented in the global data. And therefore that means if there is any solution or any problem that is being solved, we are not included. And then another barrier is the fact that the health system does not address or come up with a life course solution. So that is the problem. So we are providing solutions for the girls in puberty. You know, there's talks about that, there's adolescence interventions, but then we're not helping the women who are transitioning into this stage with the information. And for me, I think that's where I would love for us to do more, is document. Let's gather the data so that we can go to the policymakers with the data, talk about how this is not only a health issue, but it is also an economic issue. And once we figure out that, you know, women's productivity is actually affected, then we'll translate that into now, can we get something done to protect, I guess, the economy of the country? That's my take.
Actually, that is the goal. I'll tell you that for us to include it in primary health care, for us, I'll speak about the US, we are now requiring that GPs, all fresh graduates, all medical students have to learn about menopause, and menopause needs to be treated at primary. care. So, which is what I hope we can do. I mean, we are so many women. 50% of the population is a lot of women. And so we need to be able to get this help and this information at the very basic. So all GPs will be required to be treating menopause, and then after that, for the referrals, will be then the specialties after that. But I think that's the only way we can train.
Thank you very much. Everyone is looking at me badly. So let's give these women a very warm round of applause for sharing their stories, sharing their lives. We appreciate them, and we need to hear more of that. Oh, they'll need to write their
yeah, and also a
commitments.
group photo.
Oh, and a group photo.
Yeah.
Okay.
Sorry for that.
Okay, you want them to take a group photo now?
Yes, please.
Okay.
And then they can sign after.
Smile for the cameras up here on stage. Bugo. Smile for the cameras. So as they take that photo, I stand here as media and so advocacy, and I have a few questions that I just want to gauge what we know about, just women's health, even before we go to menopause. Kuna watu hawaoneshi meno. But thank you very much. Let's appreciate this lovely, lovely women. Thank you. So now I have very, 5 questions, which we'll just do by acclamation. Does anyone here know the first time when researchers were required to include women in research? Yes? 1993, correct. Let's appreciate her. I suspect you'll know the answer to my next question. Do we know the year when researchers were required to report findings on research, like when they do research, men and women, to report women-specific data from their research? Do we know when that was? If that was 1993, when were they required to give the data from women? Much later, yes, it's much later, but when is that? Prof. So I'll tell you, 9 years ago, that's 2016, it was required. Now, by NIH, 2016. So it means for a better part of women's existence, we were not part of data, part of research. Now, do we know the amount of our lifetime that we spend in poor health as women? You're saying 50% all the time? Hi, Justice. So a quarter of our lifetime, 25%, we spend in poor health. Only 25%. Okay, 25%. No, globally. Global. So Chief Honorable Justice is correct. She's saying all the time, 75. Okay. Now, in terms of the money spent in research and development globally, how much goes into women's health? How much? Who wants to hazard a guess? All you're asking me how much? How much money in research and development is specifically spent on women's health? 3%? Almost 1%. 1%. 1%. What does that tell us? We don't care. It's not a priority. Women are invisible. Zero attention. Women are not in those decision making. Now, the last one. Do we know how much, well, in percentage of data is, or, well, let me not say data. Say the drugs that are being researched, how much of that is known to affect women during pregnancy, lactation, during that period? Prof? Yeah? So, when they're doing research on medicines to see side effects, blah, 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 how much or what percentage of that is done on pregnant women, lactation, so as just to know, 1%, 0%, 10%. So it means 90% of the medicines we take, we don't know its effects on women during pregnancy and lactation. So the reason I'm saying all of this is just general, women's health. Now, when we come to menopause, what would those numbers be looking like? Almost non-existent. And I hope now you see where we come in as media, because what are we talking about when we don't have that information? Yeah? Remember that as media, we are part of this society. I usually say media, for me, how I usually see journalism is it's a gossip industry. It's what Wala knows, what Justice knows, what Meta knows, and then I put it together and tell all of you. But if that information isn't there, then what am I talking about? What do I talk about? We've seen here, the confessions, if I may call, of how difficult it is to have those conversations. I can tell you for free, I have never had a conversation with my mother about menstrual hygiene, about the menstrual period, nothing. We are not going to have any conversation about sex. Zero conversation about menopause. And we're in this society, so if we're not having those conversations within our houses, how are we going to have those conversations in the media space? My name is Dr. Mercy Korir. I am, on a regular day, a journalist. I'm a trained medical doctor, and I see myself as practicing medicine differently by amplifying these stories like the ones we are having here today, by giving people a platform to have conversations that are not clickbait, as we are in this current generation, but conversations that enrich and can drive policy. And we do that through Willow Health Media. We are a digital organization. We are 1 year old, and our work is purely dedicated on reporting and talking about health and health issues. And my questions coming here was just one with sub-questions about why is media silent on menopause? And I have sort of painted the scenario that even from a media perspective, we don't have that information. From a medical perspective also, we don't have that information. When we were training us in medical school, we just brushed through menopause. These are the signs and symptoms. When it comes to your Q&A, you make sure you get it right. When you go to the Viva questions, you're facing prof, you make sure you have ticked. I don't remember us ever discussing treatment, management. How do you support women? It was, you know the symptoms and you move on. So even as medics, we don't have that information. So media is not going to have that information to put out there. So that awareness alone from a media perspective, and even just starting from a medical perspective, is really important, because we tell the stories of society. We tell your experiences, and so if we are not hearing them, then it will not make that headline or get that airspace. And then we're in a society about taboos, stigma, like we said, like Prof said, you're 60, why do you want to talk about sex? Like, it's your sunset years, your time is up. So we are also in that society where we need to break those cultural taboos and stigma so that we in media are also able to overcome them and be able to talk about that. And then there are gender stereotypes about women's bodies, what we go through, that you don't want to talk about, or even when you're talking about it, you're just emphasizing that bias. You know, women are supposed to be like this, and so that's how we've always done it, and so that's how we always are reporting about it. Then the bigger issue generally is health is not usually a priority topic in, let me say, mainstream media. I say mainstream because on social media we talk about many things and everything. But unfortunately, and we were discussing this the other day, in our digital spaces, when we are talking about health, we are just talking about only sex, and we forget the overall health issues. So in mainstream, health is not a priority. I can tell you, when I was in mainstream media, if I had a really good health story, and then that day one of the politicians says something, it's not getting airtime. No, it's out. Or they're calling a press conference, it's live, and your story is supposed to go, that story is not running. So it's about time that we also start prioritizing health, because we know really a healthy society is a productive society, but it starts from this room. And why I say it starts from here is when we are not available to have these conversations, then media will find somebody else talk about other things. As we say, nature abhors a vacuum. So when people want to talk about this, and I reach out to Evelyn, then Evelyn gives me her list of an availability for the next 2 weeks. News has to happen. The newspaper has to be sold. You know, people have to tune into radio. What happens? Somebody else will occupy those spaces. So we need to actively make sure that we are occupying those spaces, because I'll tell you, media is always looking for content, for stories to tell. And if we are available there, then we are able to change that narrative. So how do we do that? And I'm happy that I have been invited here to speak. We have to include journalists in these conversations. They have to be here as active listeners and participants, not to cover. It's good to cover, but when they cover, you're looking at, have I gotten a sound bite? I can tell you for free, I'm almost calling you Chief Justice. Maybe I'm manifesting. I'm manifesting. So Justice Njoki will definitely make news today, because media was here, you know, and that gives us an opportunity to be, you know, to be in those spaces, because we have the right newsmakers here. So apart from having journalists cover this conversation, can they be active listeners to learn, to listen, to just come and have a one-on-one with Prof to understand some of these things so that they have a good grasp? And also, specifically, and this I'll challenge Evelyn, Angela if she was here, Nelly, train, you disappeared, you're my table mate here. Train journalists on women's issues, not just menopause. Train them, you know, call them for these workshops. For my almost 10 years now in the newsroom, we have very good people willing to tell these stories. But sometimes they don't know who to talk to. They don't know who to ask this question. They don't know if they're available or if they'll give them time. So get them, train them to understand more about women's issues, about menopause. Safe spaces for conversations like what Bugo has with, you know, the Women's Health Cafe, and I'm happy that, you know, we have women willing to tell their stories. And journalism is about storytelling. If I hear the story of Werimo or Mokami, then I have something. Like I said, journalism is gossip. Then I'll have that story to tell somebody about, this is what she was experiencing, this is what Prof says, this is what can be done, and it makes for a good story. So if we have those safe spaces where women can tell these stories and we amplify them, then we'll continuously change the media landscape. There's a lot of misinformation. I don't know if it's you, Prof, who was talking about misinformation, disinformation, all of these things, especially in this day and age. I saw that a lot during COVID on WhatsApp. A very long WhatsApp message is sent by, according to Dr. So-and-so, and then it goes to Group ya Chama, how many women are there, and they believe it. My mom had refused to be vaccinated because somebody from India said many things, yet it was fake. Can we as medics be willing to challenge misinformation actively? Don't wait to be called out, because all of these things, we're in these spaces on social media, on our WhatsApp. Let's challenge misinformation as much as possible. Let's even call out journalists. If I have reported on something that is false, call me out and say, you know, this is wrong, this is what is right. Because that's how we learn, and that's how we advance good information, good conversations. And then lastly, is to highlight positive aspects. Chances are you don't watch TV, but I'll just ask, how many of us watch news? Sometimes, okay, Doc is saying very depressing. You do not. Why is it? Why politics is too much? Why don't we watch news? Same old. Deaths. Yeah, like when you tune in, sometimes story 1, somebody hacked somebody. Story 2, yes, somebody did something wrong. Somebody was stealing something. It's always just negative. Yeah. So can we actively populate our airwaves with positive stories, like the women we've had here? Like, who doesn't want to have a feel-good story? Something that makes you feel nice, encouraged, you know. When you hear Ruth Musembi's gone back to do a PhD, she's defending, we're all happy. Everyone wants to hear a good story, because it's the nature of human beings to be hopeful, to want something good. So let's continuously see the good in the things that we do and amplify those ones. I know the journalists here will tell me the training in journalism school is you're told if it bleeds, it leads. But we need to change that narrative, because we need to give hope. You know, we need to amplify those positive aspects of stories, and only that can come from the people here and from the people that, you know, work with the people who know, because that gives hope. Even Prof's narrations, they were hopeful, there was hope. Even when Jen was saying he's trying, I'm saying mercy for him, all of you are feeling, yay, it's going somewhere, right? So everyone wants a good story. Then the other thing was on language and framing, and this also comes to just, you know, the positive aspects. Yes, it may start out badly, but there's always something positive at the end of it. So we need, as media, to just change how we frame the language, to have the positive or the silver lining in the conversations come up, as opposed to just saying, you know, it's bad, then people become hopeless. And then we need to have empowering language that is inclusive, that really highlights positive aspects as much as possible. And for many of the people know here, as a journalist myself, who's a medic, passionate about advocating for health, I'm always open to amplify these stories, because I consider myself being in a very privileged position, having a platform that can talk about health, influence policy in a way, drive policy in a way, hold people accountable. So I'm happy to always, you know, be working and having conversations. I'm seeing a few people here that have promised we'll have conversations. I promise we will see these conversations pull through. Dr. Riwala, I beg to close there. This is the time you clap for me now.
Thank you so much, Mercy. Do you mind signing my commitment form? Yes. I want to know, by a show of hands, how many of us have ever gone through a media training? Okay, so Dr. Korir, your team is here. Where's Willow Health? Willow Health team, you're here? Please take note of those hands. Put up your hands again. So all these people are available for stories. So I am sure Willow Health, you will not lack. And at my left side on your way out, there's a whole, let's start with that booth, yeah? Let's start sharing our stories. And thank you so much, Dr. Korir. It's amazing to hear the statistics on research on women. It's a very sad statistic. But I don't want us to end on a sad note, yeah? Because you're going for lunch. So we are turning the pause into applause, yeah? So we are turning all these stories, all these experiences into something positive. And that's the gear we want to come with in the afternoon, because you're saying, okay, we've had all this, so what? My chats are still empty, please. I invested in these things, imagine. Don't let me go back with them empty, yeah? They're just very simple questions. They're flip charts. I mean, they're sticky notes, marker pens, one word each. Commit to doing that for me, will you? Thank you. So lunch is going to be served at Ladder Restaurant. It's on ground floor. You'll be guided. And there'll be vouchers. So it is 1:10. Let's be back by 2:10, because the afternoon session, we've disengaged from the medics. We're giving it over to the anthropologists. Asante sana, and see you in the afternoon. Thank you.
When the symptoms of perimenopause began, she didn't have a name for it, just symptoms, just confusion about what was happening to her body. There was no nurse or doctor to explain what to expect in a language that she could understand. No one to ask, and no answers given. It was just her, alone.
over to Good. So, number one, someone needs to. Okay, I have secretly Googled menopause symptoms at least once. Secretly. Secretly, no? Okay, we have two people there. Okay, second statement. Someone I know is going through menopause and I have no idea how to support them. Wow. Okay. I think Kenya media has not done a good job talking about menopause. Okay. I would be more productive if my workplace had menopause-friendly policies. Okay. Yeah, if you're neutral. I wish someone had talked to me about menopause earlier in life. Okay. If hot flashes were a person, I'd block them. Okay, and the last question. I feel more confident talking about menopause after this morning's session. Wow, thank you. And thank you for that vote of confidence for the morning session panelists. Asanteni sana, we may be seated. So is there anyone who's joined us apart from Shimiwa here? Anyone who was not here with us in the morning? Karibu sana. Oh yes, and sorry, Betty. So karibuni, we've had a very energetic, hopefully, energetic first morning where we had introduction, and then we had lived experiences, and then we had the experts also on the panel. And now we are moving gears towards what next. Because I think it's very easy to state problems and keep stating problems, but we need to have solutions at the end of the day. So we are going to have Professor Olunga to come and take over this session. He's an anthropologist, and he's going to tell us more what that is. It's the study of what? Thank you.
Thank you, Amakove. Good afternoon, everybody.
Good afternoon.
I did not want to bring much attention to myself because my topic or something that affects me, anthropos, is not on the menu. So first of all, I think anthropology is the study of humanity in its totality. I'm an anthropologist and a gender study professor at the University of Nairobi, and I'm happy to see quite a lot of faces that at least I can identify with. I have a panel of eminent persons. Mine is first of all to request the panelists, please step forward and occupy your seats at the podium. Honorable Millie Odhiambo Mabona. Dr. Josephine Kibaru, Honorable Betty Maina, and Dr. Sheila Kioi. Please. You know, sometimes I and Osuru, we've been accused of getting our noses into women affairs. And sometimes when you are enlisted on a board, people ask you, what are you going to talk about? But let me start just a small story. Some couple of years ago, I mobilized a number of my friends. There were 6 in number, and I asked them to come along with their spouses, and we went to Watamu to celebrate my 50th birthday. And when we were on the fireplace, I think I'm the one who started the conversation and said, menopause, I think is a very bad thing. And I think we need to understand it. And sometimes I think there are hormonal changes that make it very difficult for the girl child to respond to stimuli the way it should be. I'm telling you, the debate became worse. My wife interjected and said, have you ever read anything to do with andropause? And my friend's wife, unfortunately, my friend passed on, Julia Zamba, the wife said, I wish you guys had read andropause. It's worse off. And we tolerate you people with that andropause. And yet you people can't even understand a little of menopause. Welcome to our session, which is basically on from heat to policy. First, I need to let you understand that before you, I do not know that I do not have the right adjectives or verbs to describe Millie. What I know is that she's a lawyer, she's a child rights advocate, she's a legislator, she's an author, and above all, she's somebody who believes in the rights of women. Minority, the rights of the marginalized. And above all, again, the ODM. No. Okay. Millie calls herself bad girl, but I choose not to call her bad girl. She's just a girl who questions. Now, let me be the anthropologist. She's just the girl who questions customs. Now, I don't think I need to introduce Millie further. Next is former cabinet secretary, a long-serving member of the professional society, the private sector alliance. And sometimes when we brought her on board, we thought we'd ask her questions on policy. And she said, despite or in spite of my position at the moment, I will still be able to react on the basis of what was set for me. But just in case you see that disclaimer, you will be able to excuse us. Please welcome Betty Maina. Next on the podium, if anybody went to medical school and branched on the gynecology, on the obstetrician, and you are never taught by her, then please check again which university you went to. Or if you've never heard about her, or you are within the medical sphere, in the medical profession, and you've never heard about her or never seen her, please recheck your degree again. It may be snatched away from you. They may accuse you of having gotten it from River Road. None other than Dr. Josephine Kibaru. Please, a round of applause. And in the morning, you also had flashes of accusations to the insurance industry. But unfortunately, today we have not just an insurance person, but a medical doctor working within the insurance sphere. And therefore, I believe that our deliberations that we've done here in the morning, and more particularly talking about insurance, they're already getting to their rightful ears. And that maybe policy dimensions will have to change. Please welcome on board Dr. Sheila Kioi. Well, now back to the situations of the day. I don't think I want Millie to stand from where she is, or unless you really want to see her, but the podium is raised. So Millie is going to start us off. And Millie will be talking about advancing menopause care through legislation and equitable funding. Sometimes I don't want to be the chief whip to say Millie will take 20 or so minutes. Millie, as you can see, we are 4 panelists. We have 2 hours, and those 2 hours includes answer question session. So through your, may you do a little arithmetic just to see how much time you need so that every other person you already have the questions. I don't need to repeat them. Please welcome Millie.
Thank you and good afternoon. My apologies, I wasn't here in the morning. I had actually hoped or intended to be here, but I recently went back to school, so I have a lot of homework. I had somebody speak because in between doing my homework, I was getting in and out of this meeting. So I had somebody talking about going back to do her PhD after her menopausal issues were sorted. And I actually went to do my PhD, not to sort out menopausal issues, but also that was a factor. It was not to sort out menopausal issues, but I was told part of if you do something new, it actually helps. So if you learn a new skill, if you learn a new whatever, and if you read a lot, it helps. Especially because you are talking about, what were you calling it? Brain? The brain fog. I have maybe a little of that. I don't know if I would call it a brain fog, but it's whenever you're talking about menopausal issues, because it has to do with, age as well. So when you're talking about menopausal issues, aging also comes into play. So I look at, when we are told about carry your hands, if you have looked at, thank you, you're wise. You know I'm struggling. If you have Googled secretly, and I've not Googled secretly, I Google very, very openly because I need to know what goes on. And I want to just thank you for warning me. In part of my classwork, I was given an assignment and we were told 3 pages. And by yesterday, we were giving it yesterday and I was at 18 pages. And the deadline was in 2 hours. Thank goodness for AI. I was told some app that summarized for me in about 5 minutes my 18 pages. Unfortunately, the app will not help me right now. So anyway, what I'd want to say is that part of the reason I was really torn of being between class and out is because this is an issue that we need to talk very openly about, menopausal issues. And I think you have heard me once in a while in Parliament. When people raise issues, I tell you, quit bothering me, I'm menopausal. Not only because I'm menopausal, but because I want us to start talking about menopause. One, because it is stigmatized. And part of the reason that menopause is stigmatized, it's because it's also attached to what is seen as sexual prowess. And so when women are seen not to be able to be excellent at having sex, then people want to reduce your worth. So you are told you are not worthy because now you can't have orgasm, we kind of want to be equated with the Harambee Stars. Like you'll be given 1.5 million for every goal. And that's not what we are about as women. Whether or not I get my orgasm, I'm still Millie, I'm still the bad girl. So I would love to have the orgasm, but even if I don't have it, I'm still me whole. So part of the reason I want women to speak about menopause is don't feel any less. Because you can't perform. In any event, we performed very well. It's just that there was nobody filming us. If there was somebody filming us, President Ruto would probably have given us more money. But because it was not a public event. So if you are slowing down, it's normal. It's okay. But if you still want to enjoy, I'm glad that there were people here who spoke about many, many issues. But one of the things that came out here is that we are all not homogeneous. From what I was listening to the earlier morning sessions, all women experience menopause very, very differently. And we were just whispering there, and Honorable Njokindungu was saying, I had incidents of hot flashes. I've never had, though I started my menopause very early, because I had fibroids, and after my fibroids were removed surgically, my period stopped. And because for me, my greatest nightmare was my periods throughout growing up, right from high school throughout my entire life. Every time I was having my periods, I would be admitted to hospital. So I was in hospital 12 months a year. And every time I was told, you have aborted. You know, every time I was admitted in hospital. So when my period stopped, I was very happy. I didn't care what the impact is. I was just happy that they stopped. So after maybe about 2 years, I didn't even link it to menopause because I was in my 40s. So after about 2 years of my period stopping, then they started again. And I'd heard before, you know, sort of casually, not as sitting like this serious what we're having here, that could indicate cancer. So I ran quickly to my gyna and I said, hey, I think I'm developing cancer. So we had to go through many tests. Then he told me, you are perimenopausal. I'm like, what the hell is that? I had no clue what perimenopausal is all about. That is how bad it is. And I'm a lawyer with many degrees. Na sikuwa nimesikia perimenopausal. So now what about other women? How many of us have never had? How many of us have no clue? I'm just asking Betty here. We guess. We live by guesswork. I lost my hair very, very early. And me, I said I attributed it to chemicals, which partly is true. Then somebody told me it's also because of your hormones. Isn't that now also a menopausal issue? Even though I don't think you talked about hair loss. If you see my hair, it's just that I'm very creative. Lakini my hair inaanza huko nyuma. If I didn't have this microphone, I would have shown you where my hair starts from. And sometimes you see a lot of women with bald head, and you're like, wow, you are so creative. Sometimes they are not creative, it's just menopause. And you are tired of trying to wear wigs and do all manner of things. And you say, what the hell, let me just stick with my hair open. So now for a lot of us as women, those are issues that we go through. When I was in high school, we sang a song. I wish you all those I would have sung it for you, but it won't make sense. But as part of competition, when I was in a school called Angala Girls, and I remember in that song it said that when I was younger, my grandmother took us to a hut, which was called Siwindenyiri, the girls' hut. And in that hut, we were taught many things. We were taught about sex. We were taught about reproductive issues. We were taught about marriage. But guess what? That Siwindenyiri is no longer there. And I listened to a lot of you here talking about my mother didn't talk to me about it. Because that's the way she was socialized. She was socialized that it is your grandmother that would talk to you about these issues. But where are our grandmothers? Our grandmothers are in Ushago, we are in Nairobi. When will they tell us about these issues? And even then, our grandmothers wouldn't put you like aside. They would be putting within a communal, system. My mother was a trained nurse and social worker. Yet when I first had my menses, she didn't have the words to tell me. She only bought me Seventh-day Adventist books on becoming a teenager. So and I thought it was a bother reading. So I didn't even know how to deal with having menses. But my mother was a nurse. What I'm saying is that we actually have a gap. And I'm glad that we have such forums, that we must start talking about this. As a legislator, getting to my core issue, I've actually brought a bill. Many of you have seen my bill, which has been under discussion, which is assisted reproduction technology. But that is basically on assisted reproduction. The one on assisted reproduction stems from, a lot of women who have spoken to me about their journey struggling to have children and not having. That time when they spoke to me, I didn't know that I'm not going to be having children. So it is also born of my own experience of not having a child and stigmatizing being childless. No reproductive issues about women. But I've also brought a bill called Family Reproductive Healthcare Bill. It has just gone through the budget committee, and it will be moving, if budget approves it as not having financial implications, it will go ahead to the relevant committee. I'm not too sure whether we'll be able to finalize it within this parliamentary term, because the time is very short. But I just wanted to tell you about the proposed part 10. Is this 10 or 9? This Roman thing, Siju?
This one is 9.
Part 9. So it's reproductive health for advanced reproductive age persons. I know when I was writing this, I said, this is now me, advanced, reproductive. You know, you never think you grow old. So I still see myself as young, but I fall under here. So it actually talks about the issues that are of reproductive nature for people who are slightly younger than me and older, meaning people in their 40s, 50s, 60s. And then we have the gerontological age that also has a special part. And some of the issues that we have here is that we are calling on the national government to undertake continuous reproductive health-related research to inform policy interventions and service provision for advanced reproductive age persons. And I think it's one of the issues that came up here. We were even talking, I had somebody talking about, you know, using traditional, you know, foodstuffs. Somebody saying don't use milk, don't, but it comes out as a rumor. We don't have proper research. We need that research. Somebody added me into a group of reproductive, menopausal women. And the first few days I was very, very happy. Then I said, as another symptom of menopausal women talking too much, I had to leave the group. We talk too much. Honestly, we talk too much. And when you're busy, you can't cope. So I left the group. But you know, we need to actually look at the research on what are the issues that women need when you're going through, what works, what has worked for Mary, what has worked for Lucy, instead of us, you know, trying to guess. Then the other thing is to obligate the national and county governments to respectively facilitate provider-initiated information on reproductive health-related problems for advanced reproductive age persons. What this basically means is that if I go to see my gyna, in my 30s, I'm going to see my gyna on fibroids. Then they should tell me, you are 30 years. Please, in your 40s, no, menopause is coming. And these are the likely symptoms of menopause. Because we wait for people to have a problem, then they go and see a doctor. No, we need the doctor to tell you beforehand what menopause is and what you are likely to experience. Because we can't we can't live our lives by guesswork. Half of us here, if not most of us, have no clue. I was listening to a lot of you here. It was happening to us like an accident that I saw. Like I remember one of the times when we were in Parliament, when I first joined Parliament, and I went and complained. I won't say who the woman is, but she was a woman member of Parliament that I looked up to, a senior that I love. Yeah, many of them I love, so don't try guessing. But she would have these very serious mood swings around me. So I'd be like, you know, I don't know what I did to so and so. Sometimes she's so nice, and then sometimes she's so bad. And I was telling a man. Then they told me, Millie, that is called menopause. I'm telling you very honestly, I had no clue why menopause would make her be mad at me. And then they told me, can't you see sometimes she fans herself? She goes by the window. That is hot flashes. And I'm sure it was just rumor mongering. Maybe it was just a hot day. But now the man had more information than me about issues we actually go through. Maybe I'll just give one last example in relation to the issues we want us to cover. We want the government, both national and whatever, to look at issues of chronic conditions such as vaginal atrophy, reproductive cancers, and cardiovascular diseases, sexual difficulties and interventions in men and women of advanced age, sexual and hormonal difficulties and interventions in women, including genitourinary conditions, gynecological malignancies, and menopause. Some of the other ones I've mentioned actually menopausal issues. Honorable Njoki and I served in FIDA. She was my boss actually in FIDA. I was an employee, she was in the board. And a lot of women would come to us with issues of divorce. And guess what? Sometimes when I look back, they were because of menopausal issues. Because the man starts doubting whether you are faithful because you don't want sex. They don't realize you are already, my body is slowing down. And I have no clue what is going on with my body, so I don't want sex. But you think I've had it elsewhere, that's why I'm saying no. This is why when you talk even about the men, a man who is a serious person, wakes up 67 years old, divorces and marries a younger woman. And then people are wondering, what the hell is going on? Menopause, and what one, the other one of yours? Andropause. So we have, that's why I brought this bill. That it's a comprehensive bill on reproductive health. It takes a life cycle approach, but it also has a gender dimension, so that we look at issues that affect us at all ages. Because when you talk about reproduction, people just think about teenagers and abortion. No, that's not what affects women from childhood. Tuko na shida mpaka tukufe, which are reproductive in nature. But it's put peripheral. So we must make it the center of policy, the center of legislation, and the center of budgeting. Thank you.
Thank you very much, Mele. You know, in the morning, I think was it Atuoli who mentioned that in our policies, we should not be living now. Our policy presupposes that we should be dead by a certain age. That's why there's nothing about menopause. Mele, thank you very much. I think in your policy, in that legislative framework, Professor Joachim also would provide some kind of symptoms of andropause so that it's not seen. I think male legislators may only support it when they see some forms of their problems that Mele is discussing. Otherwise, sometimes they fail to understand that this affects them. Thank you very much, Mele. And I think in the morning we did talk about policy concerns. And I think you can now see that somebody already was thinking about what we're talking about. Our next presentation comes from Dr. Josephine, and is implementing menopause care at county level and whatever level that Mele has also talked about. Dr. Josephine, please, the floor is yours before we go to our next colleague.
Thank you very much. Good afternoon, ladies and gentlemen. Yes, we all know that health is devolved and action happens at the county level. So even as we speak all this high-level language in boardrooms and even here, would be wanting to see how that translates into actual action at the county level. What Evelyn shared this morning about a lady getting treated for malaria several times is reality. I actually checked patient's booklet because she came to me wondering why her malaria she never recovers from this malaria. She was 62 years. And that was just the tip of the iceberg. Apart from being treated for malaria, they are treated for many other things. Dr. Muthigania was just reminding me even brucellosis. Those doctors who are here in this room know that's not something which is found all over the place to be treated for brucellosis because you have aches and pains and sweating. So from where I'm sitting, I am an obstetrician gynecologist by training, but I do a lot of moving around counties, training in leadership and governance, and also other areas of reproductive health. So when we talk about, I was asked to bring up some issues like how can we integrate menopause care into existing reproductive health services at county level. You had Dr. Serem this morning There is maybe a paragraph or so on menopause in the reproductive health policy. There are no guidelines. But he did promise that that will be forthcoming, hopefully in the next few months, hopefully. But in the meantime, what can we do at county level, even as service providers continue giving services? By virtue of the health system in Kenya, it is actually set up in an integrated fashion. If you go to OPD or MCH, FP, the infrastructure in most facilities actually is conducive to integration of services. But when we see, or when our clinicians, doctors see patients, there is a tendency towards just treating the symptom which brought the patient there. So I think we need to be working towards trying to see how do these clinicians reduce the missed opportunities. When a woman comes with headache, I mean, in their mind, they should also be thinking about menopause and all other aspects of health, which would make this lady come to the hospital for headache. But the real story is that if a woman is coming for maybe bringing a grandchild because they are sick and they have a problem, they do not matter in totality. So from where I sit and seeing the health systems as they are in the counties, I see the opportunity for reducing the missed opportunity by updating the skills of these clinicians and doctors so that they go beyond that which has brought this lady to be in front of them. Because some of these women take very long to come to hospitals for various reasons. So when they come, we need to make sure that our clinical people are using that opportunity to actually give as many services as possible, of course, including screening for cancer and so forth. But what stops them from doing that? I think one of the key problems in the counties, they have several problems, but one of them, which I meet in almost all counties, they talk of a shortage of personnel. They don't have adequate clinical officers, they don't have adequate nurses. I don't know where everybody went. And the wage bill is still very high in those counties. In one or two where we've been able to do more detailed study, you find actually the wage bill is not for doctors, nurses, and clinical officers or people like that. It's for drivers, for clerical staff, of course attached in the Department of Health, but some of them drivers with no vehicles. And there is a health center which needs a nurse or a clinical officer. So those kind of systems and disconnect by the leadership at the county level need to be addressed so as to be able to increase the human resource for health within these counties. Because seriously, when we go there, you do find the gap. So what happens is we are trying to say, treat this woman holistically. So that even menopause is one of the questions you ask, how old are you? Then in your head it should be clicking, maybe this could be menopause, so that you don't give 3 doses of antimalarials within 1 month. Yeah, it is disheartening because that is exactly what happens. So let's have county leadership get more staff so that they are able to prioritize services in totality, because the possibility of integration is actually in place by virtue of our way our health services is structured. The other issues which we find among the health systems issues affecting menopause treatment is even availability of the information. We talked this morning, and many of us have confessed here, even in medical school, they did not get adequate exposure. Now imagine the clinicians, the clinical officers, and the midwives, who are usually manning 80% of the facilities in this country. They are the frontline health workers. We need to have a way to update them on some of these issues so that we raise their index of suspicion, so that if a woman comes again, you begin thinking it could be more than just brucellosis or whatever else we are rushing towards. So updates. So as we moving forward, updates for those who are already out there in the field. And for the pre-service, I think we need to look at those curricula again so that we have people coming out of these institutions who are already empowered with information and knowledge, so that once they are posted to this health center as the only health staff, they are able to also think beyond just the obvious. I know they told us in medical school, common things occur more commonly. That was a slogan. And a woman at 60 or 55 who is sweating and having joint pains could be malaria, I agree, but not 3 times in a month. So we think also of the next possible reason they would be having this. The other missed issue or challenge I see in counties is lack of other support systems. For instance, when we are treating menopause, like we've ably articulated in the morning, there is the medical management and there is the non-medical management. So we are thinking of issues like nutrition advice, issues of weight loss, how lifestyle changes and so forth. While nurses and other people may be able to also address this, but there are also cadres like nutritionists and others who could be integrated within the OPD so that they are able to give this information as part of those health talks. When I used to be in government many years ago before menopause, we used to, as part of the outpatient sitting arrangement, there was always a sitting area where everybody would be educated on health issues. I have been in many counties and they actually don't have that facility anymore. I mean, the patients are always there, many of them ready and willing to listen and be treated, but there's nobody to talk to them. If maybe once in a long while there may be one, but they are likely to talk about the current issue, COVID, when it was COVID time, or now the issue is maybe malaria, depending on where one is. But if these talks were integrated on a regular basis, then this would be addressing, giving people the information. Ladies and gentlemen, women, we are very bright, we are very resilient. I mean, they are surviving without being managed, their menopause as we speak. But let us give them the information. Because when I go to churches, and I do that a lot, or even speak in the vernacular radio station called Wemwaro, and they call me, they say, Doctor, do I have cancer? I'm sweating so much. And I hear one of the things about cancer is sweating. So now we have to go back and go around and talk about what menopause is. Let us give these ladies the information. Let us give them the information so that they can make informed choices. And informed choices includes things like their nutrition, their issues around what they eat, how they sleep. They don't need the biggest duvet or blanket if they are sweating, and then putting it away from their husbands who get annoyed in the middle of the night. So you can sleep with a sheet where you can use the duvet. That way you don't have to fight over the blanket in the middle of the night. Simple things which make them comfortable. They are resilient, but they need the information, and we have the information. The county need to be updated, those nurses, those clinical officers, those nutritionists, so that they can pass this information to women in their women groups, in the church groups, and all those areas. Because even when they are talking, somebody talked about, sex being so painful because everything is so dry and so forth. They don't know why it is happening. They think it's a sickness. So, let them know it is because of changes in their body issues and what can be done about it. There are KY injuries and other things. Please, not Vaseline. Yeah, then maybe the role of community health frontiers. I was asked to also maybe bring it up. Yes, community health promoters now, as they are called, they are first level providers of service. They are expected to be trained on almost everything from what I've seen their curriculum. They could be a very good resource in terms of passing this information to their households, which they cover, because these are people who are trusted by the communities. They take whatever they tell them seriously. But the gap I see there, of course, is they themselves have no clue what menopause is all about, among other things. I looked at their curriculum, and it is really just geared towards the preventable diseases, issues of HIV, AIDS, malaria, and such. So it's important that these other things are integrated within those trainings which they are given as they are being made or being graduated as community health frontiers. But I believe they have a place in all this. But also, like Anne Kihara told me as we were sitting there, the criteria for determining who these community health frontiers are, it says they should be ex-Form 4s, somebody who can read and write, coming from the area. But when you go on ground, hey, the chief's cousin who never even stepped in school is the community health frontier for some of these areas. So I think it's just making sure that we do the right thing. And I believe a properly trained ex-Form 4 who has been given the information can be a very good resource for the communities in the counties, since that is a system which is already in place, and it can be upgraded to also include the integration of menopause issues. So finally, as I conclude, I think I have covered most of this, but there was issue about low-cost interventions in counties. What can be done now as we wait for bigger things? I think I've alluded to some of them. Yeah, being able to update our staff so that they can give the information. Have integrated outreaches. That's what they were meant to be, even during the primary health care slogans of the 80s. Everything was supposed to be integrated. So when the nurses go for immunization, why don't they talk about menopause to these women who are bringing the children for immunization, or those coming for family planning? They are the ones who are going to menopause in a few years. So can we have these outreaches being integrated? And then, of course, investing in those other empowerment for the communities, being able to give them the information so that they are actually empowered to take care of themselves. And of course, lobbying, and we continue to do so with the organizations and people like this in the room for HRT. I think there's no reason why hormone replacement therapy should not find its way in the essential drug list, so that counties can procure it from KEMSA, depending on their needs, because now it is a devolved system of government. Some governor, depending on his how empowered he is, or if his wife is almost menopausal, may think it is a good thing to procure, and like another. We see very many things in the counties, but I think if it is in the essential drug list, then the possibility of it reaching that woman, the 80% of the women in the next few years, could be a reality. Thank you very much.
Thank you very much, Daktari. I think you do allude to system and staff rationalization. You do allude to cultural context in terms of different counties, but maybe this, when you talk next, we'll find out whether there's variation, geographical variation in when people get to menopause within the context of our counties. I think there's also a need for culturalized information with respect to the cultural policymakers, the nexus of power, and more particularly, I don't know how you interact with the religious leaders in different counties. So related support systems, and then you did say something about Vaseline. I'm sure you will come back to it when you ultimately have another chance. Now we go to Honorable Betty Maina. Betty, take the conversation whatever direction you feel like, although it was menopause at work, particularly employer strategies, support and retain mid-level talent. Please welcome. A round of applause for her, please.
Well, thank you. Thank you very much. I guess a good place to start is to say that in the absence of an overarching policy demand, employers will not have a particular response. So whatever responses are coming in response to their own initiatives. Sometimes it may arise out of leadership by women who are aware of this, so they now start to create a more conducive environment for other women going through menopause. Others, it just, I think there's just been conversation around it. But in the absence of a national policy demand, it will be very difficult to find, shared actions across many employers. But that doesn't mean people are not doing some things. You would have read, you would have shared, companies, whether multinationals, are domesticating policies that they have at global level and applying them in the context of Kenya. I think I remember reading about the Standard Chartered group sometime last year. So at least there's been some response. I checked with the Federation of Employers yesterday, talking to Jackie and asking, are you guys discussing this? No, they're not discussing it as at board level yet. But that basically tells you, given the fact that menopause is something that has been stigmatized, there's been a lot of silence, there's a lot of rumors, there isn't shared knowledge around it. It's very hard to mainstream those conversations. So I think a conversation like this today is actually going to be helpful in forcing people to have that conversation in their boardrooms. Now, why should employers care about menopause? I mean, that's the other thing. It's not just that it is demanded by law. When it is demanded by law, they will care. The way they care about, maternity leave, now paternity leave, the way many employers are providing, child-rearing facilities in their, in factories, so child nursing facilities. Those have become normalized because we've talked about them, but at the same time, it's also because they are aware about their productivity of their workers. Facilitating lactating mothers to have access to their children has a lot to do with productivity. So, and they have studied, and there are studies that have shown that. So for me, the other thing that is really missing in this context is sufficient data and research that shows the impact of menopause on productivity of women in Kenya. In early stages, when we were discussing, when we were discussing women's rights-related issues, we relied a lot on data. What does it take to be more inclusive, to have more, women-friendly policies? And you could demonstrate from data, and that data informed policy, and then it informed legislation. If we don't have data on what my brain fog costs the company, or an afternoon of non-productivity, how much does it cost the company? And if there are several of us there, then several of us in that age group, a company will not take it very seriously unless it is something that they actually notice it is costing them their productivity. And it is critical to note that the people who are going through menopause are your senior staff. They are your experienced staff. People above 45, people that are making critical decisions. So if I make a bad investment decision, it's going to cost the company, and they need to become aware that if they don't support that sort of cadre of people, they're going to lose productivity. Now, if they decide that the best way, because usually sometimes employers decide, what about the cost of it? But what is the cost of letting go of senior people at 45, 48, or even 51, compared to making the workplace more accommodative for them? So I think for me, the bigger lesson in this conversation is, first, conversations around menopause need to really go a notch higher to make it commonplace. And those should be talked, not just in the outpatient departments, but this should be part and parcel of employee conversations. I checked with the HR officer in our organization last week and asked, do we talk about menopause? And she said, actually, yes. We did have a talk last year, and we're scheduled to have another one this year. So at least it tells you it is being surfaced. Then I asked her, what about in other, in your HR community of practice? Is this something you're talking about? Yes, it is. And then thirdly, in the case of our organization, is it covered in our insurance? And yes, it is. But now that is just an example of our own organization. There may be others that don't, but you can push the line, and that's, activists like yourself can push the line. If you can cover maternity for reproductive young women, young workers, why can you not cover menopause treatment? If we can have talk about mental health, every quarter there's a talk on mental health. But why don't we talk about menopause? So that, hair loss for Millie, hot flashes for somebody else, palpitations for others, sleep deprivation, and all these other things can become commonplace, because I think we are dealing with absence of shared knowledge. In our churches, we will talk about parenting. I'm sure you've gone through parenting classes in church. Have you had menopause discussions? And you're in the women's committee. So what I'm trying to say is that employers will respond to signals from society. And if those signals are not forthcoming, they will not. If somebody then says, oh, in our organization, people just sharing, what do we do? In our organization, we put menopausal women near the door, near the window, so they, they get fresh air. We supply fans, or we don't mind them hogging the fans. And you know people who hog the fan, right? So if you normalize that experience, and you take it away from stigma. Because I think for me that is the challenge. The more you stigmatize it, I'm glad your colleague in Parliament, and it wasn't a rumor, and please congratulate him that he was aware that that mood swing was menopause related. But you hadn't known about, but maybe his wife was menopausal and he had gone through it at home, so he had better experience. He saw about hot flashes. But we need each other in this conversation. And it's not a conversation, that's my second point, it's not a conversation for women alone. We made reproductive health-related issues women-only issues for a long time. Menstrual health, we made it women's issues alone. And yet there were fathers who would feel embarrassed if you asked them for money for pads. You remember those? So sometimes, even when you wanted to go and ask as little children, I remember when I was having my menses, so I'd ask my father, because he was the one with money, I need money. For what? Then I'd not be able to say it's for my periods. I said, it's just for private things. And I think he figured, and somehow it's like, no, he would get me some money. But many men that generation didn't participate in menstrual product purchases for their daughters. It was all handled by women, by their mothers, and you were actually told not to tell your father, as if he didn't know. So if we can normalize these conversations, it will be helpful so that your partner can support you, your co-workers can support you. They're not going to go snickering behind. But fortunately, because of AI, I think these boys are also Googling menopause, so they probably know a lot more than we give them credit for. So I think as I end, I think the point I'm making is that even if there isn't a national policy requiring employer response so far in the country, in reality, many employers are quite far-sighted and doing something. Okay, they may be the multinationals that are domesticating policy, but others will learn from them, and when we talk about, when other workers talk about it, they will be able to bring the same learnings from the organization. But the other thing that I think people are also acting on is that they're also responding to the legal framework around discrimination, equality at work. So even if I'm menopausal and I am moody and I am, cranky in the office, you can't get rid of me before before retirement age. Otherwise, I can sue you for discrimination. And we can, and I'm sure the lawyers in the House can begin to activate even on the basis of, employment laws and discrimination. But we just need to have a bigger conversation, a more national conversation, so that we would have more employers responding, whether from the formal sector, but those signals will also go to the informal sector. Paternity leave was I remember giving paternity leave in my previous organization at the Association of Manufacturers, and the guys were still embarrassed by taking paternity leave. And it was only 2 weeks. Now there are companies that will actually give you paternity leave of 3 months. And the men, especially the younger fathers, are taking advantage, taking advantage of it and bonding with their children. So this change doesn't come overnight. And for those of you starting the journey, ICRW, trying to normalize and mainstream conversations on menopause, these changes in culture, normalizing it will not happen overnight. It is just something that we need to keep going at it. And before long, even the informal sector in Kenya will be aware and will be, supporting their workers in that response. So employers respond to incentives. Those incentives come from policy, come from requirements, but they also come from their own assessment of their own bottom line and the impact of not supporting this productive, even if they are older workers, because definitely they are not younger. It's just that there are some in their senior ranks by that time. Thank you very much.
Thank you very much, Honorable. Another round of applause. I think to summarize what Honorable is saying is that we need, number one, a justification. We researchers, I feel very good about her statement, because she's saying we need information and data to inform policy. So a job is being created for me there. Now, and we also need to justify to employers why menopause should be invested, the investment on menopause, because of the net effect. I think it took us for almost 45 years of independence for Justice Njoki to remind the policymakers that sanitary towel was not a luxury commodity. So what Betty is telling us is just to ensure that we do our best to bring this conversation to our normal tables. And finally, we must also ensure that the provision of this information does not remain within the shelves. They are also cascaded to the people who matter. Let's hear issues to do with insurance, closing the insurance gap for older women's reproductive healthcare needs. And this is from Dr. Sheila. Please, the floor is yours.
Good afternoon, everybody. All protocols observed. There's many honorables here. I am humbled to be in your presence and on the podium with you, and to learn right along with you. So Dr. Sheila Kioi, I head clinical operations at Old Mutual, Kenya. We'll talk about insurance. I think I have been in the line of fire in the course of the morning. But I'll ask a question as I start. For food for thought, I would assume probably 99%, if not 100% of the people in this room have medical insurance. True? 99%, I'm sure, have medical insurance. Okay, we want to raise our hands? No, I think we'll work with a high percentage. And the reason I say that is because what we may not know is that only 3% of the Kenyan population has private medical insurance. And when I was saying 90% and above, I was not talking about SHA. I was actually talking about private insurance, which is a majority of us. So when we say 3%, and this is men and women, they have a maybe 1.1 to 1 ratio. So we are saying just about 1 million and another 1 million. So we are saying only 1 million women have private medical insurance. And these are women of all ages. So from babies all the way to the elderly. So if we then categorize how many of these women are in perimenopause or menopausal or postmenopausal, we're not talking about very many people. So this is to put my disclaimer across as I give my presentation, that this accounts for a very small percentage of the women in this country. Yeah? So if we look at the global trends, insurance penetration is at about 7% globally. If we look at Africa, it's at about 3.5%. They're about below 4% in Africa. South Africa is leading. They hold about 68 or 70% of the full African population that has private medical insurance. Kenya, we've said, is only at 3%. So we can see there's a lot of room for this 96%, 97% to get into private medical insurance. Generally, what we find in the African population or in the West is that the public health system, especially in Africa, is highly under-resourced. Focus, as we've had this morning and afternoon, is on essential services. Essential services being acute illnesses, the malarias, the tuberculosis, HIV. It doesn't cater for things outside of that scope. The Western world is a bit ahead of us, and we are seeing them cover menopause and menopause-related symptoms a bit more than Africa. South Africa, as I said, is a bit ahead of the rest of Africa, but we are still quite behind in what can be covered as far as menopause-related complications are seen. In Kenya, what we do see is that in 2024, we had about 204 billion underwritten profit. This is how much money went into premiums in 2024 for general insurance. Out of these 200 or so million, about 76 billion of it went into medical insurance. It sounds like a lot of money, 76 billion shillings. But what is also interesting to note is that generally the medical insurance industry is struggling and is drowning because we are making losses and have been making losses. 2024 saw in the range of over 200 million in losses in the medical insurance industry. So when we ask why are we not in that space, various reasons, one of them being a cost issue. We've had it said today that HR, hormone replacement therapy, is exorbitantly expensive. It is not affordable. And so if we are saying that insurance would need to cover for this, then we are talking about an increase in premiums, which again then puts everybody out of the bracket of being able to benefit from private insurance. In the West, we see people take private insurance. In most times, it's usually just to supplement what they have from their universal health coverage systems within their countries, because they work and they cover about over 90%. So you do find them take private insurance, but in most cases, it is because of the slowness of getting this treatment. You may get an appointment 2 months down the line to be able to see your menopause consultant, and you can't wait for 2 months to get your renewed prescription. So you find them taking private insurance for some of these things that they know they cannot get through the mainstream. I'll go into Kenya and what we are currently seeing as gaps. I'll look at 4 items, one being coverage. When we look at the coverage, I've alluded to the fact that we usually look at essential services as insurance industry. We don't look at anything out of that. And when we are talking about essential services in the women, then we are looking at women, the younger women, the ones in the reproductive age. Older women are largely overlooked. We've had it said. Why? We don't know. We have policies that are not there. We had Dr. Serem, yes. We had Dr. Serem earlier telling us that he's going to form a committee to discuss menopause because it is not something that has been discussed before. So there are so many gaps in this area. And if we look at the coverage even with private medical insurance, then we understand why it's not covered by most of the insurance companies in the market. What are our opportunities, or what should be done to fill this gap? We have talked about it. It is about looking at the woman from pre-adolescent all the way to the elderly. What are our needs throughout? Because we look at even teenagers and they are ignored. You have children or teens who come in with dysmenorrhea, with endometriosis. Is it covered? Do we talk about it? Do they understand it? Yeah. They get to miss school. They are 2-3 days every other month out of school because they have to stay home and deal with some of their symptoms. The second thing is about product development. We have minimal offerings, if any, in the private corporate world that cover menopause. What we are seeing, as Honorable Betty has talked about, is employers who are advocating for menopause to be covered within their insurance. And that, I would say, is the key towards unlocking some of these things. The underwriters are okay. The insurance companies are very willing to cover for anything that they are paid to cover. For the premiums able to cover, all they need to do is do a pricing. It's about the risk. So we price the risk. This is the risk. If you say cover for even somebody who is 80, 90 years old, you just need to price the risk and you'll be able to give a cover to the client. So if we are able to demand for this through our employers, then we'll be able to see a difference in the product field in what is there. The retail market has not had a product that offers menopause care. I'm happy to say All Mutual launched a product only 2 weeks ago. I'll speak into it at the tail end of this. A retail product that actually looks at menopause, this being the first in the market. So the products that have remained there are restrictive. They look at illness, they look at maternity and obstetric issues, they look at gynae issues, they look at cancer screening in most cares and management of cancer. So we are talking about dealing with the illnesses and not dealing with the things outside of that illness. Looking at the opportunity for product development, of course, there is room for more. I dare say that with the new product that Old Mutual has launched, we will see a move towards more retail products that cover menopause and a move towards more corporates as well, asking for the same to be covered for their staff. This should cover mental health support for menopausal issues. We've talked about anxiety, depression. We've talked about sleep deprivation. These all need to be covered in one way or another. We look at things like other menopause-related symptoms, whether it's HRT, whether it's osteoporosis, we need to have these covered and included in our products. We look at issues of community awareness and drives to reduce the stigma. Why are they not within our products? Yeah, because we have insurance companies that cover county for medical help, for medical insurance. When they go for medical talks, for health campaigns, for webinars, or whatever it is that they are doing, can we communicate to them that this is menopause, this is what half your population is going through, this is what all women will transition into, and this is how to take care of it, how to be preventive, and how to treat early so that you have early intervention before complications arise, including screening. The third thing is about public and private partnership. I think there's, it's interesting that I'm seated on this, I'm seated with the honorable members on this podium, because they've already alluded to it. We have seen the gaps, yeah? And we can see what can we do together, how can we work together. I think what has been obvious is that there is little or no collaborative initiatives between insurance companies and the public forums. We lack trained providers, both in public and private facilities. We've talked about a gap in undergraduate. The doctors in the room can testify that we never went through training on menopause. We just went through, maybe talked about it, but really did not get into it. In my previous years of career, as I saw patients who may have been going through menopause, I actually don't recall having a sit down and walking them through symptoms that could have been menopause. I was younger then, maybe I was ignorant, maybe I didn't think I could be of help, or maybe I also thought that this is menopause, it will come, deal, as we all think. But there is a gap there. Can we train them? Can we train the community health workers? Can we train the nurses and the clinical officers to know how to identify? I think Dr. Josephine said we were all taught that common things happen more commonly. That is true. So when a lady comes in and she says she has issues with a fever or she's feeling hot at that age, the first thing that should come to my mind is menopause, and then I go ruling out with my differentials for what else could be possible with this lady, yeah? The truth is that we, as insurance companies, already cover menopause, and we cover for menopause-related symptoms, not knowing, or knowing but not being able to do anything about it. And as long as it is not identified as a menopause symptom, then it will be covered. So when a lady in her 50s has a diagnosis of osteoporosis and we treat, and we pay through insurance, what are we paying for? When menopause, when we are treating cardiovascular issues in ladies and women in their 50s and 60s, what are we treating? We are told about 50% of all the visits in outpatient clinics are mental health related. So if you're looking at the women in the menopause bracket who are visiting their outpatient clinics, why are they there? Yeah, we've had clients, we've had patients here, we've had individuals speak here and say they went in for investigations. It was not indicated that it was menopause. Yeah, one of us told us that she went in with palpitations more than once, with a battery of tests that were done. Who paid? Insurance. Because it was not indicated that it was menopause related. So to be truthful, menopause is actually covered for the most part. Where it's not covered is where the clinician will actually indicate that it is menopause related. Yeah? So as insurance companies, we need to embrace the fact that we are actually covering this, and we should openly cover it and possibly give a cap instead of saying it is an exclusion altogether. Can we put a cap on what can be covered for menopause? If we can put a cap on antenatal clinic visits, if we can put a cap on vaccination for children on outpatient, why not put a cap on menopause and menopause-related symptoms? The final thing is about regulation, advocacy, and consumer demand. So the gaps there is, of course, we have discussed it in the course of the day. Lack of policies, no advocacy, employer advocacy also lacking, and there is just a general knowledge gap with men and women about what menopause is. So how do you fight for something if you don't understand it in the first place? How do you fight for something if you don't think it needs to be fought for in the first place? Yeah? So we have opportunities here in regulatory mandates so that we can ensure that these are things that are put in the health plans from a regulator perspective, that the regulator should be able to say that you should not sell a product in this industry that does not cover menopause. Yeah? If that is done at that level, then all insurers are on board. Yeah? It may have an impact on the premium, it may not, because as I said, we are already covering menopause silently. Yeah? Can we look at the opportunities for government subsidies and tax incentives? Possibly this will help with the premiums so that even when insurance companies are covering for menopause-related symptoms, then there's no direct effect on the premiums to the clients. It is not translated there to them. We've talked about increased awareness as well to drive this demand. That is what I have in terms of how the insurance industry can plug in, keeping in mind that it is a very volatile industry. It is highly loss-making when you look at the medical insurance industry. The loss ratios in the last year were in the range of 78, 79%, and they keep going up year on year. It was 77% in 2023. Last year it was 78%, 78 point something percent. So this keeps going up. So what can we do and do different? The Western world that we are saying covers for menopause and openly covers for it are at a range of 50 to 70% in loss ratio, meaning their medical books, their medical insurance books are profitable, and yet they cover these things, and yet you find their premiums may actually be lower than ours. Yeah? Can we as an insurance industry look at what is ailing us? To be honest, there's a lot of fraud in the insurance, medical insurance, where we find that I have a cover, but my sister is using it. I have a cover, but I'm covering my nieces and my nephews on the same cover. I have a cover that covers for a male. I have a cover that covers for one wife, but we find it in the northeastern region where you catch a client benefiting from maternity more than once within a year, and you wonder what is happening. Yeah? The reality is we call our patients in hospital, and many times they are not in hospital. I have personally called patients who are in a marketplace, and they're supposed to be on a hospital bed recovering from surgery. Why? Because there's somebody else there. We have visited patients in hospital and found somebody else. We have collusion between hospitals and the principal members or the members who are covered. And these things are happening. You go, you find claim forms coming in, all the data is there. It looks like legit. Somebody ran their fingerprint on a biometric machine, but you call to even ask them, why were you admitted? How are you feeling? What is going on? They have no clue because they never went. They just went to the hospital, put their fingerprint, whatever is paid, they have an arrangement on how that will be shared. And that is what is ailing the system. That is what is ailing the medical industry. And I think until we can get to the bottom of that, then we find ourselves a bit hard-pressed. So I'll speak a bit into the Lady Anchor product I talked about. This was launched 2 weeks ago. It's a retail product from Old Mutual, and it's tailor-made for women. Tailor-made being that you can pick the items that you want to be insured. So it has a medical angle aspect. It has motor insurance, so you can take your medical and motor together, or you can take just a motor alone, but you can also add things on it. It comes with an inbuilt critical illness cover. You can put in a domestic worker cover if you want. That is optional, which I think is a great thing because even for me, I ask my girl all the time at home, have you paid for your SHA? Because if she hasn't, that is my problem. Yeah, so it has a domestic worker cover, which you can opt for, and it also has financial services. So this product looks at different things. When we are looking at the clinical angle, we are looking at a menopause cover within a certain capping on outpatient. It includes gynae referral, menopause specialists. It includes hormone replacement therapy. It includes access to telehealth and telemedicine services. It includes regular checkups. On the psychological front, there is awareness. We have workplace alignment. Workplace alignment, I mean that we do visit our clients at the workplace, and as we give them talks, we engage the HRs and let them know what they need to do different for their patients within that bracket, yeah, in terms of trying to encourage them. If they don't have a menopause cover, we encourage them upon renewal, you need to take a cover and you need to take this cover enhanced with menopause. We will be doing monthly women's webinars, women's health webinars. We will have a fitness angle, a lifestyle modification angle with personalized fitness and nutrition plans for our clients. And we will have the financial well-being. So financial well-being, part of the webinars will be, what are you doing with your money? Are you saving? How are you saving? Can you put that extra coin into a money market fund as you try and think about what to do with it tomorrow or the next day? Are you aware of how you can invest? Are you aware about emergency plans? Because we don't know what will happen tomorrow. And then it will also have an emergency support where we have rescue services for medical and security. So 24-hour rescue services, so whether your car has broken down on the road or whether you have a break-in in your house, you have access to 24-hour services on this product. I think I will end it there. Thank you very much.
Thank you very much, Anne. Actually, Sheila, I actually almost stopped you, but the final part of your presentation was so critical for everybody else. Now, we have about 15 minutes to go. At the beginning, I thought 2 hours was pretty long, and Amakove had warned me to ensure that I can save the time for the whatever. We just need at least a question for every panelist, and I also know from what I've seen, they're very time conscious. If everybody takes 3 minutes, that will be 12. I'll still donate 3 to Amakove. The first question will be here. Second question there, that is fine. Third here. Fourth, Professor Sur, and that's fifth. Thank you. I can see one at the back. Let's continue. First.
All right. Thanks, Prof. I'm Dr. Masi Korir, journalist, medical doctor. My question is to Millie, and maybe a challenge to the rest of the room. But from what I see, the private members' bill usually move at a very snail pace. It's like pulling teeth. That's how I see it. What support can the women and the people in this room provide you so that there's movement? Because like Betty said, some of these things, if there's no overarching legislation, then nobody is mandated to do something about it. So what can we in this room, the women in this room, the people in this room, do even after this so that we are able to support you, so that you are not a one army bad girl, but you've recruited other bad girls?
Thank you. We'll take all the 6 questions and then they will be answered at once. Then there's a hand over there. Thank you. Thank you very much. Yes, give it to...
Hello. My name is Anthony Akolo. I'm an advocate and Reproductive Health Network Kenya. So my question goes to Honorable Millie Odhiambo, and in regards to you making policies and bills. The 4th schedule of the Constitution stipulates that the county and the national government are supposed to enforce and ensure that health is delivered to the counties and so on. At the national level, you do make policies and bills, but you're having so many policies at their deathbed. Why? There is a problem when it comes to implementation. As you make these laws, how do we bridge the accountability gap between the national government and the county government so that we don't have these policies there for the sake, yet they are not being provided at the counties?
Thank you very much. Yes, young man.
My name is Simon. I'm from Reproductive Health Network, and I have like a question for all of you. I am a fourth-year medical student, and we're currently having a problem. I was sitting with some of the students who are ahead of me, and we're having just a discussion on consent and sexual harassment and the kind of things I'm getting. I'm like, oh my God, how are you guys the next line of doctors? And I can imagine the kind of things you're going through and the house. So my question is, how do we engage the men? How can we have this discussion? Because even in the things that we seem to already have a standing on, like consent and harassment, it seems like we're not getting through. Now, my question is, how can we do it better? Even us with the other men who are here, so that when we bring more men to the understanding of this discussion. Yes.
Thank you. Is it consent in menopause or? Okay. Let's have the one at the back, then we'll have Professor Ann and then Professor Sur. Yes, yes, I have them all. Was there one at the back? Okay, bring to Professor Ann here.
Yes. Thank you very much to all the speakers. I want to just give an acknowledgement, particularly to Honorable Millie. I know we worked on ART with you, and this is a blessing you're bringing in. But, I always have a but. When we're talking about hormonal therapy, I love the fact that you're putting it in a life course approach. And the main problem is access to HRT. When we're looking at it in the life course, you're looking at women and giving hormonal treatment for fibroids, for endometriosis, for heavy menstrual bleeding, even the family planning commodities, now menopause, even gender-affirming hormonal therapy. So where are we in this life course in terms of, one, securing that these medications will be available and accessible and affordable, and particularly to public, not the private realm where we even have the beauty of the insurance cover.
Thank you. Professor Sur, then the last one would be, you will just have to excuse me, but I'll give it to her, please, so that when, if there's time, will come. Professor Sur, and then the last.
Yeah, thank you. Yeah, just on the legislation, so Bad Girl will have many questions today. You've seen how complex this issue is, and it's multifaceted. Issues of financing, insurance, workplace, social issues around culture and all these things. There are a lot of medical issues around it. So how do we work together to ensure that the bill is comprehensive and covers all these things? We are available to give input, but I'm just not sure how we do that and where it is now, whether that is still possible. But it would really be good to make it comprehensive, because if we miss any aspect, then it will be very hard to revise it later.
Thank you very much. Yes, my sister.
Good afternoon or good evening. So Prof echoed my question actually, because, and my question was based on the presentation on insurance about access to HRT and menopause services for women. And you mentioned HRT. So I'm gonna echo what she asked. One, access. Do we have them? Are they available? Two, how many will be able to afford that access? And if Old Mutual as one insurance is offering access, what about all the others? What are the conversations you are having as an insurance body to be able to have this as an inclusive service that will not just be specific to Old Mutual, but will also, what is the word? The brain fog, will also echo, yeah? Throughout for all the other insurance. And two, Prof is a gynecologist, to educate other service providers. The other issue is also when you're providing HRT, Prof mentioned in the morning, is a safety issue. How are we going to be dealing with that? What are the things that you're putting in place as much as you're providing to mitigate and minimize the risk that's gonna come, the increased cancer, possibly, not 100%, but possibly, the increase in cervical cancer, the increase in breast cancer.
Thank you very much.
The education, and let me finish, and the mitigating factors.
You indicated that your question had been asked. Give it to her so that I don't go out here with an LP, please.
Thank you so
That's
much.
the very last question, then we hand over to the panelists.
Thanks. My name is Dr. Wangui Muthigani,
And my question will also be to the financing and just adding on to the last sentiments. I think we're almost looking at this like we're doing women a favor. And we shouldn't be seeing that. We should be treating women with the dignity that they deserve. And unfortunately, Doc, this comes to you. I know it's not you. I know it's a whole industry. But all through, from the point of, like the whole life cycle of women is treated like we're doing them a favor when it comes to financing of health. That's why I would like for your response to really be reflective, not just as an insurance provider, but also as someone who, during this journey, is more likely to be on the end where you're not covered because you will not be in employment past a certain point, and you won't be able to afford the premiums that are given to older people. 2, for the county level, and I really needed to say this to Dr. Kibaru.
It's okay.
I think also at the point when we are talking counties are very happy to declare health is devolved when the money is coming. But when the accountability is on them, all of a sudden, the money doesn't come from national. There's a part of accountability to health as a whole. So from my end is, in your reflections, how do you see counties being, holding themselves or us holding them accountable to delivering care to all the constituents that they serve, including women who we are applauding? Thank you.
Thank you very much. We'll start with Honorable Millie. In that order until the end. Please include your parting shot so that we see you. Millie, please.
Wow, those are many questions. I hope I'll remember all of them, though they were sort of related, especially on the legislation. What I can say, borrowing actually, and I agree with you, from the ART bill, which is assisted reproduction. As you well know, I'm a lawyer. I'm not a health expert. But I can say that if there were people who were really, really good, the doctors who helped. We sat, I was just hearing, expert words flying over my head, because I don't know. I was hearing words like vaginal atrophy for the first time. I have never heard of such things. So it would be very, very important, because on this bill, we haven't done that. We've had awareness workshops, but we haven't gone, the way we went through the ART. So it would be nice if you can facilitate a meeting with the doctors so that we go through it in details. So that whatever is missing from a gender perspective, from a life cycle perspective, would be very good. We can still do it. So I'd be very happy. I'm not an expert on health issues. I'm just affected as a woman. So my business is to make things better for women, and how the experts do it, it's you guys who know. I don't know. I was learning a lot of things. And again, even as we had said before, not all of us are affected the same way. So there will be other experiences, I don't know. But for you guys as medical practitioners, you'd be able to know what may be excluded. So yes, I'll be happy. How can we assist other than that? Because not all of us are medical practitioners. Many of us are religious. You go to church, you go to the mosque. Please talk to your church and your mosque. There's usually a lot of misinformation. And Honorable Njoki will tell you that even when she was coming with the Sexual Offences Act. There's a lot of misinformation whenever you are coming with bills like this. The original bill that we actually worked on, you won't notice it, because it was mutilated in the last parliament by some of our colleagues who are quote-unquote representing the church. Because when you hear assisted reproduction, for some reason the church sees lesbian and gays. And I don't know why they are mortally in fear of lesbians and gays. I don't know what lesbian and gays does to them. But they just see assisted reproduction, they think it's lesbian and gays. When they see a reproductive health care bill, they see abortion. Yeah. They don't see hot flashes. They don't see, women having problems having sex and people divorcing, they only see abortion. So if you can talk to your church and tell them, before you pray, even God tells you, don't just pray and tell somebody, send somebody off. Give them assistance. I know there was a case I was dealing with a very good friend of mine who kept asking me, Millie, can you help me in prayer? Let us call fasting and prayer. It's menopause. So even as we are fasting, let us fast, but know that sometimes God has also given us information it is menopause. So let us just provide for the law and for the money and the systems that are needed. Sometimes we disturb God when we should be praying about serious issues like Israel, you know, what's happening in the Gaza. Yeah, let us pray about the Gaza. But if God has given us excellent doctors here with the information, let us pass the law without praying over things we can, you know, sort at our own levels. I hope I covered most. The rest, I think, like for instance, the one on consent.
There was an issue on laws lying on whatever without implementation.
Oh yeah, there was something that was said about the counties especially. That's a very difficult question to respond to. And the reason why it's very difficult, if you noticed, was it yesterday or the day after? Yesterday we were basically throwing tantrums against the president and Baba because of what happened the day before when they were told that parliament is corrupt. I'm not going to say whether parliament is corrupt or not. I think EACC is in a better position to say that. And I think really corruption, there's no parliamentary sitting we sit and say, now let us all be corrupt. So we cannot all be held, you know, in unison. I think it's really an individual thing. But my concern is that we devolved corruption. We are looking a lot at members of parliament, which is a good thing. But let us also look at our counties. Because on our side, even though we are being told, wachana na CDF, etc., which I don't want to talk at length because Honorable Njoki is here, and she will actually deal with that when it comes before her. I'm actually doing my thesis on CDF as a development model in Africa, and I have my own reasons for doing that. But even if you are looking at, you know, being told to, if you put aside CDF, Parliament on Tuesdays we sit until 7. Yesterday we were in Parliament until 7. Wednesdays we sit until 9. Of course the media will not cover that. Thursdays we sit until 7. And then sometimes we also have morning sittings on Thursdays when there is a lot of work. In other words, we are doing our legislative work extremely well. In this Parliament, maybe our oversight role has not been as good because of many marriages, yeah, many political marriages. So people were very happy yesterday when we were hitting on the executive a little bit. But our legislative work is done very well. I am hoping that our counties, because devolution, if devolution was actually working completely well, then there would be a very good case to kill CDF. Not because the money will go to counties, because the devolved money for CDF is national government. It's not county. So CDF dies, that money just goes back to the president. He can use it to give Harambee Stars, you know, double the money to Harambee Stars, because it's national government money. It's not county government. But the portion of the county government money, where does it go to? And I'd want to challenge all of us. I wasn't going to look at this in my thesis. My thesis is about political theories and how political theories say, Homa Bay County, and this is not because of my governor, you go to Homa Bay County, all the CECs are Luos, or maybe Suba, Luo and Suba. Yet before that wasn't there. How do we restructure such that we don't go to Nyeri and all the CECs are Kikuyus? Because that's what we have done to us now. We have to rethink how we did devolution, that we have now very heavily devolved ethnicity and corruption and lack of accountability. And that's why you saw a lot of people were challenging Baba, which we rarely do, saying, no, let Senate oversight. Because if we leave, because all of us know that the MCS cannot oversight government. So that I don't have to wait in State House. And we are hoping a ward fund can also be developed so that the MCS don't have to wait. Because when I go to the constituencies, a class is not working, people asking you, where's the class? Then I have to wait at State House. If the health center is not working, the MCA has to go and wait for the governor. And if that is not done, I'm happy at least that in terms of the operations, we passed a law recently that gives a bit of autonomy to the county assemblies. But maybe we need to think beyond that. So it's a genuine concern, but which I hope Senate, because it's not in our mandate as the National Assembly, but I'm hoping that the Senate can pick it up.
Thank you. On Betty.
Okay, there wasn't really a specific question, but I think the gentleman, the medical student, asked us to reflect on why sexual harassment still takes place, despite clarity about consent. In my opinion, two things. And first, I think we need to know sexual harassment and a lot of those sexual offenses are not sexual. They are power. It's a reflection of unequal power relations between people. And men sexually harass women, women sexually harass men. I know we don't talk enough about it, but there's been a lot of evidence on it. But that's so I think it's really those unequal power relations. But the other thing I think is also the failure or inability to deal decisively with it, because it represents itself, or in order to prosecute a matter of sexual harassment or sexual offenses, there is a lot of victim blaming. You tell us, what were you wearing? Why did you flirt? Why did you stay out late with him? You know, there'll be very many things. Why did you drink? When you thought drinking with the person, there are no consequences. There's a lot of emphasis on victim blaming. But the other third thing which I think we need to address, would have to address in the law, and especially around protection of minors. I've recently, had to deal with the frustration of using the Sexual Offences Act to deal with a teacher who groomed children during their high school time and then made a move on them after they left school. And two things we were dealing with, even when the teacher was still in school. When we went to the Ministry of Education, they said, do you have evidence? Now, how do I provide evidence of grooming? I mean, unless somebody has had, impregnated a child, you can't. Our law is still, I think for me, it heavily protects perpetrators rather than protects the victims. And we need to figure out, especially in the context of child protection, we need to figure out how we can have a more child-centric law that doesn't have the same burdens. In other jurisdictions, if a child complains about a teacher, that is enough. That is enough. And therefore, children can come forth. But if a child complains about a teacher now, And the question is going to be like, what exactly did he do? Did he touch your boobs? Did he touch your whatever? And who else was there? And if there were other people, of course you're already embarrassed. You think you're going to repeat it. So we need to think about the context in which a lot of sexual offenses take place and how to really put in a victim supportive framework. The current framework is not, it's not enough. It is good it is there, but it is not enough to really become a deterrent, especially if we engage in a culture of victim blaming.
Thank you. Dr. Kibaru?
Yeah, thank you. I think I'll just say something about health services in terms of the delivery of services at the county level. Like we said, the health is devolved. And quite a number of studies have been done to see whether the health indicators are better for it or not. I think from the studies which we have seen, the jury is out there. It kind of ranges from county to county. But having said that, even as in the state we are in now, the Ministry of Health, the national government, still has a responsibility in terms of quality, assurance, policies, and so forth. So in as much as counties are, semi-independent, there's still the issue around cooperation. The Council of Governors plays the role of peer pressure. I don't know how good that works. There is the Intergovernmental Relations Committee, which has several committees which the national and the county government are supposed to engage in so that they keep, track of what is going on the ground. But I think the jury, like I said, is out there. But when it comes to something like menopause management, HRT, the Ministry of Health has the responsibility of seeing how the medicines can be more, can be cheaper. Moving from where we are now, I think even right now, if I give my own experience, when I needed HRT, Nairobi Hospital was importing for me. I don't know from where. So I don't know what is available now. How about going generics, getting generics? Can they work? How does the ministry then incentivize the industry to be able to procure so that then they can include it under the essential drug list? Because the way it is right now, the prices out there, I don't see it being a priority for the Ministry of Health. And once this policy is available in KEMSA, we can now, ask the counties for accountability in terms of what they are doing about it. I think I just want to stop there.
Finally, Dr. Sheila.
Thank you. I'll speak to the question on what we are doing as far as an industry to ensure that menopause is covered. I think as Old Mutual, what we have taken as a step is heeding to a demand from the consumers. And the demand was that we have a gap and we need to do something about it. So as a business, we have taken that decision to be able to produce and to have a product out there that is needed and that will be used and that will be appreciated by those we serve. As far as the rest of the underwriting community, I'm sure it is just a matter of time, because as we do more and more education, as the people in this room continue to spread the word and raise awareness, then we will have the consumers out there demanding for a cover with menopause, and they will have to also follow suit. So I think it's just a matter of time. Somebody had to do it first. We are the ones who started it, but it will come. It will come in the future. Of course, by then we are hoping that all these policies will have come into play. So we have HRT being affordable. Even for now, it may not be that your full cover will just cover HRT. Yeah, because you have other issues. You get sick, you have acute illnesses going on, you have children who may be on the cover. So some of these things we have to look at it as a whole. You may get some level of HRT, but the bigger benefit will not be on hormone replacement therapy. The bigger benefit will be with everything else you can get out of it. And by this I mean the consultations, the webinars, the education, towards even the nutritional support towards using more natural products as opposed to using medication. Remember that a lot of women are doing self-prescribed HRT, which is a danger in itself, because what then happens is that then it interferes with whatever other medication you're taking at that age. So you have symptoms coming from your menopause related stage, and then you have symptoms coming from contraindications between drug interactions, which is a whole other problem, because you take a drug for a symptom, then you take another drug for the symptom brought on by a side effect, and before you know it, it's a jumbled mess. So we'll see how this will work. We are hoping to work together. I think that's the idea of this forum, that we can bring all these brilliant minds together. So many people in the room doing things in silos. Can we work together to get, even Kabuko said she can't even get something registered, and we are all wondering how. It is the truth. We are in this country together. So can we work together to see what we can do together? Because for women, menopause is inevitable, but it doesn't have to be debilitating. Thank you.
Thank you very much. My co-moderator, before we go for a round of applause for the panelists, do you have a specific question from the audience online that you'd wish to raise just for us? Or we can go ahead and have a round of applause. So let's have another round of applause as thank you very much, the moderators. Thank you very much, the audience. And we can take a photo here, right?
Yes, please.
As I hand over to you.
Yes, and then they can sign for me my commitment form, please. Yeah. Thank you. Thank you so much, Prof, also for leading that. That was an intense session. Great. Let's stand up to just stretch. We are on our last one. Listen. Yeah. So, the ministry. Yeah. Then you conclude with the three call to action. Yeah. Please stretch. Okay, cool. Yes. Thank you. As they are signing up, you may be seated. I hope you stretched. Okay. I'll call upon, we do not have Dr. Serem, but he left us in the very able hands of Mary Magubo. So Mary will request you to come in front. Sam, are you able to just put her bio there? Okay, Sam is not there. It's government. No, I gave him. Okay, let me just say who Mary is. She's the section lead for advocacy, partnerships, and social behavior change communication in RAMCA, which is where Dr. Serem leads, at the Ministry of Health. She's a nurse by training and has a Bachelor of Science in Nursing and a Masters of Science in Health Systems Management, in this occasion in health communications, combining over 20 years expertise, both in clinical, policy, and program leadership. Karibu sana.
Thank you so much, Dr. Cobbs. Thanks everyone for attending this workshop, and we really appreciate that you're here and kicking off this process because, sorry. Maybe. Okay. Yeah, so I was saying we appreciate as a ministry that this discussion has started off, and because it's something that somehow I want to confess that we neglected, because it's just a mention in the policy, in our RH policy, and we didn't do much about it because
you find even it's just one paragraph, and it says RH for the elderly, something that most people didn't like that word. I know most of us who have seen the documents don't like it, and that's something that most of those women who were in that room didn't want to discuss. They just spoke in low voices. And so that's why we appreciate that these are started off. We thank ICRW and RHNK and everyone who is here for kicking off the process. So as Dr. Serem had mentioned in the morning, that is going to form that committee of experts to at least also just discuss on the key points. Because again, some of the issues that we've also have to agree as a ministry is that we've neglected this component. And this age of menopause, we feel we are not investing in it because initially it wasn't a productive age for us. We feel from the pyramid, we feel like from the 20s and the 30s are the most productive age that we can invest in. So we feel we are wasting money on the older people. So that's why then we have to change now the coin because of these discussions, and because now we've agreed that even the menopause age starts at 34 for some, even 40, and for some even 50. And these are the same people who are very productive, and as we call them, most of us are called rich aunties. Are we here? Rich aunties, rich baby girls. So we are the people with money. So we're still doing businesses, we are still, we are the people in the companies and doing so many other things. So that's one of the things as an advocacy champion, I'll be able to also share with the relevant people. And even for the donors and the partners who are in this meeting, those who are watching online, let's change our thinking and invest in this age cohort. Because it's a continuum of care. As we all agree, from the newborn, we are covering from even our RAMCA, the name RAMCA, Reproductive, Maternal, Newborn Child, Adolescent Health. We've invested in a newborn child, we've invested in a child, we've invested in an adolescent, and now we want to invest in this age cohort. So those are some of the things we really need to agree on. And immediately we formed that committee. I want to promise you that we'll immediately start developing our guidelines, which we don't have. I've said we just have a mention on the policy, and we don't have a guideline on menopause and andropause. But for us, again, we can't leave the men behind, so we include the andropause aspect of it. Another thing we love to also do is the indicators for menopause, because we have to report. So we'll develop our M&D framework and also do some research on it so that then we have relevant indicators to report to. We are currently doing our RAMCA advocacy and communication strategy. So this is a window of opportunity to also go and include those components of menopause and andropause because it's not yet signed. So this one I want to promise you as the advocacy lead that I'm going to put it immediately. And after that, we'll, of course, wish to do a coordinated mass media campaign to inform all Kenyans in this age cohort on what they need to know, because we've seen there's a big gap in terms of getting accurate information. I know we have champions here on Facebook, like Dr. Covey, are ready. But we want standardized messages, something that we can all sing about, and so that when she's communicating about something, I can also say, this is correct. And also in our COE meetings, our TWG meetings, will include even the beauticians, the gym instructors, because now we've seen this fat here. We want to go for tummy tuck. But we see she said it's a what? A mechanism? What did you say, Dr. Kihara? It's a compensatory mechanism. So sijisumbwe na tumbo yako, please, if you are in that age. So those are some of the things we must say in our discussion. So we don't need to lie, we don't need to make money out of people.
let's just give facts on what we need to say about our messages. These indicators, I also want to say that we have to include them in our DHIS because they are not reported. And I also had a question for Millie, Honorable Millie, about these beauty procedures that are ongoing in the country. Can this be added in one of the bills that you're discussing, like the family health bill? Because it's a bit of a confusion even for us. Sometimes we say, why are they not regulated? I know it's the ministry that is supposed to do that, but we want that discussion also to come from you, able parliamentarians, because you are our advocates and your issues are taken more seriously than even us. So the ministry will continue to commit on these issues that I've talked about, but in case of anything that I missed, you can also reach out to us and we will support, because I also want to say that before this meeting, there are so many people who are concerned and want to join, but they don't know where to join. We have guidance from like Moi Referral Hospital, Dr. Mogeni, who are, they have given us even proposals, but we don't know where to start. I'm talking like this from the ministry, but I'm happy that these are started. We are so happy and we will support you in every way. And I want to say for information gap, I want to give an example. When I turned 40, I went to my gyna for my pap smear checkup. And as I was there, because I didn't want another baby. I had already had 2 babies, so I'd closed the chapter, because now I'm 40. Then he says, you know, Mary, when you turn 40, you'll either need another baby or a Ben 10. You see, those are the discussions we get from our gyna. So if you're gyna, you can't have a deep conversation with them, I don't know, you're missing so much. So me, I say, me, I'm okay. I think like a year later, I had another baby. I was pregnant. So the moment you think that now you're in your menopause, you stop your family planning contraceptives, then again you conceive. Now what am I supposed to do from there? So many people are facing different things, but we don't have a voice. We don't know where to ask. So I don't know. We open up another page for golden. You called it golden what? Golden girls and golden boys, so that we can have a chance to discuss. So I'm going to organize also at least we can start with a space. Dr. Kihara, Honorable Millie, can we agree to do it very soon? Like an space to just invite people to discuss. COV, you can organize for us. And anyone who feels like joining, there's a champion there. So that's my take. On behalf of the ministry, we're in support of this and we will support it.
Thank you so much, Mary. I will lead you straight to my commitment. I had very many nice commitments from you, and I'm really, really glad that that's coming out. Can I have someone assist in folding that? So did you hear that she's inviting us? We need to input into the RAMCA policy, the advocacy policy. She is opening her doors. Yes, she is inviting us to be part of the research process, to give data. So quite a number of opportunities, and we really appreciate. That's the conversation, that's the output. In fact, if you forget everything else, apart from sex orgasm at 114 years, please remember the things that she has committed to comply. So I want to just mention 3 things. That's a big summary. And if you've not finished writing, there are more papers at the back. So please commit, or rather, indicate in our 7 questions. You may pick each of them or only one, whichever that you fancy. Outside, we do have a booth. Our audiovisual team is still taking in short clips of what you want to pass. So very much welcome. Before I wind up, the young people, I had Gen Zs in the room, and I think we've not heard their voice. We had the millennial from this team, you're millennial, yeah? The baby girl. Now we want to hear from our Gen Z. I think there's someone from Malkia. Was it Malkia? Yeah, please come in front. Tell us what's your general view of this. You can actually conclude for us. Karibu sana. And I'm sorry your name escaped my mind, but at least I remembered Malkia.
Hi everyone. Hi Millie. So my name is not Malkia. Malkia is my friend. My name is Alvin Tina Oma. Hi Evelyn. So today I'm just happy that we're having this conversation and that the organizers of this conference, thank you very much. I think it's been a wealth of knowledge. I've been writing a lot of notes and getting a lot of ideas on how we can continue to advocate for menopause, that we have normalized conversations around menstruation. And I remember when we were having this conversation with Nelly and Evelyn, we were just storytelling. And I'm happy that those stories birthed this session, and I'm looking forward to many, many more. What I hope that this conversation leads to is that, do you all know that always ad of girls dancing and saying, stay happy always? I hope that we can have ads like that about menopause on TV. So thank you very much. And we hope that next time, it's just not me and Malkia in the room, that we have more young women, because we are gonna age. And you know us, we are Gen Zs, and we are well known for securing our future, right? Sivyo mnatujua. So we have started securing our future now by talking to you to plan for our future, so that when you get to menopause, it's tuna slide too. So please, as we secure the future, we are leaning on intergenerational knowledge and wisdom to help us slide into our menopause era with a lot of ease. And we hope that we can work collectively as seasoned women and younger women, and also have a fun time doing this, right? Tujibambe. Because the vintage baddies does not mean that you cannot have fun, sindo. So tujibambe.
Thank you so much. So we've turned our pause into applause. We are giving a brighter future to the generations that are coming behind, simply because we've started the conversations. So the conversations I have summed up into 3 in terms of way forward. And then I'll hand over to Evelyn to wrap it up for us. 1 is establishing a multi-sector menopause working group. I think we got the invite from Dr. Serem. And so the Ministry of Health is very happy to lead that. So we will plug that and follow up with him and his team. The second one is from here. That's why I kept on emphasizing, please capture your thoughts, because we are preparing a white paper or a policy brief based on today's conversations and also other spaces in which other conversations are happening. So this will help us to start, give us a baseline on where we are at. And then from there, many other things, like Prof. Olunga said, he's getting work from this conversation. But generally, let's spark a movement on data especially. And the third one is launch the Pause to Power public awareness and advocacy campaign. I think Mary has said she is ready and willing to guide us on the language, on the general communication that each of us can carry within our various spheres of influence. So, have you gotten those 3? Yes. One is a committee, another one is a policy paper or a white paper, and the third one is an advocacy campaign. Yes, please. Oh yeah. Okay. Frame it for me.
Well, I'm not very good in English, so I'll just say the law.
So we'll figure out. So we'll ask our chat GPT the law. So I think the bill that's already. Oh yes. Okay. So the law, through the actions and activities that are being championed by Honorable Millie Odhiambo, we will see and find a way of inserting this very important conversation or refining what's already in existence. Thank you so much. I'd hand over to Evelyn.
Thank you so much. When we started in the morning, we said rooms like this change norms, change culture, change policy. And I think we are getting, well, it's not close, but it's a step towards the right direction. I want to thank all of you for staying with us till the end. I want to acknowledge that all our speakers honored our invitation. And you have seen the caliber of speakers that we had today. They were the right people to start this conversation. I know, Lady Justice Njoki, you are to be here for half day, but because you found the conversation so interesting, you stayed to the end. I want to thank you. I want to specifically thank Honorable Millie. You have always honored our invitation. And there's no serious conversation without the bad girl and without Njoki. Because when you look at the history of the changes that we've made on gender, you have been there. We thank you. We appreciate that you are part of this initial conversation on an issue that is stigmatized. Thank you. I really want to thank Honorable Betty Maina, because we don't always have the private sector in such rooms. And when we invited you, you accepted. And you brought that perspective that we don't always get, especially on conversations on reproductive health, on women's issues in particular. I really take to heart what you have said. You have challenged us to amplify the conversation because employers will respond to the conversations. And we will do that. And I really want to challenge all of us because when we live here, there's a role for each one of us. We have been told that if we push and demand, insurance will act. If we push and demand, employers will act. We must go back to our institutions and demand that our institutions act. Thank you, Professor Kihara. We don't take it for granted that we have the FIGO president right here with us. Thank you to this honorable table of many professors, many doctors in the room, many advocates in the room, and I'm glad that we are also having intergenerational dialogue. I want to also really appreciate the Ministry of Health. We had the head of reproductive health program, and he made a commitment, which we will hold him to. And Mary, please, thank you for staying and pass that information to him that we are coming back. And you have seen the commitment right from this table and all of us here that we want to see action on this issue. So we expect that the ministry will hold through. Thank you to our facilitators, Dr. Mkove. When we started planning this many months ago, you have walked the journey with us, and I truly appreciate Prof. Olunga and all of the speakers. I want to also really thank the media who have given us good coverage. And we said that if we have good coverage, if we amplify the conversations, we will see action. And we are hoping that you will stay with us in this journey, Dr. Mercy and all of you. I want to thank the donors who are here. I cannot see them anymore, but they stayed until the evening and asked questions. We had the Gates Foundation, we had Co-Impact, we had Hewlett joining, and I hope many more. And I hope that you will invest in this very worthy cause. We will be following up with you. I also want to thank my board, who have stayed with me through this and who have helped in shepherding this under the leadership of Mete and Helen and Professor Sur, who also happens to double up in my board. I want to thank RHNK for partnering with us on this. I want to thank Amref University, Women's Cafe,
and also the sexual organization that have partnered with us. I want to thank all the partners, all colleagues who have made it this far. We had a huge attendance online. We had over 400 people joining us online. And we appreciate you from wherever you are joining us. Let's keep the conversation alive. I am sure I am forgetting somebody or a category of people, but please blame it on menopause or whatever it is. Brain fog. I just want to truly, truly appreciate everybody who has made it this far, the RHNK and the ICW team who have worked hard towards this. I want to appreciate and give a shout out to our IT guys who have been with us and who have kept us online, our communications people. Thank you so much. When we leave here, please let us all be champions of menopause. In our little way, please let us talk about menopause. Thank you to the women who so generously shared their stories. Please keep the candle burning. Thank you, and have a lovely evening. We will be reaching out again, and we will be having this conversation with the ministry, but also in our churches and in all the public places. Asanteni sana, and have a blessed evening. I am sure tea is served outside, so please feel free to have that before you leave.
When the symptoms of perimenopause began, she didn't have a name for it, just symptoms, just confusion about what was happening to her body. There was no nurse or doctor to explain what to expect in a language that she could understand. No one to ask and no answers given. It was just her, alone, with the body changing in ways she didn't understand. The only solution she thought of was taking traditional medicine. Across Kenya, thousands of women are walking through menopause with no guidance, no support, and no recognition. Once they are no longer of reproductive age, the health system stops seeing them. Their needs fade into the background, unseen, unspoken, unsupported.
My name is Nalaketi Leposo. I am 50 years old. I started experiencing changes in my body when I was 40. Headaches, backaches, and then one day, my periods just stopped. I was not using family planning. It just happened. I didn't know what was going on. No one had ever told me about menopause. Not a nurse, not a doctor, not even other women. I didn't ask, and I didn't go to the clinic, partly because I didn't have a husband, and partly because who would I even talk to? Up to today, I have never gone to a health facility because of menopause. I managed the symptoms the best way I knew how. With herbs, I walk into the forest and pick what I need. Other times, I buy from local herbalists. I didn't tell anyone. In our culture, you keep such things to yourself, even when you don't understand them. It's only later, when I talked to other women in the village, women my age, that I realized that they had all gone through the same thing, quietly, alone. We talk now, we share what happened, But still, it's too late because we already navigated the worst. I never had a single checkup. What I would want most is for doctors to give us information, to tell us what age menopause starts, what to expect, and what is normal. At that time, I just want someone to sit me down, explain what was going through my body. I lived through the change in silence. But maybe the next woman won't have to. When a woman has the right information, she is able to navigate through menopause with clarity, not confusion. She becomes her own compass.
Kake mikununya naapa agira aisho itu eponari keetu egira adoyio mpaka neeku meeta.